Welcome back. We will have our next speaker, Axel Bex, Professor of Urology at University College London, urologic surgeon and consultant, clinical lead at Specialist Centre of Kidney Cancer at Royal Free London. Dr. Axel couldn't join us live. We will be viewing his pre-recording presentation. Thank you.
Hello, my name is Axel Bex. I'm a urologist at University College London and working at the Royal Free London Hospital. And I'm also affiliated with the Netherlands Cancer Institute in Amsterdam. Unfortunately, I cannot be directly online today, so this presentation is pre-recorded because we have a competing meeting in London which requires my presence during this time. I will be talking about neoadjuvant therapy, current evidence, and ongoing trials. And these are my disclosures. I would like to start with this slide here. This is actually knowledge base from last year, let's say around July 2024. There may be a couple of more trials now to be found on clinicaltrials.gov. But if you compare the situation in kidney cancer with, for example, the situation in melanoma, lung, and breast cancer, as well as bladder cancer, where there are very good neoadjuvant concepts already investigated in phase 3 and have led to practice-changing situations, then we have to say this is unfortunately not the case. We have one, in the perioperative space, we have one approved adjuvant drug, that is pembrolizumab. But in the neoadjuvant setting, there's not a single trial that has led to approval or practice-changing medication. Most of these trials, and it is not a surprise that this has not changed practice, are single arm. As you can see, they're 62%. Some of them are randomized, but if they are randomized, they actually randomize against themselves. Against other experimental arms, but not the standard of care. Drugs used are very often anti-PD-1 plus a TKI, so either axitinib and lenvatinib is very common. We also have other combinations like anti-CTLA-4, but by and large, combinations are being used. The primary endpoint is, not surprisingly, possibly because it's easy, is resist response in the primary tumor, but hard oncological endpoints like disease-free survival are very few trials, only at 6%. The majority of trials investigate the length of 3 months without wanting to say that this has been sorted out. I think there's still a debate ongoing what the good length of therapy would be. And more or less shockingly, most of these trials actually have less than 40 patients included. So that's still 70%, up to 70% of the trials are dealing with smaller patient groups. And exploratory endpoints, which would be extremely important in this setting, have only been included on clinicaltrial.gov in 56% of the trials. It doesn't mean that it's not being performed in the others, but it's not disclosed what their concepts are. So this has led to a kind of disappointment within the genital-urological community that is dealing with kidney cancer. And we have met on 2 occasions. We were given an opportunity to prepare a consensus meeting in Boston during the KCRS in July in 2024, which then had a sequel meeting at the Netherlands Cancer Institute in Amsterdam for European participation in October 2024. So what we wanted to achieve is, first of all, amalgamate a group aligned to what they've done in melanoma. And we wanted to ask questions like, what is the best efficacy marker to guide adaptive treatment decisions? What would be the actual optimal drug or combination, the optimal length of neoadjuvant treatment, but also how to select the right patients. We see in adjuvant trials, for example, that a lot of patients are probably being excluded because we have this 90-day window before they would be randomized into these studies. So that was the eligibility check. And on some study logs, we've seen that up to 20% of the patients would develop small nodules in comparison to baseline and then would be excluded. So how do we select these patients when you randomize actually before surgery? Because you cannot use pathological endpoints. And can we agree on adaptive and practice-changing neoadjuvant trial designs? Now, this has fortunately led to the building of a consortium. We are calling ourselves, not unlike in melanoma, the International Kidney Cancer Consortium. And in that consensus finding, the themes in which no consensus was identified are actually exactly these questions. So we all agreed there's more work to be done, but surrounding the best trial designs, the best length, and the response markers, there's still a lot of questions ongoing. It is not that there hadn't been attempt in the past to actually produce data, practice-changing data in the neoadjuvant or perioperative setting, and PROSPER is the outstanding trial here. So the investigators should be applauded for actually setting this up. This was a study which included patients from 7 centimeters and upwards, so from CT1B up to further stages. They wouldn't require a biopsy for selection criteria, but they would require a biopsy at least to demonstrate a histological subtype of kidney cancer. They would also include other subtypes than clear cell. And at that time, when the trial was performed, the standard of care was still observation. But what we learned from this study is first of all, there was probably not the required equipoise. So while the trial was ongoing, there was this uncomfortable feeling that 4 weeks of therapy might be too long. And eventually, in order to speed up accrual, it was dropped to one single dose of nivolumab 480 milligrams prior to surgery. Now, this might have been far too short. It may have been that nivolumab monotherapy is not the right drug. You remember the Checkmate 914 adjuvant trial, where it was also negative. But the other thing we learned from it is that if you look at the recurrence-free survival curves, that approximately 11 to 12% did not undergo surgery when randomized upfront. There may be different reasons, but quite a few of these patients actually had disease progression. And this is something we should take into consideration. And for example, we were seeing in melanoma, when you have an active drug, that by virtue of just simply randomizing patients upfront before a surgery is being performed, you actually see a benefit in event-free survival in the neoadjuvant arm. Because when you start them on systemic therapy, the recurrences that would then occur in the arm of surgery after surgery and then the eligibility check for adjuvant therapy are less in the neoadjuvant arm. So these are, I think, very important theories to keep in mind. But let's not forget, PROSPER was a negative study, and currently there is no approved drug in the neoadjuvant setting. That is the status we are currently having. Now, if we look at reported phase 1 and 2 neoadjuvant trials, as already mentioned, we learned from them that 6 to 8 weeks nivolumab monotherapy is basically not leading to anything that would be remarkable. There's no resist response. There is very little pathological complete response reported. And I think the agreement in the community is now that we should actually go for combination therapies. Now, the problem then is what kind of combination therapy do you give and what length? There was a pilot where durvalumab plus tremelimumab was investigated. They had to stop because of toxicity, especially in the adjuvant arm. And so what we learned from trials ongoing is that we see some responses here, but that you will probably need a certain period of a combination therapy. And I would like to take you through in the next slides through a trial that we performed at the Netherlands Cancer Institute, not because this is the most important study or the only one performed, but because I have been the PI. I'm quite familiar with what we've done, and we learned a couple of things which I would like to share. So first of all, the study primary endpoint, there was a RECIST response in the primary tumor of at least 25%, was reported at GeoASCO in 2022. You can see that for the first time, we actually used a hybrid system of clinical TNM where we wanted to capture at least tumors of a significant growth and biopsy grade. So if they were smaller than T3 or T2B, clinical T2B, then they would require a grade 4, which is quite rare on biopsy. But all the others would then either have to demonstrate a higher grade or at least a higher T stage. And patients were subjected to therapy for 3 months, and they could segue out of the treatment at 6 weeks if an interval CT scan would actually show either primary tumor progression or systemic disease progression. Now, at ASCO 2025, we were reporting the first translational results of that study. All patients actually made it to surgery. That resulted in that we had pre-treatment biopsies, but also an nephrectomy specimen of all patients, and we also have on-treatment PBMC at baseline and at different points during treatment. And the whole translational program consists of bulk tissue and PBMC analysis. And this time we focused on description of pathological response, for which we used the International Neoadjuvant Melanoma classification, which I will explain in a minute. And we also reported Visium transcriptomics on FFPE. What is currently ongoing in the background is DNA and RNA sequencing, and especially TCR receptor bulk sequencing, in order to demonstrate whether a clonal expansion could be used as an on-treatment biomarker. So what we learned is that actually our hybrid system of selecting patients with higher risk works. You can see that the majority of patients actually are T3 and higher. We had 42.5% with clinical node positive disease. Now we all know that this is not translating in pathological node positive disease in all cases, but I would like to remind you that the mean lymph node diameter was 2.6 centimeters. So there were definitely some patients who were lymph node positive. And this is also reflected in the disease-free and overall survival. Now, the median disease-free survival in this study was 25.1 months. This is half of what has been reported in the placebo arm of Keynote 564, which is roughly 5 years at the latest update, which was also presented at ASCO 2025. Now, you might critically say this is probably because axitinib and avelumab doesn't work as good as pembrolizumab, but that would be a bit short-sighted. I think what it demonstrates is that if you select patients based on clinical TMM and biopsy grades, you actually keep those rapid disease progressing patients in your trial. As I said already, most adjuvant trials actually had a selection period of 90 days. They needed to rescan, and up to 15 and 20% of patients in some of these trial logs were demonstrating new lesions in comparison to baseline. So those patients who are probably really in need of some sort of systemic therapy are not in our adjuvant trials. 8 patients died in this study. 1 died unrelated from metastatic lung cancer. Now, what we subsequently did, we looked at RECIST, response, and survival. And I would like to remind you again, this was a 40-patient trial, so we shouldn't expect extreme differences which are statistically significant. But the signal of the hazard ratio is at least interesting. The curves seem to separate. And most importantly, having a radiological response is prognostic, because none of those patients have died of disease in that study. We subsequently looked at pathologic response and its association with radiological response. It may not come as a surprise because it has also been reported in other tumor types that there was no association. But just to remind you, we used the INMC classification, which is admittedly not approved for kidney cancer, but we thought we need to start somewhere. So 3 patients had a near complete major pathologic response, which is defined as less than 10% viable tumor. The majority had more than 50% of viable tumor cells, which would translate into no pathological response on these large primary tumors. And when you look at how that looks under the microscope, this is an example of someone who had a pathologic near complete response. You can see collocation necrosis. We use a very thorough program in which the tumors are sliced in 1 centimeter thicknesses, which is then blocked, and we take the surface slides to then assess the amount of necrosis. Again, when you look at pathologic response, similar to the RECIST response, patients having some form of pathologic response, so either major or partial, This is prognostic. Um, Patients who died of disease were in the group who had no pathological response. Now, is this something that we should use in the future? That's debatable, but again, you see that there's discrimination. And when you have discrimination, then you have a good starting point to investigate translational endpoints. And that's what we did. We looked at 18 patients with divergent pathological response and DFS and subjected their tissue to Visium transcriptomics. For those of you who are not familiar with it, it's important to realize that each spot on those slides, on those barcoded slides, captures the entire mRNA transcriptome of 10 to 15 cells. So it's important to realize that while most of these cells may be of a certain type, it's still a mini bulk sequencing and not a single cell sequencing technique. This is important to understand this slide because the next thing you do is a spot cluster analysis. We identified 19 spot clusters, but again, those UMAPs are probably more familiar to you from single cell sequencing. But here we have certain predominance of cell types. They're not exclusive, but we have, for example, clusters 1 to 18, which are more predominant tumor. Then we have immune predominant clusters and necrosis clusters. And then you do a annotation. We used here cell2 location scores for the immune cell repertoire. And that can then be used to do, as I will show in this slide here, the spatial co-localization analysis. Now, let's take a little bit of a minute to understand that slide. So what it shows you is here on the left, the patients with their pathologic responses. The Bordeaux red is no pathological response, and the green is major pathological response. Then this is plotted against what happens clinically. So the red ones had a fast recurrence, so less than 6 months. The orange was a late recurrence, so more than a year, and green had no recurrence. And what we could demonstrate is at least the signals that in patients who had major pathological response, there were only very few. There's one who behaves slightly different, but there was a spatial co-localization of tumor cells with tissue-resident macrophages, CD8 positive cytotoxic T cells, memory T cells, and B cells. And two of them hadn't had a recurrence yet. And on the other side of the spectrum, in tumors with no pathologic response and rapid disease recurrence, you basically see an almost absence of this co-localization. And with multiplex immune histochemistry, we found that, for example, CD8 positive, CD39 positive tumor reactive T cells are co-located in the tumor cell compartment. And when there was an above the median density, then these patients had an association with prolonged DFS in comparison to those who had lower CD8 densities. And I think these are things you can take further into investigation. So where do we go from here? This is a schema which I think is a nice model and has been tested, for example, in other tumor types in melanoma. So at the bottom, you see what is currently standard. You do surgery, then you do an investigation of your primary tumor. You assess the risk, and then patients are subjected to 52 weeks or a year of adjuvant pembrolizumab. We have KIM-1 potentially coming up as a predictive biomarker. It needs further investigation. But other than that, it's still very difficult to assess the right patients here. Maybe with our AI technology in the future, but we are not at that point yet. So on the contrary, patients who are exposed to neoadjuvant therapy, we could use their primary tumors to then assess how to deal with them further. So we can actually individualize therapy, we could de-escalate it, and this needs to be investigated in trials. For example, you could use pathological response criteria, possibly also in combination with T cell repertoires that are easily identifiable with immune histochemistry to decide about de-escalation in those who had complete or near complete pathological responses, and maybe also de-escalation in those who had no responses, because why would you expose them to continued immune therapy if there was no effect on the primary tumor at all? Now, this would require at least an agreement in how we assess pathological response. I'm happy to inform you that we have work in Lancet Oncology in press of a consensus that we found together with US and European pathologists how these specimens should be worked up so that we come to a standardized reporting we will be using incremental steps of 10%, but for the time being, we will use the same cutoffs as in the International Melanoma Classification. But it may be that the future, when we link these pathological responses to trials, we will learn that other cutoffs are more important in kidney cancer. This is interesting because we will get more information from this trial, which is currently ongoing at the Netherlands Cancer Institute, and of which the results will be reported at this year's ESMO in Berlin in October. This was a study that randomized up to 14 patients per arm to either nivolumab monotherapy, 6 weeks, neoadjuvant, nivolumab ipilimumab for 6 weeks, or nivo-relatlimab, which is a LAG-3 inhibitor. Primary endpoint was pathological response, and if there were at least 2 or more of those pathological responses, patients would go into the second stage. Now, we will present the results of these of this study of the first stages. I truly believe this will be interesting, so I would like to draw your attention to it. But this will be very informative to then design further trials. Ultimately, if we do not start to randomize, we will probably never change practice. And I'm happy that at least a phase 2 randomized trial is currently in the startup phase in Spain and in the United Kingdom. It's run by Christina Suarez and Tom Pauls. It's MSD supported, so therefore it will be investigating pembrolizumab plus lenvatinib plus belzutifan, so a triple combination for 12 weeks, followed by pembrolizumab adjuvant versus pembro plus belzutifan only, followed by pembrolizumab. And it will also randomize against the standard of care, which is 1 year of adjuvant pembrolizumab. The primary endpoint is overall response rate in the primary tumor between the 2 neoadjuvant arms, but it is an interesting design. So the third arm is used to deliver for the first time exploratory endpoints on overall survival, event-free survival, what we discussed. So how many patients will actually progress when you randomize them upfront. And there are other proposals. This is not exclusive. There are more trials ongoing. But this is a proposal from the Netherlands where we believe that maybe a shorter period of neoadjuvant therapy can already make a huge difference for patients. We will then also investigate event-free survival in comparison to pembrolizumab for a year. But obviously, we will also have the secondary endpoints, including translational endpoints. So with this, I would like to conclude. I do know that you will have a discussion afterwards in which I unfortunately cannot take part, but this is my personal opinion so far, what I have really learned. I do believe that if it comes to best efficacy markers, to guide adaptive treatment decisions, so not the standard oncological endpoints, but really to guide us in escalation or de-escalation, then it is likely a combination of clinical pathological response plus a TIL signature. The optimal drug or combination will very likely be a combination of anti-PD-L1 with either a TKI or anti-CTLA-4. Probably something in between 6 to 12 weeks is required. And I would like to challenge you to think about that it's probably the initiation of the process that leads to clinical pathological response, which is more important than the proof of it in the long term. So in other words, if we have a biomarker that would allow us to define these patients early on, like for example, a clonal burst in the peripheral blood, then this would help immensely. Patients should be selected by clinical TNM plus biopsy grade. I also believe we will find consensus here. And I would say there's a careful yes that we can go with adaptive and practice-changing neoadjuvant trial designs. With this, I would like to thank you for your attention, and I hope you have a very fruitful discussion. Thank you.
Thank you so much for a wonderful presentation. And we will move to our next speaker, Ali Hakimi from USA, Associate Professor and Urologic Surgeon at Memorial Sloan Kettering Cancer Center. Dr. Hakimi couldn't join us live. We will be viewing his per-recording presentation. Thank you.
Hi, my name is Ari Hakimi, and I'm here to present on um, prognostic models in localized RCC. I'm a associate professor of urology surgery at Sloan Kettering. I also run the kidney cancer translational research program, and I have a lab of cancers. I'm happy to share my thoughts today on prognostic models. No disclosures. So I'm going to start off with several different historical models that have been used, talk about some of the current ones, and some of the more contemporary genomic models, although none of these are ready for prime time. So the most notable one is starts with the UISS model, the UCLA Integrated Staging System model. This was developed in the early to mid 2000s that incorporates TNM stage from integrated performance status to stratify postoperative RCC risk, including ECOG and nuclear grade. The reported performance is it was C index of 0.55 for recurrence. This was used in the HREC cohort, and it was inferior to other ones at the time. This brings us to the SI model from the Mayo Clinic. This stands for stage, size, grade, and necrosis. It was developed for clear cell RCC specifically and widely used in clinics and trials over 20 years ago. This pathologic T stage, tumor size, lymph nodes, nuclear grade, and tumor necrosis. This was validated with the C index of reportedly of 0.82, which is quite impressive. However, in prospective validation, which I'll talk about in a minute, in the ASSURE adjuvant trial, it was only 0.688, which is lower than it would have been reported in the series, single center series at the Mayo Clinic. Here at MSK, we had developed a nomogram in 2001 called the Python postoperative nomogram. This was a 5-year recurrence-free survival probability, used histologic subtype, symptom status, presentation, T stage, and tumor size. This had a reported C index of 0.67, and this was validated in a French cohort, but this is thought to be relatively inferior to the other models and is not currently utilized by most folks. An important paper that came out of Fox Chase, published in the JCO about 6 years ago, tested several of these models and a few other models to look for how they performed in a more prospectively maintained database from the ASSURE trial. This was an adjuvant trial comparing sunitinib to placebo. And obviously all patients in this trial were deemed to be even more intermediate to high risk. And as you can see, the performance status was lower than expected for several of these models. And I think that speaks to some of the limitations of how models are developed. Often, even if they have a training validation set, they're often developed in a single center experience. And often there's a mix of early, intermediate, and high risk. So they can be diluted in terms of their events, and that models, when they're put into a more meticulously maintained database from a trial, can underperform. So that led to the advent of the ASSURE nomogram, which was based on this clinical trial data. It was derived from the adjuvant trial to predict DFS and OS post-nephrectomy. It uses clinical pathologic features available at surgery, including T-stage node status grade, necrosis, sarcomatoid features, margins, etc. Reported performance internally of 0.68 for DFS and 0.69 for OS. There was external validation also that reported 0.63. So reasonably improved, but not overly impressive. It's still probably the best current nomogram out there. And you get features like some of these things. This is one of the examples of what you get from the ASSURE nomogram. And by the way, I heartily encourage folks to look at this website, cancernomograms.com, which is maintained at Fox Chase Cancer. They have all, at least from a urologic standpoint, have all the GMEDOC standpoint, they have a lot of the nomograms that are utilized across the different diseases in GU. And you get these types of probabilities, but also probability of early disease progression. So here's an overall comparison of the models that I talked about. The UISS, lead SI, which are closely related from the Mayo Clinic. They've been utilized. Again, I would say the ones that are most commonly used in the literature include the S-sign and the Assure nomograms now, but they all still have limitations, which brings us to the current ones that utilize some of the genomic biomarkers. So some of the ones that have been utilized in prognostic biomarkers, and obviously there have been a myriad of papers that have come out, especially from things like the TCGA, but I'm going to highlight sort of the more robust biomarkers, ones that have been used by many. So one of the first attempts was looking at truncal mutations in common tumor suppressors in RCC. That includes BAP1 and PVRM1. In this case, BAP1 is thought to be mutated around 10 to 15%, and PVRM1 around 40 to 50% of the time. BAP1 is thought to be a poor prognosis, PVRM1 thought to be more favorable. And this has been looked at both from a mutation standpoint, also loss of protein expression by IHC. And the agencies typically not been performing these studies, but they have looked at hazard ratios, showing that patients that are BAP1 mutated often have a hazard ratio of over 3 for events, including DFS and OS, and then having a double negative shows the worst outcomes. Those are rare to see. So our group had showed this back in 2014 or so, where we demonstrated the first time that BAP1 mutations were associated with worse outcomes. This is also shown by James Bergolis' group in UT Southwestern in a similar paper from Renal Oncology, demonstrating BAP1 mutations being associated with worse outcomes. And then the same group subsequently used immunohistochemistry with a large consortium and demonstrated very good prognostic capabilities using BAP1 mutations. However, we tried then to integrate a lot of these features in some of the models. We used the SI model here to see what additional values it got. And you can see BAP1 mutations, although it's quite prognostic in those earlier treatments. I showed you when you adjust for things like tumor grade and other features from the tumor using the SI model, for example, you can see that some of this will wipe away. In this particular analysis of about 1,000 patients, we demonstrated that BAP1 lost its value, although it still trended, but it was not significant. Well, the p53 mutations seem to be independently associated with worse outcomes, but those are much less common, about 3 to 5%. So, take that with what you will. We did see some signals again, but when you add these prognostic models that we know, a lot of these signals get washed away. So the other attempts have been RNA-based biomarkers. This includes a CCA-CCB marker from Kim Rathmell's group. Initially, this was described using microarray data. We identified two subgroups, CCA and CCB. This was a large whole transcriptome microarray data set. Then they refined that down to 34 declared genes. They used nanostring and RT-PCR. We helped validate this in a collaborative effort, demonstrating better outcomes for CCA, worse outcomes for CCB. This one, they showed in their paper that it did outperform S-sign and UISS. But again, the AHCs are modest in this, 0.64. Others that I've seen validated have been cell cycle progression score. This is a sort of tumor agnostic score. It doesn't really take into account RCC specific biology, more looks at like cell proliferation markers and others. But essentially, this was 31 cell cycle genes combined with clinical nomogram. They reported very high CNX of 0.87 and associated with recurrence and disease-specific mortality. This was validated in the consortium with MGH as well. Finally, I wanted to mention some work that we had done utilizing another clinical trial. This was the adjuvant trial from the PROTECT trial, led by Bob Motzer and others, demonstrating the benefit of, no benefit of pazopanib. However, we had the placebo arm of this trial, again, all high-risk patients, clear cell with T2 or T3 clinical stage, so again, all high-risk patients. In this analysis, we compare the patients that recurred versus not. This is work led by senior member of my lab, Lynn Vuong, and one of our former fellows, Phil Rapolt. So initially, we sort of compare the recurrence patients and non-recurrence patients, identifying things that you would expect, such as EMT features, but we also found certain immune-related responses, and in particular, we identified a signature, what we call the MSK inflammatory signature. This picked up multiple genes associated with myeloid signaling, and this seemed to be highly associated with tumor recurrence. Again, all high-risk patients. And what we found was that if you were in this category, and really good stratified by quartile for this is the expression of that myeloid with MSK inflammatory signature, you can see how beautifully stratifies patients by recurrences. We validated this in TCGA and in a cohort from Moffitt. And again, this seemed to be very important for predicting response or recurrence. Angiogenics, this was the opposite. So if tumors were more angiogenic, they tend to do better. Again, similar quartiles, not quite as robust validation in the TCGA, but nearly validated in the Moffitt cohort. So not quite as robust, but clearly showing the microenvironment may substratify patients into higher low risk by recurrence patterns. And here we incorporated the inflammatory signature along with other features like clear code and the UISS scores. And you can see that there was independent value in adding the inflammatory signature. So potentially also improving the ADCs above 0.7. So does suggest that there may be some value in including these microenvironmental features. Importantly, these are thought to now be associated with specific response therapy. So as we kind of move into the adjuvant world in RCC more commonly now, and who to select to give, but also what types of drugs to give, these scores may end up helping inform that as much as anything else. So thank you for your time and attention. Happy to participate in the panel discussion afterwards.
Thank you so much, Dr. Hakimi, for a wonderful presentation. So we will move to our next speaker, Vincent Hsu, Assistant Professor of Medicine at the Harvard Medical School, Medical Oncologist at the Dana-Farber Cancer Institute. Thank you for joining us. The floor is yours. We will share your screen.
Hello, thank you for this invitation to speak on the management of post-surgical recurrence. My name is Vincent Hsu from Dana-Farber Cancer Institute. These are my disclosures. Today, we will discuss these following topics. First, we'll start with the patterns of recurrence after RCC surgery. Then we will discuss how to detect recurrence. We will discuss the management of recurrences should they occur locally. And then finally, we will discuss systemic recurrence. Recurrence is unfortunately a common problem among patients with kidney cancer. In patients who enrolled in the Keynote 564 trial, which led to approval of adjuvant pembrolizumab, as you can see, about 52% of patients were cured with surgery alone, and about 8% of patients who received surgery were additionally cured with adjuvant pembrolizumab. But if you look at the top part of this Kaplan-Meier curve, there's really about 40% of patients who ultimately recur if they have intermediate to high risk or high risk RCC, even if they received 1 year of adjuvant immunotherapy. And so there certainly is an unmet clinical need for managing recurrence among patients who are not cured by surgery alone. So how do we detect people who recur? Currently, it is standard of care for patients after surgery to receive imaging surveillance, and most recurrences are found with routine imaging, which in 2025 for RCC consists of CT scans and MRIs. Now, there is an emerging role for other biomarkers, including minimally invasive biomarkers and blood-based biomarkers, and that is hopefully coming around the corner. So here are, I'm sorry, the slides are unsynced. Okay, I think these are the previously loaded slides, that's fine. So among imaging biomarkers, there is an emerging role potentially for carbonic anhydrase 9 based biomarkers. This includes girentuximab PET. This was based off the ZIRCON trial, which was a trial that was presented at GU ASCO and shows a potential role for this novel PET tracer, girentuximab PET detecting CA9, which can differentiate between patients with benign renal masses versus those with clear cell RCC. And there's some emerging data that the same PET tracer may be useful for detecting also metastatic disease. There are also blood-based biomarkers as well. In many other cancer types, ctDNA has proven useful as a minimally invasive way to detect cancer. The data in renal cell carcinoma is a little bit more mixed. And what we see is that in patients who are post-resection, if ctDNA is detectable in the blood, this does correlate with a significantly higher chance of recurrence of cancer. However, the issue is that many patients who do recur do not have detectable ctDNA. And so this biomarker is relatively specific, but relatively non-sensitive for kidney cancer recurrence. One of the benefits of this assay is that because of its use in lung cancer and other cancer types, commercial ctDNA assays are pretty widely available. And so, while these are available, I would caution folks that just because the ctDNA assay is not present or negative doesn't mean the patient definitely will not recur. And so, that leads to the question of, can we improve sensitivity of blood-based detection? One of the ways that we might increase sensitivity of blood-based assays is by looking at signals beyond DNA mutations. Clear cell kidney cancer among cancer types has a relatively low mutation burden. And so we can amplify this signal by looking for epigenetic signals, for example, with cell-free methylated dipseq. And what we've seen is that cell-free methylated dipseq can detect methylation signals that have a greater number of changes compared to just tumor mutations alone. And this does increase sensitivity somewhat. In this prior paper from Nature Medicine, the authors were able to show that cell-free methylated dipseq was able to identify with pretty high sensitivity patients with metastatic renal cell carcinoma, although the sensitivity was still a bit lower in patients with localized disease. And ultimately, even though this is a more sensitive test, the detection is still dependent on the presence of circulating tumor DNA. And circulating tumor DNA, we know, is shed much less, or sometimes not in detectable levels at all among localized tumors. There is another circulating assay called KIM1, which is a tumor-derived protein. And this assay has quite good evidence now in several trials as a minimal residual disease biomarker in kidney cancer. KIM1 is a transmembrane protein, so it is upregulated in cancers that transform from the cell of origin in the proximal tubular epithelium. The benefit of KIM1 is that it's really present at very low levels among patients who are healthy without cancer. And even in patients with renal injury, KIM1 is elevated in the plasma and serum, but not to the same extent. It's much higher elevated in patients with kidney cancer. And so the question has been raised of whether looking in the blood for residual KIM1 after kidney surgery can be an indicator of impending recurrence or residual disease. And indeed, in several adjuvant trials, including ASSURE, CheckMate 914 Part A and Part B, and IMMotion 10, we've seen that elevated KIM1 after nephrectomy is associated with risk of kidney recurrence and death. And I think what's equally interesting is that KIM1 seems to be useful as a potentially dynamic biomarker looking for recurrence. And so on the adjuvant IMMotion 10 trial, plasma was tested at baseline and at cycle 4, day 1, after 3 cycles of atezolizumab versus placebo, and again tested at time of study discontinuation. What we see is that in patients who had an increase of circulating KIM1 from baseline to cycle 4 day 1, these were patients who had very high chance of subsequent recurrence. And recurrence risk was especially high in patients who had high baseline KIM-1, and the KIM-1 continued to go up during treatment. The median recurrence-free survival, or disease-free survival, in that subset of patients was only a little bit over 4 months. So these are patients who recurred extremely quickly. Whereas if you look at the opposite end of the spectrum, patients who started out with low KIM-1 and the KIM-1 didn't go up between baseline to cycle 4 day 1, these patients had great outcomes, and the median disease-free survival was not reached in that population. Looking at a similar question in a slightly different way, when you compare the baseline blood to blood collected at time of study discontinuation, if you look at patients who discontinued study because of disease recurrence, in most of those patients, nearly all, KIM-1 was higher at time of recurrence compared to the baseline KIM-1. Conversely, patients who discontinued trial for other reasons, toxicity or any other reason, they generally did not have higher KIM-1 at time of discontinuation. Again, showing that blood-based KIM-1 often goes up before recurrence is radiographically detectable. And what happens then when patients do recur? If patients have relatively indolent disease and/or patients are asymptomatic, could there be a role for active surveillance in the metastatic setting? And indeed, it appears that there is. In both prospective and retrospective studies, and again, these are patients who are carefully selected by their oncologists to be people that, in the oncologist's opinion, are good candidates for active surveillance. In these patients, the outcomes are generally excellent. And among all these published studies of patients with metastatic RCC undergoing active surveillance, the median overall survival tends to exceed 4 to 5 years and is often much longer. And indeed, in prospective phase 2 study, the median time for needing systemic therapy was about 15 months. How do patients recur? Well, after nephrectomy, many patients may occur in an oligometastatic or localized setting with only 1 or 2 or 3 sites of disease. Conversely, many patients occur in a multifocal way with lots of metastases in lymph nodes, lung, bone, or other areas. And as we'll discuss, the management strategies can differ depending on the pattern of recurrence and even the pace of recurrence. And patients who have oligometastatic recurrence might be better candidates for metastasis-directed therapies, which might even be curative in some situations, whereas patients with widely metastatic disease will generally need systemic therapy. What happens in clinical practice after recurrence? We have a good hint of what happens in the general population based on results from long-term follow-up of KEYNOTE-564, the adjuvant pembrolizumab trial. On this trial, approximately 45% of patients received systemic therapy after recurrence on either pembrolizumab or placebo arms, and about 20 to 25% of patients received systemic therapy in combination with a local therapy that could have been surgery or radiation. Approximately 15 to 20% of patients did not get systemic therapy and only got local therapy with surgery or radiation. So these were likely patients who had oligometastatic recurrence. And finally, about 15 to 20% of patients didn't need any further treatment at all, despite recurrence. And these might have been patients who are good candidates for active surveillance, for example, with indolent metastases. We do have some data that metastasis-directed therapy can be useful. There was a very recent paper published within the last month by Dr. Chad Tang and colleagues showing results from a single-center phase 2 trial. In this trial, among 121 patients, serial metastasis-directed therapy was effective at delaying the need for systemic therapy, with a median progression-free survival of about 18 months and a median systemic treatment-free survival of about 34 months. Notably, the 40% of patients who had undetectable ctDNA at baseline did even better with longer time to systemic therapy, the requirement for systemic therapy. This actually reflects, remember, all these patients are metastatic. So the fact that 40% of patients had undetectable ctDNA despite being metastatic does also, in a different way, reflect the relatively low sensitivity of ctDNA. But it does show that ctDNA is prognostic in the metastatic setting. And for further details on this trial, please do look at the talk from Dr. Chad Tang for this meeting. Next, let's look at first-line systemic therapy. So in patients who are not candidates for surveillance and not candidates for metastasis-directed therapy, what should they receive in terms of medications? Here is a slide that has been shown many times before. These are the first-line systemic therapies in RCC, assuming patients have not received prior immunotherapy. Most patients who are immunotherapy naive and require medication for systemic therapy should receive an immunotherapy PD-1 based doublet. And this could be nivolumab plus ipilimumab, or it could be cabo-nivo, or len-pembro, or axi-pembro. Next slide. Among the IO-IO versus IO-TKI options, patients who prioritize the possibility of a durable response, prioritize treatment-free survival, may want to get combination immunotherapy, especially since if patients have a good response, many of these patients can pause treatment and have a prolonged treatment-free interval. However, these combination regimens with ipi-nivo have a higher chance of immune toxicity. Conversely, all the IO-TKI regimens have a higher objective response rate and better and faster upfront symptom control. And so I would prioritize these for patients who have rapidly progressive disease or are already starting to have symptoms from their disease that are significant. There's a relatively low rate of upfront progression of disease based on these regimens, as low as 5% or so. But this comes at the cost of being on really indefinite VEGF receptor TKI therapy with chronic TKI toxicities. But what about patients who have progression either during or immediately after adjuvant immunotherapy? Adjuvant pembrolizumab is currently the only approved adjuvant immunotherapy in renal cell carcinoma. And if patients have rapid progression during or after treatment, should these patients receive an immunotherapy combination, or should these patients receive VEGF receptor TKI on its own? Well, these questions were not answered directly, but we have some pretty good indirect data from two randomized trials. The first trial is CONTACT-03, which randomized patients to cabozantinib versus cabozantinib in combination with atezolizumab, the PD-L1 inhibitor, among patients with metastatic disease who had progression during or after prior ICI treatment. So these were not adjuvant immunotherapy patients. However, these are patients who are previously exposed to immunotherapy. And as you can see on these slides, there was really no improvement at all in progression-free survival or overall survival from the addition of atezolizumab. And there was some increase in immune toxicity. Similarly, the TiNivo-2 study looked at the addition of nivolumab to tivozanib in patients who had previously received immunotherapy for kidney cancer. And this trial did include some patients who had received adjuvant therapy. 14% of patients on TiNivo-2 had received adjuvant therapy and subsequently had progression. So that's a minority of the study population, but there were some. And as you can see here, again, the progression-free survival and overall survival were not different between arms. This shows that patients should not be routinely rechallenged with immunotherapy after prior PD-1 failure. So in summary, how do we approach recurrent renal cell carcinoma after surgery? I would first ask, is the recurrence localized or oligometastatic? If so, I would strongly consider patients for surgery or radiation or any number of potential local therapies to render the patient cancer-free. And indeed, there is some chance of prolonged treatment-free survival or even cure with oligometastatic directed therapies. By contrast, if the patient has indolent disease and is asymptomatic, some of these patients may be good candidates for surveillance. If patients do require systemic therapy, we consider whether the patient has had immunotherapy in the recent past with adjuvant pembrolizumab. The 12-month cutoff is somewhat arbitrary, but is a number that the field has a little bit converged on, although clinical trials to determine the optimal time duration from prior immunotherapy exposure really are lacking at this point. Patients who received recent immunotherapy should mostly receive TKI-based therapies. That could include cabozantinib or tivozanib based on the CONTACT-3 anti-NIVO2 data, or lenvatinib and everolimus or axitinib, which are standard subsequent line therapies in RCC. Patients who are immunotherapy naive should strongly consider an immunotherapy-based systemic regimen, including any of the first-line immunotherapy PD-1-based doublets. Conversely, there are carefully selected patients who might still be candidates for single-agent TKI. This includes patients who have a contraindication to immunotherapy, or patients who have really favorable risk disease and biologically tumors that appear very angiogenically driven, potentially, requiring systemic therapy, progressing slowly with angiogenic phenotype. Finally, what are the future directions for treatment of recurrent RCC? As you've heard from some of our prior speakers, one active area of investigation is doing better for preventing recurrence. This could include neoadjuvant therapies, as Dr. Becks just discussed, or it could include novel adjuvant therapies, some of which are under investigation, including ongoing trials with addition of HIF2 inhibitors or vaccines, or the STRIKE trial, which is adding 6 months of tivozanib in the adjuvant setting. Or can minimally invasive biomarkers help guide our management? Biomarkers might help with early identification of recurrence, with selection of patients for active surveillance or metastasis-directed therapies, or for management of systemic therapies. Finally, further advances in local and systemic therapies will continue to change the paradigms of care. And a lot of this new exciting data is being shared today and during this meeting. Thank you very much for your attention.
Thank you so much for a wonderful presentation. So now we would move to our panel discussion, moderating with our chair, Rana McKay. So please.
Overview on management of localized disease from a surgical aspect, preoperative risk assessment, and then thinking about what to do post-op and subsequent to that. So maybe we can kind of walk through a case and get all of you all's pearls on how to assess, how to manage in the modern era. I think we see a lot of these patients who present with hematuria. They get some imaging and they have initially very large renal mass, and sort of what's the first decision tree to think about, what's the standard approach, and what do you think are evolving? I know we don't have Axel Becks to talk about the neoadjuvant strategies, and we'll walk our way through this case as the person progresses. But what's your initial approach? Maybe Dr. Zhu, if you want to start as a surgical oncologist, just book them for the OR. What else do you do?
Okay. I don't have my photo on. Okay. So yes, when we're meeting with such huge mass cases, as I showed you in my lecture today, we usually try first to assess the patient is fit for the surgery or not. If it is fit for the surgery, as I said, we use in the holographic imaging really helping us to assess the patient. If they are feasible to be operated, we will do the surgery directly. Otherwise, we can think about the new adjuvant treatment. But however, so far it is not a standardized option for this kind of patients. So maybe still, the thinking, the surgery is the first option from a surgeon point of view, and also with help of the robotic surgery, more cases becoming feasible. Surely, because if this patient with metastasis, we need to think about put this patient on the medical treatment rather than go for surgery directly. This so far the practice in China, and also there are lots of clinical trials ongoing, as Dr. Xu and other speakers today. So yeah, we this is so far the current status in our practice. Yeah.
Maybe for Vincent, I know you've done a lot of work in this space. We've certainly heard a lot about postoperative risk stratification. What do we do for risk stratification in the preoperative setting? Brad, feel free to touch on this too. And is there a role for pre-op KIM-1 or pre-op biomarkers?
That's a great question. And I think this will be increasingly important as we have adjuvant trials and also neoadjuvant trials opening. We do have data that, at least for KIM-1, preoperative KIM-1 is strongly prognostic. And we have this from two cohorts, from a cohort from the Johns Hopkins Biorepository, as well as an international cohort with a trial that was led by the WHO and enrolled mostly patients from Moscow, actually. This was a DoD-based collaboration with Moscow, kind of before the geopolitics went everywhere. And in these cohorts, patients who had higher KIM-1 before nephrectomy had significantly higher chance of metastasis and death after nephrectomy. And I would argue that, that there's some signal that perhaps these patients may be the highest risk patients that could undergo intensify therapy with neoadjuvant, for example. And so, what else is out there? Well, potentially some of these novel imaging biomarkers with girentuximab PET, for example, may help to risk stratify, perhaps in the way analogous to what we've seen in prostate cancer. If we do have better imaging, there might be early tiny metastases that could be detected with more sensitive imaging. I think that remains to be seen.
Yeah. Thank you. And Brad, what if this patient had a huge mass, 15 centimeters, IVC thrombus, some adenopathy? They were like borderline resectable. How would you approach them? I think sometimes we see these patients and you're kind of scratching your head if they could be resected. We just lost our surgeon, so.
Yeah, I think that was the key question, right? So, we always engage and have multidisciplinary discussion with our surgeons to see, is this something that's surgically resectable? And we're fortunate to have very fantastic surgeons that can sometimes take these challenging cases and not. But if it truly is a situation where, it's not resectable now, but if you were to shrink it, you can get to a resection. What I really do think about Nivo-IPI frontline for my metastatic renal cell patients, this is a situation where I go to IO-TKI because I think that the PDS best response is much lower. The objective responses are much higher. And I think we have data from Axel that, IO-TKI is certainly safe in the neoadjuvant setting. We have data from Surtime that, TKIs can be stopped as early as 24 hours before surgery and patients do quite well. So this is a situation where we will think about an IO-TKI approach upfront to try to shrink the tumor. And I think to that point, I do think that, we're making progress in kidney cancer. And we know in melanoma that, perioperative immunotherapy seems to be better than purely adjuvant. So we haven't answered that question. I think Prosper was a fantastic trial, but it looked at one dose of nivolumab. Some patients had surgery within 2 weeks. So I don't know if we really definitively answered that question. And I think as we think about perioperative trials, I don't know that path CR rate in the kidney is really what we need to care about, because our hope is that there's immunomodulatory effects beyond the kidney. And so, that may not be the best surrogate for like long-term benefits as we think about what is the benefit of perioperative immunotherapy.
Thank you for sharing that. Yeah, I agree with you. I think that we all kind of adopt that strategy. So this patient ended up undergoing resection. He was found to have a T3 tumor with renal vein invasion. It was grade 3. No nodes were sampled at the time. There was no nodes that were actually seen on his clinical imaging. And now he's post-op. He's recovering well. How do you all approach? Maybe Vincent, we can go to you next. What's your approach after surgery?
Yeah, so it sounds like, Rana, this patient is a T3A based on renal vein invasion, right? Which means they would be eligible for some of these adjuvant trials. Although, T3A is certainly a relatively on the good side of patients who would have been eligible, for example, for KEYNOTE-564. So I think, if the patient is not a trial candidate, I think adjuvant pembrolizumab, if they're clear cell, is reasonable. Knowing that in KEYNOTE-564, if you look at the forest plots, patients with intermediate to high risk versus high risks seem to still have benefit from adjuvant pembrolizumab, even though the absolute benefit might be a bit lower if they have lower absolute risk of recurrence. And of course, this is a conversation needs to be balanced with toxicity, et cetera. But if the patient is a trial candidate, I would really strongly consider trials, including, for example, the STRIKE trial currently led by Dr. McGregor.
Thank you. Brad, anything else to add? Dr. Zhu, this patient ended up undergoing surgery without any preoperative treatment, had a T3 tumor with renal vein invasion, no nodes, grade 3, and we're talking about what to do for the patient now. Yeah.
Yeah,
Brad,
100%. I think this is a patient that we should be discussing the role of adjuvant therapy, right? And I think, at the end of the day, there's a lot of discussions about KEYNOTE-564 and people say, oh, I don't believe the data, but this is a positive trial. And so we should just share the data with our patients. And so with the T3 grade 3, that is sort of like the heart of that was the majority of the patients that were in that trial. And so absolutely, I use the Assure nomogram to sort of get an idea about the risk at 3 years. I applied the hazard ratio of 0.68 to get an idea of the absolute risk benefit. And as Vincent said, if anyone is thinking about adjuvant pembrolizumab in the US, for sure, I think that STRIKE is an excellent option using the well-tolerated TKI tivozanib with pembro versus pembro alone to see if we can, enhance the responses. So as you look at these trials, I think there's 2 different ways to think about it. You can say, oh, we're over-treating patients, or you can say, hey, there's a population that's relapsing despite that. And so with STRIKE, we're looking, what can we do for those patients that are, despite pembro, are still relapsing? Can we improve those outcomes even further? And again, thinking about quality of life safety as a key aspect of advertising, that's where we chose to use tivozanib.
Wonderful. Thank you for that. I know we don't have too much more time in the discussion. We encounter this a lot. Post-operatively, you get imaging on them, and they've got small sub-centimeter pulmonary nodules. You don't have an old scan to know what the heck is the status of these nodules. How do you approach somebody? I know this is a clinical conundrum that we encounter all the time, because if they're M1, you may treat them differently. You may offer them metastatectomy, whereas if they truly are NED. So maybe Dr. Zhu, how do you approach that when you see somebody post-op, small lung nodules? They're all, less than a centimeter. Maybe they've got three or 4 of them, sub-centimeter. What do? Do you jump right into adjuvant and send to your medical oncologist, or do you repeat another scan? Do you send them to CT surgery? What's your strategy?
As a urological surgeon, we usually, collaborate with our oncologist, and also usually very often we hold the MDT for this kind of patient. So we discussed with the experts. They contribute their opinions about the treatment and follow-up protocol suggestions, and then we discuss with the patient. For this kind of patients, usually we will, refer the patients to our oncologist. They will most often, if there's metastasis, according to the guidelines, we usually suggest adjuvant treatment. Most often we use the pembro plus axitinib. As I showed in my cases, the patient responds so far very well. Surely, I would encourage our patients go to the clinical trials. But, most often this kind of patients being handled by our oncologist rather than the surgeon. Yeah.
Thank you for that. All right, last final questions. Do you order ctDNA on these patients? Yes, no.
No, not from my side. Yeah.
Brad.
No.
Vincent.
No, I think if you knew it were positive, it would worry you. But we also don't have proof. Unlike in bladder cancer, we don't have proof that treating a positive ctDNA is better than not.
Yeah. Do you order Kim1? And where do I order Kim1? Vincent.
So there's a CLIA lab, but the CLIA lab is only for research right now. We are working on a laboratory developed clinical CLIA assay, and I know actually other people are working on it as well. So that will hopefully be available in the near future.
Okay.
And one last question: if they were non-clear cell, would you even consider them for adjuvant?
So I don't think we know the answer. I mean, the B940 trial is allowing papillary RCC in that space. I mean, there are trials in development through ECOG that I think will hopefully answer that question. So right now, it's tough to definitely pursue it. But to that last question really quickly, I think it's really important when I'm thinking about adjuvant therapy, as much as you don't want to overtreat, you don't want to undertreat. So if someone has indeterminate findings, I'm worried. I always make sure I have a scan after surgery before I start. If there's indeterminate findings, I tend to do nothing and monitor them closely and give them therapy for metastatic disease, because we know like nivo-ipi has durable CRs, but you only get one shot. So
I completely agree with you. I will do a short follow-up scan. Like if I see them post-op, they're 6 to 8 weeks, and I'm like, I'm not really sure you could have lung mets. I sit on them for like 6 weeks to see if something blossoms. And then if it doesn't, great, we jump into adjuvant. They're still kind of within their 4 to 5 month window. And if it does, then you've done, it's a good thing. Well, thank you all so much for your wonderful presentations and this lively discussion. Hopefully our audience participants really enjoyed it. And we'll kind of continue to move on with the program. OncoDaily, it's all you. Thank you all.
Thank you.
Thank you.
Hello, and thank you for our wonderful panel for the very engaging discussion. Thank you, Dr. McKay. We will have a short break and move on.
Thanks, everyone.
Hello, and welcome back. My name is Elma. I'm the managing editor of OncoDaily, and it is my pleasure to welcome everyone to the Global Voices in Renal Oncology 2025. It is my pleasure to introduce our next speaker, Giovanni Luca Ceresoli, Head of Pulmonology and Oncology of Urological Hospital Humanitas Cavazzini section. Please welcome his presentation.
Good morning, good afternoon, or good evening, wherever you are. Thank you to the chairs and to the organizers for this kind invitation. I'm a medical oncologist based in Bergamo, Italy, and it is my pleasure to have this overview of the current state of renal oncology in Italy. Next slide. These are my disclosure. Next. Despite the improvement in renal cell carcinoma diagnosis and management observed during the last 2 decades, RCC remains one of the most lethal urologic malignancies. With the expansion of routine imaging for many disorders, an increasing number of patients who harbor RCC are identified incidentally. The probability of harboring kidney cancer is higher in males, in elderly people, among smokers, obese individuals, and individuals with hypertension. Next, please. Geographic areas and individual countries with higher levels of Human Development Index have higher incidence and mortality due to renal cell cancer. Development Index is a summary metric of 3 key dimensions of human development: life expectancy at birth, education based on years of schooling, and gross national income per capita. Next, please. For all this reason, in Italy, the incidence of RCC is rising, with more than 13,000 new cases in 2024, with a male-female ratio of about 2 to 1. There were 4,600 deaths for renal cell cancer in 2022, with a 5-year survival of 70 to 71% in both male and females. And it is estimated that 154,000 patients in Italy are alive after a diagnosis of renal cell cancer. Next. As in many other countries worldwide, the incidence of RCC in Italy is increasing, with an increasing of the absolute number of renal cancer estimated in new deaths. However, 5-year survival after diagnosis of renal cell cancer is increasing in the last 15 years by 11%, from 60 to 71% at 5 years. Next. The reasons for decreased RCC mortality in Italy are related, on one hand, to the improved diagnostic management, with an increasing number of early-stage cases identified incidentally, and also to the improved therapeutic management due to the introduction of TKIs and immunotherapy, in particular the combinations of the two in advanced disease, and more recently by the introduction of adjuvant immunotherapy. But also, this decrease in mortality is due to better surgery and better local treatments. Next. Laparoscopy, and particularly robotic surgery, are the reference techniques for RCC in Italy, and open surgery remains limited to the management of larger tumors and to more complex operations. Robotic surgery, as well known, offers benefits like reduced pain, less blood loss, shorter hospital stays, and faster recovery compared to traditional open surgery. It's particularly beneficial for preserving kidney function in case of partial nephrectomies. The available evidence suggests a potential association between higher surgical volumes and better outcomes in RCC. However, a volume recommendation issued by professional association are largely absent in Europe and also in Italy, and where present differ considerably between countries. Despite this, the RCC guidelines panel of the European Association of Urology encourages the development of a rigorous evaluation of indicators of surgical quality in RCC to better inform the designation of high quality centers within models of centralized care. Next. Non-invasive and minimally invasive ablative treatments, including stereotactic body radiotherapy, radiofrequency ablation, microwave ablation, and cryoablation, have emerged as key treatment options for managing renal cell carcinoma, especially for patients who are not suitable for surgery, and they are developing more and more in our country. All these ablative methods represent effective treatment choice in renal cell carcinoma, and this finding supports multidisciplinary discussion of these treatment methods along with surgery and surveillance to individualize the best treatment decision in each patient. Next. Perioperative treatments represent a major improvement in oncology in several cancers, including RCC. Landmark trials investigating adjuvant vascular endothelial growth factors inhibitors produced the conflicting results with only a single trial of sunitinib, the STRAC trial, resulting in an FDA approval on the basis of a slightly prolonged progression-free survival. However, subsequent meta-analysis failed to show a benefit for adjuvant VEGF inhibitors. Adjuvant sunitinib was approved by FDA, but not by EMA and by IFA, the Italian national agency, due to the imbalance between risk and clinical benefit. Next, please. Several trials evaluating immune checkpoint inhibitors in the adjuvant setting will be published, everyone knows, with conflicting results, and several are currently ongoing. But adjuvant pembrolizumab therapy after surgery for renal cell carcinoma has been approved on the basis of a significant improvement in disease-free survival in the Keynote 564 trial. And as well known in this phase C trial, patients with clear cell renal cell carcinoma with an increased risk of recurrence after surgery were randomized to receive pembrolizumab or placebo for up to 1 year. And DFS was the primary endpoint, and overall survival was a key secondary endpoint. Next. Next slide, please. We all know the results of a trial with a significant improvement in disease-free survival and according to investigator assessment, okay, that was the primary endpoint, and in overall survival. Next. Therefore, the results of a Keynote 564 trial have been acknowledged by the current European Society of Medical Oncology guidelines, and adjuvant pembrolizumab has also been approved for use in Italy in April 2025. Next. The recent approval of adjuvant immunotherapy in renal cell carcinoma in Italy poses a few challenges to the Italian oncologic community. First, there is a need of timely evaluation of resected RCC patients within multidisciplinary tumor boards, and we need a dedicated multidisciplinary tumor boards, not only in academic institutions, but also in smaller institutions. So alternatively, patients should be referred from primary care providers or secondary hospital with the lack of the necessary specialized services to the tertiary hospital nationwide. So we have to find the right model of organization. Next. And as everywhere in the world, a new challenge we are facing also in our country is how to incorporate adjuvant pembrolizumab in current treatment algorithm in case of metastatic relapse, because a relapse pattern is heterogeneous. There are no randomized data or high-level evidence to guide treatment decision. Next. Moving to metastatic renal cell carcinoma, the last 15 years have witnessed a revolution in the way we treat metastatic renal cancer, also in our country, with the introduction of target therapies and immunotherapy, and more recently of a combination of the two. Next slide. Next slide, please. And according to ESMO guidelines, in favorable risk group, 3 combinations are approved for use: lenvatinib pembrolizumab, axitinib pembrolizumab, and cabozantinib plus nivolumab. While in intermediate and poor risk groups, all these 3 combinations are approved with a 4 combination of ipilimumab and nivolumab. Next slide. However, in absence of validated biomarkers in clinical practice in our country, the choice of treatment regimen is largely based on clinical consideration. And Cabo-Nivo and Pembro-Lenva have the highest response rate, the lowest rate of primary refractory patients, and are therefore the most popular combination used in our country, particularly in patients with high volume disease. Next slide, please. A few trials we all know have investigating the possibility of treatment intensification, for example, adding ipilimumab to cabo-nivo, like in the COSMIC study. Next. And the results of the study have shown that among patients with previously untreated advanced renal cell carcinoma with intermediate to poor prognosis risk, the addition of ipilimumab to cabozantinib and nivolumab show longer progression-free survival when treated with nivolumab and ipilimumab alone. However, grade 3/4 adverse events are more common in the experimental group than in the control group. And in updated analysis, the benefit in PFS appear limited to patients with intermediate risk, and no benefit in overall survival was observed in each subgroup. So this treatment is not approved currently for use in Italy. Next. Treatment of patients with favorable risk metastatic renal cell carcinoma is challenging. We have in our country 3 combinations approved for the use in this subset of patients: cabo-nivo, lenvatinib pembrolizumab, and axitinib pembrolizumab. However, we know that while PFS is significantly prolonged with the combination as compared to sunitinib in the 3 trials, with a higher response rate, particularly and higher rate of complete response, and overall survival benefit is not demonstrated with double therapy in this setting. Next. Next slide, please. So in these patients, and particularly in patients with a very favorable risk, defined as primary diagnosis to systemic therapy greater than or equal than 3 years, absence of brain, liver, or bone mets, and cardiovascular performance status of 90 or 100%, the use of single agent TKI is a valuable option, and it is allowed by current European and Italian guidelines. Next. Selected patients with oligometastatic disease can be managed in clinical practice with serial metastasis-directed therapy with prolonged time of systemic therapy with favorable progression-free survival and limited adverse events. In this trial that has been already shown in previous presentations, on 121 patients, median progression-free survival was 70.7 months, and median systemic therapy-free survival time was 34 months. And this is a strategy that is commonly used in our oncologic centers. Next. And finally, just one slide regarding later line therapies. With the use of doublet therapy, also in our country, in first-line setting, this is really an unmet need. Current European guidelines indicate in case of progression on a doublet therapy, cabozantinib or any VEGF-targeted therapy that has not been used previously in combination with IO. In case of prior TKI, European and Italian guidelines suggest the use of nivolumab or cabozantinib, or alternatively also axitinib. For patients pretreated with several prior lines, including IO and TKI, the European Association of Urology guidelines suggest the use of belzutifan, an oral HIF-2 alpha inhibitor. However, this drug, unfortunately, is currently not reimbursed in Italy. So, in conclusion, clinical practice for renal cell cancer in Italy is adherent to international and particularly to European guidelines, with some limitations in drug reimbursement. Adjuvant pembrolizumab is the standard of care since April 2025 in intermediate, high and high risk resected clear cell renal cell carcinoma. Doublets with IO TKI and IO are the standard of care for first-line treatment of metastatic renal cell cancer. TKI monotherapy can be considered, and it is still used in our country in patients with a very favorable risk. And TKI monotherapy is the standard of care in clinical practice as second or third line after IO or IO TKI. Unmet needs in our country in the treatment of renal cell cancer include the development of dedicated multidisciplinary tumor boards for renal cell cancer, the selection of criteria for choice for first-line therapy for metastatic renal cell cancer, treatment algorithm for relapse after adjuvant IO, and second and third line therapies. Thank you very much for your attention.
Thank you very much, Dr. Ceresoli, for the very informative presentation. We are moving on to our next speaker, Çağatay Arslan, who is a professor and medical oncologist at Medical Park İzmir Hospital. Welcome, Professor Arslan. Can you hear us?
Okay, thank you, Ellen. Can you hear me?
Yes, we can hear you. Please share your presentation.
Can you hear me?
Proceed.
Okay,
Yes.
good. Thank you. So can you see my slides?
You can see your slides, but it is not the slides.
Can you see my slides?
Dr. Arslan, we can see your screen, but you have not put your slides.
I can hear you.
Can you hear us? Can you hear me? We can see your screen,
Yeah,
but
I can
not
hear
your
you.
slides,
I can hear
because
you.
you have not opened your slides yet.
Okay. I'm trying to do it again. So is it okay?
Yes, please share with full screen
Is
and
it okay?
proceed. Yes.
So sorry for this problem. So can you see it full screen?
We cannot see the full screen yet. If you click on the button at the right lower corner.
طالب فاينانس عن وصول رحلة رقم 271 القادمة من الرياض. Your attention, please.
There is a window button at the right lower corner next to the Zoom option. Yes, that one.
Okay, I think. Is that okay? So,
Dr. Arslan, we lost your slides. If you can send it over to us, we can share it for you. If not, please proceed like this.
okay. So it seems that I'm sharing, but
it's okay. You are sharing. Can you please see if it moves to the next slide and proceed?
okay then. Now we cannot control it.
Can you please share it to our email and we can share it for you?
Okay. Okay. Okay. So I will. Can you please direct me? How can I share it with email or?
We are texting you right now in the chat. If you check the chat.
Okay. Okay. Okay.
So we are gonna do a 5-minute break until these technical issues are solved. Drink
Okay.
water and come back. Hi, and welcome back to the Global Voices in Renal Oncology 2025 Summit. We are going to introduce our next speaker, who has a pre-recorded video for us, Dr. Emre Yekedus. He is the Associate Professor of Medical Oncology at Ankara University. Thank you.
I would like to thank the organizing committee and the co-chairs, Rana McKay and Yüksel Ürün, for this kind invitation. And it's my great pleasure to be here and to present my slides in this part of the session. And so my name is Emre Yekedus, and I'm a medical oncologist in Turkey. And I'm primarily interested in the genitourinary cancers and the renal cell carcinoma. So I will mention the current state of renal oncology in Turkey in this part of the session. So I'm going to mention the epidemiology first. And when we look at the incidence rates, and it's about 6.6 and per 100,000 persons in male, and it's about 3. And actually, it's a bit lower and when compared to the series stats and the rate of new cases in the United States. It's about 14.8 per 100,000 persons. So it might be associated with the risk factors of kidney cancer, for example, the obesity and the hypertension and the smoking status and other risk factors can be affect actually the rate of the kidney cancer in male and female patients. So on the other hand, when we look at the prevalence, and it's the 6th most common cancer in male in Turkey, and the overall population, the 5.1% of all cancer subtypes. After this cancer stats of Turkey, I will mention a nationwide study which is published in 2025. The median age actually is 59 for female and male patients. And when it comes to those year stats, it's 65 median age at diagnosis. And our population a bit younger than the United States population at diagnosis. And there might be several reasons of this. And again, the risk factors and the other genetic factors can affect this situation. And when we look at the male to female ratio, it's about 1.5 to 2, and it's as expected ratio in all over the world and the United States stats, and almost similar in our cohort in Turkey. When it comes to the RCC subtypes, and the most common RCC subtype is expected the clear cell renal cell carcinoma. It's around 70% of all patients diagnosed with the RCC. So followed by the papillary RCC, the second one, and the chromophobe RCC, third one, and the other unclassified and other rare subtypes. And it's about 5 to 6% of all RCC patients, which is very similar to the global stats and the other series stats. So the type of nephrectomy is also important, and because of the prevention of renal function is very essential for these patients. And almost half of patients had undergone the radical nephrectomy, and a bit more than half of patients, it's about 55%. And the partial nephrectomy rate is 45 in male and female patients. So actually, we have a large cancer registry database for kidney cancer patients, and which is established by Yüksel Ürün and our team and other high volume cancer centers all over the country. So up to now, we included 2,000 patients diagnosed with metastatic RCC from approximately 15 high volume cancer centers all the country. And up to now, and for the last 5 years, actually, we have been published 12 publications from our database. And when we look at the treatment attrition rates and from our TKCC database, and approximately 60% of all patients receive second-line treatment. And this rate is approximately 25% in the third line, and it's getting worse and over the treatment lines. For example, it's only 2% in the fifth line. So the most common reason for treatment attrition, all the treatment lines, actually the disease progression and also as expected death. And so actually, if you look at other reasons, for example, 10 to 15% of all patients actually experience the treatment toxicity. And because of the treatment toxicity, they had to leave from the treatment. So this is very important. It's not a lower rate, actually, 10 to 15%. So we have to consider about it and what's the reasons and how can we manage these toxicities. So it was necessary to leave the treatment. So we have to actually evaluate all of these reasons, and we have to consider during our clinical practice. And this is the survival outcomes from our TKCC database. And the first line, the patients receiving sunitinib in the first line, we included more than 500 patients. The median overall survival was 31 months in all cohort. And actually, it's more than 40 months in IMDC favorable risk group. And this is really good, actually. This is impressive. And furthermore, and if we classify patients based on the favorable risk category and very favorable, and the remaining patients are favorable risk group. And in the very favorable risk group, the median overall survival was 55 months. And it's really great because if we check the CheckMate 9ER, for example, and this is the pivotal trial for all IO-TKI combinations, and the median overall survival in the ITT population is 46 months. So still, we have some of patients can get benefit from only TKIs. And so we need more data to classify those patients based on their molecular subtypes and the other clinical aspects. And when it comes to the non-clear cell RCC in Turkey and our TKCC database, and so actually published this data with 118 patients, and the median overall survival was 19 months. The most common subtype for non-clear cell RCC subgroup is the papillary RCC. It's more than 50% and half of patients. And the second one is chromophobe RCC as expected, and the other rare subtypes and unclassified subtypes are following the papillary and chromophobe RCC. And this is another database study from Turkish Urology Association database, and they include more than 2,500 patients, and they also compare the clear cell RCC and the chromophobe RCC based on the survival outcomes. And according to the study, the chromophobe RCC patients had better survival and compared to the clear cell RCC patients. So if you look at the clinical trials and the current situation in Turkey for kidney cancer, and for the last 5 years, we recruited patients in clinical trials and more than 15 clinical trials, for example. And we searched for the last 5 years, and we had 18 studies, and some of the studies still active and recruiting patients with metastatic or non-metastatic RCC. And what are the future perspectives? And actually, we are very excited to build stronger international collaborations with other participants and other institutions and other countries. So we are very eager to expand our translational research aspects, and also we are expecting more innovate in drug development. Thank you very much for listening to me, and thank you very much again for the organizing.
Welcome back. Introducing again our next speaker, Çağatay Arslan. Dr. Arslan, are you here? Let me remind you that Dr. Arslan is a professor and medical oncologist at Medical Park İzmir Hospital. Can you hear us, Dr. Arslan?
Yeah, I can see, I can hear you. So sorry for the technical problem from my side. Now
No
I have
problem
a
at all.
camera problem. Okay, so but I will go through with my slides. Can you see my slides?
Yes, we can see your slides.
Okay, okay. So thanks again, and sorry for the problem. So this is my topic. So I will talk on chromophobe renal cell cancer diagnosis and treatment. So this is the last WHO classification of renal tumors. This is the 5th edition. Yeah, we can see that oncocytic and chromophobe renal tumors are in the same class. So oncocytoma of the kidney, chromophobe, and the other oncocytic tumors of the kidney. So we know that chromophobe.
I'm so sorry to interrupt you. You are not changing your slides, or rather, we cannot see how you're changing your slides. That way is better. Please use the cursor,
So,
okay?
Okay. So I will move forward with this. So as we know, the chromophobe renal cell cancer is originated from the distal convoluted tubule, so from the intercalated cells. So we know that around 2,000 new chromophobe renal cell cancer cases per year. And the median age of diagnosis is around 60, and there's a slight male predilection. So around 5% of the renal cell cancers are chromophobe renal cell carcinoma. This is a well-wide clinical presentation and prognosis. These tumors are generally diagnosed in early stage, and they are generally asymptomatic and detected incidentally, as in all renal cancers. And the patient might have some local symptoms as flank pain, abdominal mass, and hematuria. And there might be some systemic symptoms as in all renal cancer cases, as fever, cachexia, and weight loss. Up to 1/3 of the patients can have these symptoms. And majority, as I told, diagnosed at localized stage. And we know that the chromophobe cancers are less aggressive than clear cell, especially in local stage. And the common metastasis sites are liver and lungs. And median overall survival is in metastatic setting is around 27 months. So there are some CT findings that is specific for chromophobe renal cell cancer. There might be a classification in 1/3 of the patients, and also central scarring in 1/3 of the patients. And contrast enhancement is less than clear cell, but more than papillary cancer. These are solid, well circumscribed margins localized to the kidney, and there might be enhancement peaks in the nephrogenic phase. And again, this enhancement is lower when you compare to the cortex of the kidney. So pathological diagnosis is up to morphology, histochemistry, and immunohistochemistry. These are typically pale, reticulated, cytoplasmic, and perinuclear hollows, including cancers. The variants are classic, eosinophilic, and mixed. So there are some tips in the tricks in the immunohistochemistry. So these are cytokeratin 7 positive, diffusely positive cancers, different from the oncocytoma. This is important. And the CD117 is positive. This is also positive for oncostoma and chromophobe cancers, positive for both. And the differentiation from oncostoma is essential. Vimentin is can be used from discrimination from the clear cell cancers, and also colloidal iron is diffuse positive in chromophobe cancers, and carbonic anhydrase and CAIX is positive in clear cell and negative in chromophobe cancers. So you can see these cancers as sheets, alveolar, trabecular, or nests. These are well demarcated cells. They can include commonly binucleation or multinucleation. They can have finely granular eosinophilic cytoplasm and perinuclear hollows. And you can see the perinuclear cytoplasm and irregular nuclear borders. They have coarse chromatin. If you see the bottom hematoxylin eosin slide, you can see that oncocytomas and chromophobe cancers are similar, looking similar morphologically. So they have some specific molecular and genetic features. So they have aneuploidy, multiple chromosome losses, and they have loss of HNF1B and TP53 and PTEN mutations occasionally. And so they have a highest mitochondrial DNA mutation rate, especially ND4 and ND5, shown in the TCGA. They have a markedly elevated glutathione levels and lower PD-L1 expression, distinct from the clear cell and papillary renal cell cancers. So chromophobe cancers might be less immunogenic compared to clear cell and papillary cancer. They have low T-cell infiltration. They have low expression of immune checkpoints as PD-1, TIM1, LEC3. So they are less immunogenic when you compare with the other subtypes. So it is related with Birt-Hogg-Dube syndrome. This is a folliculin mutation, which this gene is in the 17th chromosome. This is an autosomal dominant syndrome, and you can see multiple tumors in the one kidney and some airs and dermatological findings in the beta-signaling, HIF1 alpha transcriptional activity also. So it crosstalks many pathways in the center of the cell. So ferroptosis is a prominent
Dr.
pathway in
Arslan,
chromosomal.
for a moment we lost you there. Can you please start from the beginning of this slide only? The current slide.
This the ferroptosis slide. Ferroptosis slide.
Yes. Yes,
Yeah.
thank you.
Okay, so ferroptosis is a prominent pathway in chromophobe renal cell cancer. So when you compare to papillary and clear cell cancer, there is an increased mRNA expression of ferroptosis suppressor protein 1, and you can see that these left diagram shows the increased ferroptosis suppressor protein 1 when you compare it with clear cell and papillary cancer. So also the glutathione levels are high in chromophobe cancers, so which deals with the protects the cell from the oxidative stress and the that. So it is shown that in TCGA, ferroptosis signature is prognostic, even in the clear cell, but most prominent in the chromophobe cancers. if the ferroptosis signature is high, so the low, the prognosis is better. So KIT is another important point, that it is expressed high in chromophobe cancers, shown in the TCGA also, even in the primary and metastatic. It is high when you compare with the papillary and clear cell cancers also. So to talk about the treatment, localized treatment of the chromophobe renal cell cancer is extrapolated from the clear cell. So surgery is the main treatment. Local thermal ablative techniques and SBRT might be used for small tumors. And active surveillance is still a choice, just like a clear cell. And it is with better prognosis when we compare to clear cell. And 5 years disease-free survival is around 90%. And there is no evidence for adjuvant treatment after surgery. So this is a negative trial, Everest trial with everolimus done in the non-clear cell cancers. When you look at the in the red rectangular, so you can see that even in the chromophobe patients, it was negative regarding PFS and overall survival. There is an ongoing study, similar design as in Keynote 564 study. After surgery, patients were randomized to pembrolizumab or active surveillance. Maybe these studies' results will help to give some immunotherapy to these patients in the adjuvant manner. So to talk about the metastatic setting, in the metastatic setting, we have to decide about the surgery, cytoreductive nephrectomy, and also metastatectomy or SBRT. And in some patients with large volume disease and maybe with significant sarcomatoid burdens, giving systematic treatment upfront might be better. But we have to evaluate each patient for cytoreductive nephrectomy or metastatectomy or SBRT, especially in the oligometastatic patients. So I will summarize the systemic treatment options in a chronological order. So this is a small study with atezolizumab in non-clear cell and sarcomatoid clear cell cancers. There were some less than 10 patients, chromophobe cancer patients in this paper by McGregor in 2020 in JCO. The patients had a response of around 20-30%, and the PFS was around 9 months, and the median OS was not reached in that study. So this is the second study by Hudson, published in European Urology in 2021. This was lenvatinib plus everolimus in the first line in the non-clear cell cancers. There were 9 patients with chromophobe cancers in this study. You can see the blue bars are representing the chromophobe cancers, and there were some ongoing responses in this patient group. So overall response rate was around 44%, and you can see the tumor shrinkage of those chromophobe cancers in the blue bars. Median progression-free survival was 92, and the OS was 15.6 months. So there was another study, Cosmic 021 study with cabo-atezo in first and even in the second line with cabozantinib and atezolizumab. You can see that the C, capital C, is resembling the chromophobe cancers. There were 9 patients again in this study. Overall response rate was 11%, and the progression-free survival is around 11%, 10.8, 11 months, 10.8 months, and OS was not reached in this analysis. The And there is another trial with cabozantinib and nivolumab in the first and second line. In the cohort 2, there was 7 chromophobe patients. This cohort was specific to the chromophobe patients. 1/3 of the patients were pre-treated with small molecule inhibitors. And you can see that there was no responses. There was some tumor shrinkage, and the patient, 70% of the patients had stable disease. And the side effects are generally related with cabozantinib as diarrhea, hypertension, and palmoplantar erythrodysesthesia. So looking from the genomic window, in this study, chromophobe patients has shown to have TP53 and PTEN alterations, no other mutations, just like the other subtypes. And the other study was a triple regimen, cabo-nivo and EP, as we have seen the phase 3 in clear cell renal cell cancer. In this study, there were 11 patients of chromophobe subtype. So these light blue bars are resembling the chromophobe cancers, and there were only 1 patient responding, and 5 patients had stable disease. So there was a 54% of disease control in this study with triplet regimen. So PFS is around 9 months, and OS was not reached in this analysis. But this triple regimen, had a high grade 3 or higher toxicity. So especially with grade AST and ALT increment, and high dose steroids required in 1/3 of the patients. So one of the biggest studies in non-clear cell was Keynote B61 study, which is with pembro plus lenvatinib 20 milligrams, and there were 29 chromophobe cancer patients in this study. So this study was done with 158 patients. You can see that overall response rate is 27.6, and PFS is 26 months in chromophobe patients, and the overall survival was not reached. But 18 months overall survival rate was 75%. So the toxicities was generally related with the lenvatinib, hypertension, diarrhea, proteinuria, and hypothyroidism. So adverse events occurred in around 60% of the patients, and discontinuation due to both treatments was around 15%. So Sunny forecast was presented in the last ESMO, so combining Nivo EP in non-clear cell cancers compared with the standard care. So this was an academic study done around 300 patients. You can see the characteristics, but I will not go into detail. So overall survival was similar, higher with Nivo EP compared to standard of care, which was statistically insignificant. When you look at the chromophobe subgroup, there was a signal that this treatment, EP-Nivo treatment, might benefit, but the statistical significance was not clear. But when you look at the PD-L1 positive patient population regarding all the non-clear cell cancers, the overall survival was statistically significantly longer in the PD-L1 positive patients. And in Sunny forecast, there was a 25.5% of response rate with EP-Nivo in chromophobe renal cell cancer patients. So this is might be a treatment algorithm for chromophobe renal cell cancer for localized disease. So we have to evaluate the patient for a partial nephrectomy or radical nephrectomy, and ablation if it is feasible for small tumors, and surveillance might be a choice for small tumors and patients who cannot tolerate the surgery. and there's no proven benefit with adjuvant treatment. In metastatic disease, we have to consider again the cytotoxic nephrectomy, especially with patients' good performance and symptomatic renal mass. The systemic treatment choices are sunitinib, pazopanib, lenvatinib, everolimus, lenvatinib, pembrolizumab. This is taken from the ESMO guideline. So a couple of slides about the ongoing research on systemic treatment of chromophobe cancers. So as I mentioned, ferroptosis might be a good target in chromophobe renal cell cancer. So glutathione is around 100-fold elevated. So free radical trapping as an antioxidant prevents the cell from the death. Oxidation of membrane lipids leads to ferroptotic cell death, and inhibition of cysteine uptake. This is the rate limiting step for glutathione, induces ferroptosis and decreases the chromosome renal cell cancer tumor size. So if you suppress ferrous protein 1, you can shrink the tumor. So this is a mice model, and this is the recent publication from Salem et al. Published in Nature. So if you knock down the ferroptosis suppressor protein 1, not in vitro but in vivo tumor growth is prevented. So you can easily see that the red and the blue bars, light blue bars, the light blue lines are resembling the ferrous suppressor protein 1 knockdown mice, and you can see that tumor shrinkage with this when you knock down the ferrous protein 1. So also you can combine the glutathione inhibition and this pathway. When you inhibit both pathways, you can see a tumor shrinkage clearly, which means combining them it have a synergistic effect. So KIT might be another target to treat chromophobe cancers. It's expressed highly in these cancers, and it is diagnosed in chromophobe renal cancer diagnosis also. Different from the GIST, it is wild type, and inhibition of KIT might decrease tumor burden in chromophobe cancers. Decreased cell survival is shown with KIT ADCs in this type of cancers, and a phase 1 basket trial is planned with a KIT ADC. So this is the publication from Alcieri published in Clinical Genitourinary Cancer this year. So you can see that in the top of this diagram, the DM1, the chemotherapy treatment. So the renal cell cancer is affected with this treatment, but papillary cancer is not affected. And lower part of this diagram is showing that LOB628 is a ADC which is inhibiting KIT, and purple and red bars and green bars are resembling that tumor shrinkage is seen with this ADC KIT in chromophobe cancers. So to conclude, clinical trials are high priority in this rare disease, chromophobe renal cancers. We have no data for adjuvant treatment yet. Cytotoxic nephrectomy and local treatments for systemic disease are extrapolated from chromophobe cancers, clear cell cancers, and immunotherapy combinations are hopeful in first line, as we've seen in SONY forecast and Keynote B61. And the available subsequent line treatments might increase this patient survival in the clinical practice. Ferroptosis pathway and KIT are emerging targets for this rare disease. Thank you, and again, sorry for the technical problem from my side.
I cannot hear you.
Excuse me for that. Thank you very much, Dr. Arslan. We are moving on with our next speaker, Dr. Guillermo de Velasco. He is the medical oncologist at University Hospital Doce de Octubre. Welcome.
Thank you, Ellen, and thank you, everyone. It's a real pleasure being here today with all of you. And today I will be talking about renal cell carcinoma with sarcomatoid differentiation. So first of all, just looking at this renal cell carcinoma with sarcomatoid differentiation, I guess the main take-home messages for all of you is that remember that when we talk about sarcomatoid in kidney cancer, it's not a subtype. It's a phenotype, which means like we can see sarcomatoid differentiation in any subtype, but it's not an entity itself. So said that, the next slide, please. So when we see sarcomatoid differentiation, and one of the most common is in the clear cell, when we want to define sarcomatoid differentiation, we need to basically focus in pathology. That is high grade, so we'll see high grade spindle cell transformation that can occur, as I mentioned before, in any histology. And that spindle cells are those that you can see in the figure in the right. Next slide. So when we think about how many of patients with RCC will have sarcomatoid differentiation, will be about 5%. Next. And up to 20% of those patients will have a sarcomatoid differentiation with metastatic disease. But what I think is very important and very remarkable is that any RCC with sarcomatoid features is classified as grade 4. So 3 important messages here. When you think about overall RCC, only 5% of the patients will have sarcomatoid differentiation. When you focus in those patients with metastatic disease, that moved from 5 to 20%. We are seeing already that the prognosis will be worse with sarcomatoid differentiation. But important, any RCC with sarcomatoid features will be a grade 4 classified by the ISO classification. So which subtypes are usually affected with? Obviously, in the right side, you see the clear cell. That's the most common subtype where you can see sarcomatoid differentiation, but it may happen as well in the chromophobe and unclassified. Up to 9% of the cases with chromophobe and unclassified may have sarcomatoid differentiation, and also it may happen in papillary, although the frequency in papillary is lower compared with the other histologies, in about 2 to 3%. In all these subtypes, when you see sarcomatoid differentiation, will be associated with worse outcomes compared with those patients without sarcomatoid differentiation. Next. Any percentage, and this is another important message, any percentage of sarcomatoid component is clinically significant and sufficient for the diagnosis. And this is relevant because in the past, it used to be a threshold. You need to have 20%, 50%, but now we know that having just 1%, which means any percentage of sarcomatoid differentiations, we need to say that our patient has this sarcomatoid component. And this is important because this heterogeneity means that you may have a biopsy that is not getting the full component, and you are missing the component of sarcomatoid differentiation, and it may have an impact in the treatment and management of our patients. Like when you are having a patient with very aggressive disease, and it may fit within a patient with sarcomatoid differentiation, if we have only the biopsy, we may be skipping that important part. Next slide. And next slide. So, what about molecular and biomarker profiles? What are the most common genomic alterations that we see in sarcomatoid differentiation? So first of all, there is no single driver mutations for some sarcomatoid transformation. So there is not just one lesion or one alterations that we'll see. If we see these alterations, these patients will have sarcomatoid differentiation. That's not have been identified so far. Next slide. What is important is like sarcomatoid RCC appears to arise due to accumulations of different mutations, some of them quite specific, and there is the epithelial mesenchymal transition program is really activated in patients with sarcomatoid differentiations. Genomic studies have shown that when you look at those patients with sarcomatoid differentiation, they share these clonal origins with the epithelial RCC, but they have acquired additional mutations. Which are the most common mutations that we see in this sarcomatoid RCC? Next slide. So one of the most common mutations that we see is BAB1. You can see in the right side that BAB1, that we know it's more commonly associated with worse outcomes, or NF2, and also P53 will be three of the most commonly mutated alterations that we'll find in patients with sarcomatoid differentiation. Next slide. But also, we know that we can find deep deletions, and this is important, in the CDKN2A-B that's located in the locus P16, or that's more common. So when we find patients with those deep deletions of CDKN2A-B, that will be associated with worse outcomes, that will be associated with sarcomatoid differentiation. And finally, which is important, we see some of the mutations such as PBRM1 or KDM5C are less common in patients with sarcomatoid compared with patients with clear cell without sarcomatoid differentiation. And we know that usually these mutations are associated with better outcomes. So in general, we see some more common mutations specifically in sarcomatoid tumors that are more associated with worse outcomes. And those mutations that we know that are associated with better outcomes in clear cells, such as PBRM1, are less associated with this sarcomatoid differentiation. Next slide. But not only everything is about genomic. What about epigenetic and transcriptomic features? And I'm telling this because the team from Tony Shueri and Bakuni and colleagues, they worked in a very nice paper, seminal paper that I will be using today to discuss all these alterations. And there has been emerging data from the Tony Shueri's group showing that there is a unique epigenetic program in sarcomatoid RCC. And we know that there are enhancer promoter profiles with the upregulation of the EMT-related transcription factors, but also there is the MYC-driven transcriptional programs are really increased. Next slide. And what we found is like TOR signaling, DNA repair genes may be high upregulated as well in patients with sarcomatoid differentiations. But what I think is really interesting, and we'll discuss why, they found also that this tumor exhibits an immune inflamed expression phenotype. Next slide. What about the immune microenvironment and PD-L1? So we know that usually when you think about RCC in general, you know that the PD-L1 expression usually is quite low, between 15-25% of the cases, depending on the series. But what I think is really interesting, again, from this paper, is that they found that it's highly immunogenic within the tumor microenvironment. And one of the things that they found is they looked specifically to the percentage of PD-L1 positive. They found that there were 20% in those patients with non-sarcomatoid RCC as compared with 43%. So there is an increase, a delta of 20% increase in PD-L1 expression in those patients with sarcomatoid, with those tumors with sarcomatoid differentiation. Next slide. So what are the prognostic implications and what are the historical outcomes? So I was saying that we know that in most of the cases we've seen that the molecular biology implies worse prognosis. And the reality is like looking at the presence of sarcomatoid differentiation has linked to really poor prognosis. So the median overall survival for those patients with metastatic RCC with sarcomatoid differentiation was between 6 and 13 months. So really, really bad outcomes. In large registry analysis, 5-year survival was really much worse in those patients with sarcomatoid differentiations compared with non-sarcomatoid differentiations, as you can see in this figure here. It's an old figure. But even in the localized tumors, and this is quite relevant, over 75% of the patients, when they are looking at patients with sarcomatoid, overall, 75% of the patients had metastasis at diagnosis. And even those that they are able to undergo nephrectomy with that sarcomatoid differentiation, there are series showing that up to 75%, which means 3 out of 4 patients, will have relapsed within the 2 years, looking again at how bad outcomes those patients with sarcomatoid differentiation had in the past. Next slide. Important. There is one concept that you should not forget. It's like any sarcomatoid component signals a high risk of early relapse. And this is important within localized disease and also within the metastatic disease. Next. So I was saying that definitely sarcomatoid differentiation has prognostic implications. So what about the risk stratifications? Are we using sarcomatoid differentiation with our prognostic models? The reality is that sarcomatoid change is highly correlated with high grade. So as I mentioned, sarcomatoid will be grade 4, and it's also tied to different other prognostic factors. So usually those patients with sarcomatoid differentiations will have high TNM stage, will have poor ECOG performance status. They will have other issues related with the tumor. And indeed, when you look at the IMDC risk model, the most commonly model used for prognosis in the metastatic setting, we don't include sarcomatoid differentiation. And the reason why is like most patients with sarcomatoid fall into intermediate and poor risk categories. Can you see a patient with favorable IMDC with sarcomatoid differentiation? Yes, but usually it's less than 5% when you look at the series. So most patients, like more than 95% of the patients with IMDC, so with sarcomatoid differentiations, will fall within those patients with poor risk or intermediate poor risk based in the IMDC classification. But obviously, there are some risk models that have treated sarcomatoid differentiation itself as an independent risk factor for survival, and it's something that you should consider. Next slide. Okay, so we have now different patients with a different subtype with a sarcomatoid differentiation. Yes, thank you. So how should we treat this patient? So first of all, surgery remains as a pillar for treatment in the localized disease. So any patient that when we could perform surgery because the patient has localized disease will be indicated regardless the presence or not of sarcomatoid differentiation. That's something very relevant. In the past, because that sarcomatoid differentiation was associated, of course, as sarcoma, chemotherapy was used. And that's why you can see in this table some regimens such as doxorubicin plus ifosfamide or gemcitabine, that they were used to try to control those patients with sarcomatoid differentiations. The response rate was low, between 15 and 30%, but with small numbers and with a really low PFS between 2 and 5 months. With the arrival of targeted therapies, different studies show that treatment with tyrosine kinase inhibitors such as sorafenib or even combination of different tyrosine kinase inhibitors, sunitinib, sorafenib, or even mTOR such as temsirolimus or everolimus show really low responses between 10 and 20%. And even combinations, because they were tested in the past, combination of targeted agents plus chemotherapy, combination of gemcitabine plus sunitinib or capecitabine plus gemcitabine or bevacizumab showed high response, but around 20%. So the benefit was really modest, and the median overall survival still remain pretty low in the context of chemotherapy, targeted agents, and surgery in the past. Next slide. But now we have a new standard of care. In general, for clear cell RCC, for non-clear cell RCC, but specifically for those patients with sarcomatoid differentiation. And we have basically two options, either using dual immune checkpoint inhibitors, PD-L1 plus CTLA-4, ipi/nivo, or we can use combination of IO plus tyrosine kinase inhibitor. Next slide. So which data do we have, next slide, with ipi/nivo? So in this figure, you have the data from the CheckMate 214. And just to remind you, for those not familiarized with the study, the CheckMate 214 was a phase 3 clinical trial for patients with clear cell RCC that compare the combination of ipi/nivo compared with sunitinib. And in this figure, you have the long-term outcomes in the sarcomatoid population. And when you see in the left is that for all patients, the PFS was 26.5 months with ipi/nivo compared with 5.5 months with patients with sunitinib. And which is important, you see a clearly a plateau, and you see that at 60 months landmark, 46% of the patients with being treated with ipi/nivo did not progress with that combination in those patients with sarcomatoid differentiation. And also, there was a huge increase in the overall survival, median overall survival 48 months, 4 years, compared with 14 months with sunitinib. So definitely there was a huge impact with the use of ipi/nivo. Next slide. Which is interesting is that we don't use PD-L1 expression usually for our patients in RCC. However, in this study, although look at the numbers that are really low, when they were looking specifically for those patients with sarcomatoid differentiation and PD-L1 expression, remember that was higher in those patients with sarcomatoid compared with those patients without sarcomatoid differentiation. And the PFS was not reached, but there is a plateau in those 60% of patients without PD at 5 years, compared with 14% in those patients with PD-L1 high. However, that difference was much lower for those patients with sarcomatoid differentiation and PD-L1 below 1%, where the PFS was only 9 months compared with 5.4. Said that, for any of those patients, the indication would go for using a combination with IO plus or double immune checkpoint blocker or IO tyrosine kinase inhibitor, but today we don't use the PD-L1 expressions to select our treatment. So far, although we are waiting for the CARE trial from Dr. Albies that we are running in Europe and many other countries across the world. Next slide. So what about IO plus tyrosine kinase inhibitor? Okay, there have been many studies with combination of IO plus tyrosine kinase inhibitor. The first one, the first one was the combination of pembrolizumab plus axitinib, the Keynote 426. And in this study, and here, what you can see is the specific data for patients with sarcomatoid differentiation. What you see is like those patients with sarcomatoid differentiations, the response rate was 60% versus 30%, improvement in the PFS, improvement in the median overall survival. Next slide. Also in the CheckMate 9ER, you can see the benefit again, 55% versus 22%. CheckMate 9ER was a study comparing cabozantinib plus nivolumab versus sunitinib. Again, in the population with sarcomatoid differentiation, there is an increase, a delta of 33% in response rate when you are using the combination of cabo plus nivolumab. There is a hazard ratio of 0.42 for PFS, and there is also an increase in the hazard ratio for overall survival. Next slide. We saw the same results with the CLEAR data, showing that the median PFS, the hazard ratio was 0.39. Next slide, with an increase in the overall survival. And even in another 2 studies with avelumab, the Javelin Renal 101, avelumab plus axitinib, show an increase in the response rate with the combination, an increase in the PFS, And even in the final study, please next slide, in the emotion study, emotion 151, the combination of atezolizumab plus bevacizumab compared with sunitinib showed a 50% of response rate with the combination compared with the tyrosine kinase inhibitor monotherapy. So definitely there is an increase in the response rate, in the PFS, and probably in the overall survival. Although all these studies were post-hoc analysis of the population included, and there is not studies specifically done for patients with sarcomatoid differentiation. Next slide. You can have here in this one also, now that putting together the CheckMate 214 as well, basically any single study with immunotherapy or double immune checkpoint blockade or IO plus tyrosine kinase inhibitor showed an increase in the outcomes for patients with sarcomatoid differentiation. Next slide. In the next slide, you can see this figure with the PFS benefit, with the hazard ratio. And although this is an indirect analysis, we cannot really say that it's any of these combinations are better compared with the other ones. Although the PFS, it looks better with the CheckMate 9ER with carbonivo LEMPEM, the reality is that the data with the CheckMate 214 with nivo-EP, the durability of the response seems better in these populations with sarcomatoid differentiation. Next slide. So I'm doing a kind of tentative meta-analytic estimate. So if you are thinking what is giving today the immunotherapy or the combinations with immunotherapy for patients with sarcomatoid differentiation, is like the response rate is approximately an increase in 30-40% absolute increase when you are using these combinations. For the PFS, you are increasing a hazard ratio between 0.4, 0.6, which means an increase from 7 months with tyrosine kinase inhibitor to 25, up to 25 with combination of IO plus tyrosine kinase inhibitor, and the hazard ratio for OS, probably it's around 0.45, 0.6 with this combination. So definitely combination of IO-based combination are increasing response rate, PFS, and overall survival. Next slide for this sarcomatoid differentiation. But there are some limitations and gaps. So definitely, as I mentioned before, there is a lack of dedicated randomized trials. So there is no trials where we are including only patients with sarcomatoid differentiation to select between IO-IO or IO tyrosine kinase inhibitor. It's happening the same in patients without sarcomatoid differentiation, but definitely it's a gap when we talk about sarcomatoid. Important about the heterogeneity, and I mentioned at the beginning that sarcomatoid differentiation is based in just any percentage. And we know that when we are including patients in the trial, some of them we are getting just the biopsy, some of them we have nephrectomy, but some of them we are missing part of the disease that eventually may have more sarcomatoid differentiation. So we need to be very careful when we are reading all these studies based on this issue of heterogeneity. Obviously, there is a publication bias and selective reporting because we are seeing all these studies being positive and trying to pick up. There are some of these studies have much more details. Some of them, they have less detail about this sarcomatoid differentiation. As I mentioned, there are some gaps that we need to be careful when we are reading all these post-hoc analyses. And one of them is like some of the studies, not the CheckMate 214, but some of them have short follow-up for this specific population with sarcomatoid differentiation. And finally, next slide, I'm going to go with the take-home messages. So I think you can go for the next, and I can go for all these because I can start discussing all once you have all these take-home messages in the slide. So first of all, that was the first idea at the beginning. Sarcomatoid differentiation in RCC, it's a marker of aggressive biology. So anyone with sarcomatoid differentiations will have poor prognosis with historical therapies, median OS less than 1 year. We know that the molecular profile much better. There are some groups have been working on this, especially acknowledged to Shoeri's lab, Previous slide, please. Yeah. So enriched for BAP1, P53, and NF2 mutations, CDNK deletions, and high PD-L1 expression. Definitely, IO combinations outperform tyrosine kinase inhibitor monotherapy across all major trials in RCC. Important, Nivo-IPI offers durable survival plateau and high CRS rates. And about the clinical choice, should balance. Need for durability, probably IO-IO. Need for rapid shrinkage, argin control, as we've been doing in all the patients without sarcomatoid, IO plus tyrosine kinase inhibitor. But all IO-based regimens clearly change the natural history of sarcomatoid RCC, establishing IO therapy as the frontline standard for all patients with sarcomatoid differentiations. And future directions, I guess, triplet regimens. We've seen that many of our patients still progress despite using the immunotherapy. So maybe novel checkpoints and specific biomarker strategies will help us to improve outcomes, especially in non-clear cell sarcomatoid RCC. So thank you very much. And thank you all for being here. As I think the main messages like we were talking about in the past for untreatable to now immunotherapy responsive tumor. Thank you very much and happy to discuss during the panel discussion.
Thank you very much, Dr. De Velasco. We are moving now with our I apologize for the inconvenience. Thank you very much, Dr. De Velasco. We are moving now with our next speaker, Clida Mati from Albania. She's a medical oncologist at Albania American Hospital. Please welcome.
Hello, I hope you can hear me. Okay, hello everyone. It's a pleasure to be here today. My name is Clida Mati. I don't hear you. Hello.
Dr. Mati, can you hear us?
Yes, now I can hear you.
Great.
Can you please, can you please share
Yes,
the
everything
presentation?
is fine. Can you share your screen?
Actually, if you can share, I sent you the presentation.
Yes. Okay, just give us a second, so we
Yes.
will share it.
Thank you. So, hello, everyone. Can I start? Okay, I think yes.
Sorry, Dr. Matti, the presentation is already live, so you can start.
Thank you. So it's a pleasure to be here today. My name is Cleida Matti, and I work as a medical oncologist at the American Hospital in Tirana, Albania. And today, actually, I want to share with you the current state of renal oncology in Albania, and but this is not just about some clinical facts and figures. It's about the challenges of delivering cancer care in a setting where data are scarce, where resources are limited, and patients often face barriers that sometimes go beyond medicine. So my focus will be to show you how these gaps actually impact patient care, and while building stronger systems for data collection, access and equity actually is very essential in cancer care. So next slide, please. So let me start by giving you just a little context about my country. Albania is a small nation in Southeast Europe with a population of approximately 2.5 million people. And when it comes to cancer care, we face many of the same challenges that other low and middle income countries do. Limited resources, fragmented oncology services, and perhaps I would say most importantly, the absence of a comprehensive national cancer registry. That means that for many cancers, and kidney cancer especially, we simply don't collect incidence, mortality, or survival data in a systematic way. And as you can imagine, this makes it very difficult to understand the true burden of the disease. And this isn't unique, I'd say, to Albania, because many countries that are still building their cancer care systems face the same problems. And I think where diseases with a relatively smaller incidence risk become actually statistically invisible. So what you see on this slide are actually Globocan 2022 estimates. These give us a modeled picture, around 8,000 new cancer cases in Albania, close to 5,000 deaths, and almost 20,000 people living with cancer within 5 years of the diagnosis. The leading cancers are the usual suspects: lung, breast, stomach, colorectal, and bladder, which together they make up for more than half of our cancer burden. Next slide, please. So, as I just showed you, Globocan gives us an overall picture of Albania's cancer burden, but those numbers actually are only modeled. They are not collected, and this brings me to the next point. When we look at the national reports, the picture becomes even more complicated. Here on this slide, you see two sources side by side. On the left, again, are the Globocan 2022 estimates. And on the right, you see the most recent national report from the Institute of Public Health, which covers the years from 2015 to 2019. And what you notice immediately is that the numbers don't fully align. Some cancers appear underreported, others vary widely across years, and kidney cancer in particular is not consistently captured at all. And this is what I mean when I say that the burden cannot be fully measured. Without a proper registry, we are left with partial data from hospital admissions mainly, or with international estimates that may not reflect actually our reality, like Globocan. So for kidney cancer, this gap is especially problematic. I mean, it is a cancer with survival potential, and yet in Albania, we cannot quantify how many people are living after their diagnosis, what their outcomes of treatment are, what are the needs of this patient that are living with cancer, or those that survive the disease. And Albania, and again, I think that Albania is not unique in this. I think that many countries at a similar stage of health system development, many low and middle income countries, actually face the same challenge. But the consequence is clear here. When data are incomplete, patients become invisible in the statistics, and then health systems cannot plan for the care of these people. Next slide, please. And so in this slide shows us the cancer survivorship landscape across Europe. In women, breast cancer dominates survivorship, and we know that, and in men, prostate cancer. But notice the kidney cancer is also consistently visible among the cancers where patients are living for many years after diagnosis. And this is an important message, because kidney cancer is a disease with a survival. But survival cannot be assumed, it must be measured. And without this reliable data, actually we cannot know whether patients with kidney cancer in Albania achieve the same outcomes as those in other European countries. Next slide, please. So you can clearly see that survival extends well beyond the 10-year mark. In fact, a substantial proportion of patients in Europe are living more than a decade, and some even 2 decades after their diagnosis. And I think that this is a powerful message, because kidney cancer, as I said, is not only a survivable disease, but now it is where long-term survivorship is increasingly the norm. And for Albania, and I think also for similar low and middle income countries, this has direct implication. If patients elsewhere in Europe are living 10 or 20 years with kidney cancer, then the absence of survival data in our country leaves us blind, I'd say. We cannot know whether our patients benefit in the same way or whether they are missing out. So without collecting and analyzing survivorship data, we cannot close this gap. Next slide, please. So this figure here highlights the difference between regions that broadly reflect income levels and health system capacity. So in high income areas, such as, for example, North America, Australia, or Northern and Western Europe, incidence of kidney cancer rates are high, over 9 to 12 per 100,000 people, but mortality rates are proportionally lower. This indicates that although kidney cancer is more frequently detected in these regions, survival outcomes are better. And this might be likely due to earlier diagnosis with all the widespread imaging and also access to modern therapies. In contrast, in many low and middle income regions, including Albania here, incidence appears lower, often between 1 and 4 per 100,000 people. But mortality is almost equivalent to the incidence. And these patterns suggest limited survival gains, either because cases are diagnosed at later stages or because access to effective treatment is restricted. So I think that these data follow a recognizable epidemiological pattern. So higher incidence with better survival in higher resource regions, and lower reported incidence but poor survival in resource limited settings. Next slide, please. So here are the main risk factors for kidney cancer and how they relate to opportunities for prevention. And so at the top, you see the non-modifiable risks, such as genetic predisposition, which we, of course, cannot change. In the middle are the secondary risks, like chronic kidney disease, prior acute injuries, certain medications, and other renal conditions, where vigilance and monitoring are important. And then at the bottom are the modifiable risks, like obesity, diabetes, smoking, hypertension, occupational exposures. These are the areas where primary prevention is possible, and I think by addressing them, we can lower the population risk of kidney cancer over time. So the structure here is simple. Non-modifiable risks remind us of the inherited suspectability, and then secondary risks highlight the role of renal health, and modifiable risk are when public health interventions and prevention efforts can make the biggest difference. Next slide, please. And all of these risk factors, smoking, obesity, diabetes, and hypertension, are all on the rise in Albania. Smoking rates remain high, especially among men. Obesity and overweight are steadily increasing, particularly in younger age groups. Diabetes prevalence has nearly doubled over the past 2 decades, with a third of the cases still undiagnosed. And hypertension is widespread, but very poorly controlled, with fewer than 1 in 10 patients achieving adequate blood pressure management. So taken together, this means that the underlying drivers of kidney cancer are becoming more common in our population. And although current incidence appears relatively low, the expectation is that with these risk factors, trends, kidney cancer incidence in Albania may increase in the coming years. Next slide, please. And so we know that that the incidence rate will increase for kidney cancer, and this is the case for many countries worldwide, but the challenge does not stop here. Early diagnosis remains a problem across all cancer types in Albania, and I think also in many other low and middle income countries. So specialized services are usually concentrated in Tirana, in the main oncological center, and patients from remote regions face significant barriers in accessing that care, from long travel distances to delays in referrals. So as a result, many cancers, including kidney cancer, are often diagnosed at later stages, when curative treatment is less effective and sometimes not even possible. So these images that you see here actually are from Albania. Theth is a mountain village in the north, and Saranda is a coastal city in the very south of the country. Both are several hours away from Tirana, where the country's main cancer center actually is main cancer center is located. And for patients actually living in these regions, accessing care can mean a 4 or 6 hour journey each way. So while these places actually look like beautiful travel destination, and they are beautiful, for cancer patients that live in these regions, they represent distance, isolation, and barriers to timely diagnosis and treatment. So this distance and this isolation make early diagnosis a real challenge, because patients often delay seeking care, they miss their follow-ups or present at an advanced stage. And this combination, the rising risk factors and systemic delays in diagnosis, suggest that without targeted intervention, both incidence and mortality from kidney cancer are likely to increase. Next slide, please. So one of the strategies to address this in Albania has been the decentralization of the oncology services, which officially began in 2017. So the idea was to bring systemic treatments closer to patients' home by setting up infusion centers in several counties. And today, actually, 9 out of 12 counties do have these oncology services, but Tirana, the capital, still manages more than a third of all new cancer cases, and all these regional centers remain limited in what they can actually offer. So, in practice, decentralization has emphasized geographic spread rather than building functional capacity. For kidney cancer, this has a very specific implications. Because diagnosis often requires imaging, pathology, multidisciplinary input, while treatment involves surgery, systemic therapy, and follow-up. These are services that most regional centers cannot yet provide, which means that despite decentralization, patients with kidney cancer still depend heavily on the main oncology center located in the capital city. Next slide, please. And as you can see here, shortly summarized, regional oncology units in Albania provide only limited services. They can manage some systemic treatments for some type of common cancers, but they lack access to multidisciplinary teams, to molecular testing, to radiotherapy, to specialized surgery. Importantly, they cannot deliver targeted therapies or immunotherapy. And this means that even for oral treatments, such as TKIs, for example, patients must still travel to the main hospital in Tirana, adding delay here, cost, and sometimes burden to care. Next slide, please. And actually, we know that cancer care is a cumulative process. This is what a comprehensive cancer care pathway should look like, a team effort that brings together oncologists, surgeons, pathologists, radiologists, specialist nurses, psycho-oncologists, nutritionists, and many, many others. And for kidney cancer, this integration is critical. Surgery, systemic treatment, and supportive care need to be connected. But in our setting, most of these services are either missing or only partially available. And patients must see their oncologist or just a surgeon, but they rarely have access to molecular pathology, psycho-oncology, or structured palliative care. So the pathway is fragmented, and the reality is that we're trying to cover the journey from point A to B, actually with too many gaps in between. And one of the main reasons for this, of course, we all know, it's funding. The resources simply don't match the complexity of what cancer care requires. Next slide, please. And what you see here is that the patient numbers treated in these regional hospitals have been steadily rising across the country, but budgets have not increased proportionally. In some cases, budgets have even decreased while patient loads have grown. This creates a structural mismatch because services expand geographically, but the financial support to maintain quality and capacity does not follow. So the results is increasing pressure on regional centers, risk of compromised care, and growing inequities in access to treatment. So for kidney cancer in particular, in the advanced stages, where effective management depends on systemic therapies that are costly, this funding gap becomes a critical barrier to timely and adequate care. Next slide, please. And when it comes to treatment, actually, these figures show how the treatment landscape for renal cancer carcinoma has expanded over the years. So globally, we now know that we have multiple TKIs, and more recently, we have immunotherapy and combination regimens that in many cases have transformed outcomes. But in Albania, however, the reality is much more limited. The drugs circled in red, like sunitinib, you see here, pazopanib, sorafenib, and everolimus, are the only options that are reimbursed for advanced disease. And beyond this, newer TKIs or immunotherapy combinations that now represent the standard of care in high-income countries are simply unavailable through the public system. And this has actually a major implication for patients' care. So once patients progress after these few reimbursed treatment lines, they are left with no publicly covered alternatives. So access to newer therapies depends on paying either out of pocket money or having private insurances, which is not the case for everyone. And as a result, while internationally kidney cancer has become a disease with significant improved survival, in Albania, outcomes remain constrained by limited access to the full treatment arsenal. Next slide, please. So I want to close with this message. Kidney cancer today is a treatable and increasingly survivable disease, but that survival depends on three essential pillars: timely diagnosis, access to multidisciplinary care, and availability of the full spectrum of therapies. And in Albania, as in many, I mean, this is a message actually, in Albania, as in many low and middle income countries, each of these pillars is still, I'd say, fragile. We lack reliable data. Our patients often face delays in diagnosis, and treatment options are definitely limited to just a few reimbursed drugs. And this means that the survival, which should be possible, too often actually remains out of reach for our patients. So the challenge before us is definitely clear. We need to strengthen our system so that every patient, regardless of where they live or what resources they have, they can benefit from the progress that kidney cancer care has achieved globally. Because at the end of the day, I think that science has made a lot of progress. What is missing actually is making sure that our patients can actually access it. Thank you.
Thank you so much, Dr. Mate, for a great presentation and sharing your insights about Albania. So we will move our next speaker. Please join Dr. Eva Nicholas from Croatia, medical oncologist at University Hospital Center Zagreb. Dr. Eva, we will go live now, so please join.
Hello, hi. Can you hear
Hello.
me?
Yes, great. Everything is fine. Can you share your screen?
Mm-hmm. One moment.
Yes, of course.
Can you see it now, maybe?
We can't see it. Yes. Okay, but we see only the email. Can you change to a presentation?
I will try to change it to my PowerPoint presentation and start it. Now, okay?
No, we can't see the presentation.
You can or you cannot?
No, we cannot.
No? Okay, can you please do it centrally?
Now we can see it. Can you just reshare again? Just switch it off and switch the presentation and share once you already see the presentation on your screen. So maybe it will work out.
Okay, let's try again. Sorry.
No problem.
Okay, maybe this one better.
No, we can't see your presentation. Now I will just switch off sharing a presentation mode.
Mm-hmm. Okay, I stopped the share.
Okay, and can you open the presentation on your computer now?
Yeah, it's open, of course.
And reshare your screen again.
Okay.
Yes, but we cannot see your presentation yet.
Okay, I will try to set the presentation now. Do you see it now?
Not yet.
No. Okay, I think we will have to do it centrally. Is it possible to do it?
Centrally, you mean? You can send us your presentation.
Yeah, of course, I already did. Can you please?
Yes, of course. Just give us a minute.
Okay, sorry.
No problem. We will move to our another speaker, Bayal Kapoor, Professor of Pathology at UT Southwestern Medical Center. Unfortunately, she is not live now, but we will listen her per recording. And then after that, we will move back to Eva Nicholas, Dr. Eva Nicholas. Thank you so much.
Hello, everyone. I'm delighted to join you today. My name is Payal Kapoor, and I serve as a professor of pathology and urology at UT Southwestern. I want to thank Dr. McKay and Dr. Ürün for this invitation. So while clear cell RCC dominates our field, more than a quarter of renal tumors fall in the non-clear cell category, as shown here. These include papillary chromophobe oncocytic tumors, among others. Recognizing this diversity is essential as management and prognosis can vary quite significantly. Historically, anything that was not clear cell has been lumped into this vague term of variant histologies. But this became problematic since variant was used both for morphologic patterns and also for genetic alterations. To reduce confusion, the 2022 WHO classification deliberately replaced variant with subtype, reserving variant strictly for genetic alterations. Other terminologies such as distinct RCC subtypes and diverse RCC subtypes could also be used. Shown here is this expanding advanced taxonomy of the new WHO book, highlighting our growing understanding of the morphology and molecular diversity. We now have a molecularly defined renal carcinomas. Few changes have been made to the nomenclature and highlighted in green here, and several new entities highlighted in red have been recognized. In this talk, I would like to highlight some of these changes, starting with the oncocytic or eosinophilic tumors. So almost a decade back, in a comprehensive genomic analysis of primary non-clear cell RCC, we had noticed some renal tumors, which at the time we had classified as eosinophilic chromophobe clusters separately, and all had activating mTOR mutations. We now know that these tumors are a separate entity, now classified as low-grade oncocytic tumors. Morphologically, these tumors are very unique and shown here, closely resemble eosinophilic variant of chromophobe. However, they lack the nuclear membrane irregularities and only focally show perinuclear clearing. Sharp edematous stromal areas, as shown here, can be seen, and they have this characteristic IHC pattern with CD117 negative and diffuse strong CK7 positivity, which can really help make the diagnosis. Using whole transcriptomic analysis, we found that lots are tightly clustered together, shown in red, away from oncocytomas and chromophobe, and even away from those chromophobes that have mTOR pathway mutations, shown in the black boxes, supporting its recognition as a separate entity. And as shown also in this heat map, where lot have a diffuse gene expression signature different from eosinophilic variant of chromophobes, which are its closest morphologic mimics. We and others have reported that lots are frequent in older men and generally of lower stage. No metastasis has been documented thus far, with almost over 100 cases reported. They frequently occur sporadically, but also frequently in association with end-stage renal disease, and sometimes also in TSC syndromic patients. Sequencing analysis of these tumors found that almost all of them have a pathogenic mutation in mTOR pathway genes, as shown here. Sorry, this is, whoops. So the structural model analysis which we conducted showed that mTOR gene mutations were indeed activating, and also consistent with the observed phospho-S6. But this activation was overall low, as shown here in the schematic, and also by the low phospho-S6 expression. Copy number analysis failed to reveal chromosome 1 loss in tumors with mTOR mutation, suggesting that wild-type mTOR protein may play a role. And this is quite different from another newly recognized entity, eosinophilic vacuolated tumors, or EVTs. Clinically, EVT and LOT are quite similar in that both are small tumors These can occur sporadically, but also in TSC patients. And to date, no aggressive behavior has been reported. They also have inactivating mutations in TSC2 and or in mTOR genes. However, in contrast to LOT, these patients lose the other mTOR allele with the loss of chromosome 1, as shown here, result in significant phospho-mTOR pathway activation and demonstrated by the strong diffuse phospho-6 ISC in this representative case. Morphologically, they're quite distinct, have characteristic cells with this intracytoplasmic vacuoles, these large nuclei with prominent viral inclusion like nucleoli. However, the IHC pattern is quite non-specific, similar to oncocytomas. So at the other extreme of this spectrum of pink tumors are dedifferentiated chromophobe, which can behave in a very aggressive manner. Sorry. So we interrogated our institutional kidney cancer database and found 204 patients diagnosed with chromophobe with available tissue in our institution, of which 15 developed metastasis to lymph nodes and distant organs, roughly 7.5%. We found that these aggressive chromophobes were significantly larger. All of them had necrosis, and 50% had sarcomatoid change, and all were of the classic chromophobe subtype. So we reviewed various slides and found focal dedifferentiation in majority of these cases. And interestingly, found 3 patterns of morphologic dedifferentiation: sarcomatoid, anaplastic, and glandular. Glandular dedifferentiation has not been reported before. When we reviewed the samples from their paired metastasis, we found that 70% had only the dedifferentiated component, even though the dedifferentiated component was less than 25% in the primary tumor, suggesting that dedifferentiation component is the more likely clone to metastasize. In all cases, the transition from classic to dedifferentiation was markedly abrupt, as shown here. On the left is dedifferentiation, while the more classic on the right. CD117 and CK7, these are markers we routinely use for diagnosis, and also are shared with their putative cell of origin, were lost in the dedifferentiated areas. Now, this can be a problem for diagnosis, especially in metastatic setting without a known history, or when the entire primary is replaced by the dedifferentiated component. In the cases that lack dedifferentiation, on closer evaluation, 3 of the 5 exhibit focal nuclear atypia, as shown here, which was much more striking in the metastatic sample. And in 2 cases, we did not find atypia or dedifferentiation. However, in these 2 cases, we had very limited sampling and no metastatic samples. To gain insight into molecular underpinnings of this dedifferentiation and metastasis, we investigated genomic features from paired classic and dedifferentiated or atypical areas from both the primary and mets, and these included around 24 samples from 11 patients. And as expected, the classic components had the characteristic non-random losses of chromosomes 1, 2, 6, 10, 13, and 17, as shown here. However, in the dedifferentiated component, surprisingly, we found chromosomal amplifications meeting the definition of whole genome doubling. In all samples, irrespective of primary or from MET, suggesting that chromosomal duplication accompanies dedifferentiation and precedes metastatic development. We found that de novo somatic p53 mutations in all patients who developed dedifferentiation or atypia, except for 2, all of which showed protein stabilization as assessed by IHC. In every instance, the same mutation was observed in the corresponding classic and dedifferentiation sample. Overall, these data suggest that p53 mutations arise in classic and precede the development of atypia and dedifferentiation. Further, we found PTEN mutations solely in the dedifferentiated and atypical areas. Given that PTEN functions in a as a negative regulator of the mTOR pathway, we performed IHC for phospho S6, a marker of mTOR C1 activation. Notably, increased phospho S6 was observed in all dedifferentiated samples, irrespective of the type of morphologic dedifferentiation. And as shown here, the adjacent classic areas were largely almost completely negative. Differential expression gene analysis showed clustering based on the corresponding histology, and those with atypia without frank dedifferentiation clustered in the middle, shown in orange here, leading us to speculate that it may represent an intermediate stage of tumor progression towards dedifferentiation. Gene set enrichment analysis demonstrated enrichment for EMT, cell proliferation, as well as mTOR pathways in the dedifferentiated component. We performed UMAP analysis and found that dedifferentiated chromophobe cases clustered together, showed in red here, far away from their paired classic component, showed in green here, from which they arose, and in proximity with clear cell RCC with sarcomatoid change. Overall, these findings suggest that dedifferentiated chromophobe shared gene expression with other sarcomatoid RCCs, suggesting a convergent evolutionary trajectory. These data led us to speculate the order of events that likely lead to dedifferentiation aggressive behavior in chromophobe. Classic chromophobe express their cell of origin markers, c-KIT and epithelial tumors, and are characterized by the known chromosomal losses, de novo p53 mutation, and subsequent mTOR pathway gene alteration results in chromosomal gains and activation of mTOR pathways and result in dedifferentiation phenotypes and aggressive behavior. I'm going to switch gears to tumors with papillary architecture. Papillary RCC has traditionally been categorized into type 1 and type 2 because of its prognostic implications. With current better understanding, many of the type 2 papillaries are now recognized as separate entities. After removing these entities, nuclear grade remains prognostic, and therefore the new WHO type 1 RCC remains as the classic papillary RCC, and subtyping into type 1 and type 2 is therefore not recommended. In the remaining part of the talk, I'll just briefly talk about some of the new entities. So one such entity, which was in the prior type 2 papillary RCC, is eosinophilic solid and cystic, or ASC RCC, now recognized as a distinct entity. The great majority are sporadic, though can be seen in the TSC familial setting. Also, most of these are females, and they can also occur in pediatric age group, where translocation RCC is the differential and a close morphologic mimic. They consistently demonstrate biallelic mutations in TSC2 and TSC1 gene, result in the activation of the mTOR complex 1 signaling. Most cases, however, have an indolent behavior. The rare tumors with METs have been reported, and complete response with rapalogs have also been documented. Morphologically, they're quite characteristic. They have a solid and cystic component. The cyst typically have cells lining in a hobnail arrangement. The solid parts are composed of eosinophilic cells, as shown here with coarse cytoplasmic stippling. Unlike most other RCCs, ASC tumors are positive for cytokeratin 20, either diffusely or focally, as shown here, which can be a very helpful marker. Another newly recognized entity is ELOC-mutated RCC. These are really rare tumors and characterized by recurrent hotspot mutation in the ELOC gene and loss of the other allele, typically through loss of entire chromosome 8. ELOC encodes for elongin C, a component of the VHL E3 ligase complex, resulting in accumulation of HIP1 alpha. Majority of these tumors are reported to have an indolent behavior, though few cases with mets and aggressive behavior have been reported. To make a diagnosis of ELOC-mutated RCC, one needs to do molecular analysis. And this is because their morphology, though characteristic, overlaps with a number of other entities, such as TSC-associated RCCs, even clear cell RCC, and clear cell papillary renal cell tumor, which is a benign entity. And therefore, descriptive terminology of RCC with fibromyomatous stroma has been proposed in the absence of confirmatory molecular results, as shown here. However, these tumors almost uniformly have strong CK7 staining, which can sometimes lead to the diagnosis and for obtaining further NGS analyses. In the new WHO, translocation RCC has been separated out from or separated into two entities, TFE3 rearranged and TFE-B altered. Though a large number of TFE3 fusion partners have been recognized to date, we do not fully understand the clinical implications of these partners. Our current understanding suggests that gene fusions with ASPL confers a worse prognosis, while SFPQ and MET15 a more indolent course. Irrespective, these are very aggressive tumors with metastasis observed within 2 years in almost 50%. These are typically diagnosed with FISH assays. However, the conventional TFE3 break-apart FISH assay cannot detect breakpoints resulting from paracentric inversions involving XP11, and this results in false negative FISH result that could be seen as many as 18% of TFE3 RCCs due to these cryptic fusions involving genes listed here. And in this setting, NGS analysis could nail the diagnosis. TFE-B altered RCC now includes two entities, the typical TFE-B rearranged resulting from 611 translocation and fusion of TFE-B gene with MALAT1 and overexpression of the native TFE-B gene. The new subgroup included in this is the TFE-B amplification RCCs with amplification of the 6p21 locus harboring the TFE-B gene and resulting in its overexpression. These tumors are typically diagnosed by FISH and unlike TFE-B rearrange occur in older age patients with more advanced stage. Unfortunately, they can be quite hard to diagnose as they don't have a characteristic morphology or IHC pattern, but have an aggressive clinical course. Another entity, ALK rearranged RCC, which was previously emerging entity, is now recognized as separate entity. It is characterized by ALK gene fusion with various partners, leading to ALK activation. It has been reported in patients with a wide age group and diverse racial background. Notably, they're notable for their potential responsiveness to targeted ALK inhibitors, illustrating this therapeutic relevance of precision classification. HLRCC is another entity that's critical to recognize, not only because of its aggressive nature, but also because of its association in a syndromic setting. It is now recognized that biallelic somatic FH alterations can be seen in patients who do not have a personal family history of HLRCC. And therefore, in such settings of uncertain clinical or family history and also unknown genomic status, the WHO recommends using the terminology of FH or fumarate hydratase deficient RCC. Both FH and HLRCC are largely same and have absence of FH reactivity by IHC and have very similar morphology, the most striking of which is the presence of this cherry red inclusion-like nucleoli, which could sometimes be present only focally. Likewise, RMC carry a dismal prognosis. These tumors uniformly show loss of nuclear expression of SMARCB1 protein, and therefore have now been renamed as SMARCB1 deficient renal medullary carcinomas for tumors that occur in patients with hemoglobinopathies. And typically these patients are young African Americans with sickle cell trait. In patients without hemoglobinopathies, the tumor may be referred to as unclassified RCC with medullary phenotype. And it's also noteworthy that SMARCB1 loss can sometimes be seen in other recognized RCC types such as FHRCC, where it may represent a secondary event. These tumors underscore the importance of integrating clinical context, morphology, and molecular testing. I want to close by acknowledging my colleagues in the kidney cancer program, our clinical and pathology collaborators, my lab team, and thank you all for your time. I appreciate it.
Thank you, Dr. Kapoor, for a great presentation. And we will move to Dr. Eva Nicholas, medical oncologist at University Hospital Center Zagreb. Once again, we will... Oh, Dr. Eva hasn't joined. I am sorry. We will have 1 minute break till Dr. Eva will rejoin again. Dr. Eva, since we are back, we are here to welcome you. We will share screen and we can start. Thank you so much.
Okay. I had some issues with the connection. I really hope it will be everything okay. So I think we can start with the presentation.
Yes, of course. Everything is fine now.
Okay. So hello to everyone. It's evening here in Croatia. My name is Eva Nicholas and I'm a medical oncologist and I specialize in GU cancers at the Hospital Center in Zagreb. I'm very pleased to be here and to give the talk about current state of renal oncology in Croatia. Can we do the next slide? Just a brief background about Croatian geography and population. We are mainly recognized as a central or Southeastern European country. It differs on the view. We are part of the EU since 2013, and it has been in our favor. Currently, Croatia is about 3.8 million people. Can we do it next? Next slide. And the latest data shows that we have accrued yearly incidence of new cancer cases about 670 per 100,000. In absolute number, that would be around 26,000. Of that, renal cancer, we have reached a number of new cases per year around 950, and we have observed a male to female ratio in incidence about 2 against 1. Renal cancers account for about 5% of all malignant tumors in men in Croatia. Please, next. Just to give a brief overview of Croatian healthcare system, it is quite complicated and the detail are out of scope of this presentation, but it is important to know that it is a public system. It is funded throughout taxes. Every citizen of Croatia is giving from his gross salary about 15% of his gross salary to the healthcare system. On the other side, the Croatian healthcare system is available to every resident, and it is mainly funded through National Croatian Health Insurance Fund. As for the private insurance companies, there are only a few, and only few people are actually eligible to be a private, to have a private insurance. In the picture, you can just see the maybe a bit detailed organization of Croatian healthcare system, from primary care accounting for GPs and primary gynecologist and primary pediatrician and primary laboratory work. Then in the secondary care, we have general hospitals, and tertiary care are university clinics and clinical hospital. Of course, up on the top is public health. Can we do next one? So, just to have a brief overview of how oncology care in Croatia is, how we manage to do the oncology networks, we have, regarding this relatively small amount of people who actually live in Croatia, we have a population about 3.8 million. We do have 63 hospitals, and oncology care is available only in hospitals and in form of in- and outpatient clinics. Out of those 63 hospitals, only 20 do provide oncology care, and some of them are general hospitals, some of them are clinical hospitals, and university hospital clinic and university hospital centers. Unfortunately, only some hospitals have a site designated oncologists that are designated to renal pathology. On the other hand, apart from these public hospitals, a few private hospitals that also take share in oncology care in Croatia, and they are partly funded by national insurance. For example, for SBRT services, for some radiotherapy services, but they are not funded for systemic treatment. Next, please. Availability of systemic treatment is mostly dependent on National Insurance Fund. Indications from National Insurance Fund for reimbursement or refundation for the medicines, they do not always align with EMA or FDA or trial indications. Fortunately, the EU membership have grossly contributed to treatment availability in Croatia. Next one. Most patients, regardless if they are treated in general hospital or in clinical hospital setting, they are discussed in MDTs. not as in many Western European countries, MDTs are not mandatory. MDTs are not mandatory, but we do actually try that every patient goes through MDT discussion. MDTs are mostly in clinical hospitals and university hospital centers, so patients often get referred to our centers. Out of note is that MDT discussion is absolutely mandatory for starting and continuing immunotherapy treatments. In post-pandemic time, we have tried to find a new way to offer colleagues from general hospitals help. So we do offer virtual MDTs, especially in Uro Oncology, please. Available medical and nephron-sparing surgery. Those are mostly open access surgeries, and laparoscopics and robotic-assisted surgeries. They do happen, but only in clinical centers. We do also have minimal invasive treatments available in bigger hospitals. Next, please. As I am medical oncologist, my focus is systemic treatment, and I am proud to say that we do have pembrolizumab fully reimbursed in adjuvant setting for clear cell RCC. I can tell that being a part of European Union has mostly contributed to this. Next, please. Also, in the metastatic setting, we do have available and fully reimbursed most of the treatments. For example, IO combination, so ipilimumab and nivolumab in the first line, sunitinib, pazopanib, the old TKIs also in the first line, and the second line, of course, nivolumab, cabozantinib, axitinib, or older TKIs and older therapies are fully reimbursed and available to all patients that do need them. It is of note to say that the beginning of immunotherapy treatment is mandated to be in a clinical hospital setting. Next. And in the end, I will just like to address a few challenges that we have in our everyday practice. For about a year and a half, we are extremely short-staffed regarding the number of nurses and technicians. Our nurses are not formally specialized to be specialized in oncology care providing nurses. In some sites, we do have oncologist deficit and major pathologist shortage. Unfortunately, Croatia is a central or southeastern European country that has quite low penetration of clinical trials. And unfortunately, we do not have IO-TKI combinations available for now for reimbursement. Also, the one problem that is affecting me as an oncologist and also my patients and the further development of renal cell care in Croatia is that we do not formally measure outcomes in oncology, not only in renal cell setting, but also throughout the whole malignant tumor settings. So I would be glad if anyone has any questions to answer it. And apart from that, thank you for your time and your attention.
Thank you so much, Dr. Eva, for a great presentation and insights about Croatia. We will move our next speaker, cancer survivor Sid Seller, and listen the fight and the role of advocacy. Sid, we will share yours. We will now. Great. So we can start.
Yeah, definitely. I'll be sharing my screen, right?
No, we have your presentation, so we will do it.
Perfect. All righty, guys. I appreciate it. All right. So first of all, I want to thank everybody, on the chair, everybody on the board for having me here and speaking today. It's a great honor So today I'm going to be talking about the fight and role of advocacy, communications coordinator, and kidney cancer survivor. We can move on to the next slide. All righty. So a little bit about myself. I'm 34 years old. I was born and raised in Nashville, Tennessee. If you're not familiar, it's nice and sunny here today. It's about 1 o'clock in the afternoon. So we're enjoying some great weather here. My background was working in communications, marketing, in the nonprofit sector, specifically in social media. So advocacy kind of came a little bit easier to me, I think, just because I had that background. My wife also works in the medical field. She was a former ICU nurse, and now she's a nurse practitioner. So I count myself very lucky that I have a spouse and a partner that has that background. Back in 2020, we bought a house, which was perfect timing for the market. We got very lucky. And we decided to start talking about the idea of starting a family kind of in 2020 as well. We can move on to the next slide. There we go. So life happens fast. This is actually my original CT scan. If you guys can see it right here circled, I'm sure many of you are familiar with CT and MRI scans. You can see right there, there is a very large tumor on my left kidney right there. I had no symptoms on the onset except for hematuria. I woke up one morning, I couldn't really urinate, and I passed some blood clots, and we obviously thought maybe it was kidney stones, maybe it was something weird like that. But I wound up going to the ER. They actually sent me home with no scans. And then I wound up contacting my PCP, my primary care physician, the next day. And he actually sent me off for some scans, and that revealed that 10.5 centimeter tumor right there on my left kidney. From there, I actually connected with a couple of advocates that were rock stars in the space, and they led me to be seen at Vanderbilt University in Nashville, Tennessee, Vanderbilt Medical Center. From there, I met with Dr. Brian Rennie, who quickly referred me. After I got some more scans done, we saw that there was no metastatic spread. So he quickly referred me to Dr. Sam Chang, who is a urological oncologist at Vandy. And from there, we decided that a left radical nephrectomy is what was needed. And thankfully, he was a specialist in robotic surgery. So that was the decision that was made, was going to be robotic surgery. Now, if you guys can tell from the scans there a little bit, my tumor was actually attached to the tail of my pancreas and a little bit of my spleen. So there was questions on, while this isn't a metastatic disease that we're looking at currently, there was questions about what was going to happen once they got in there. But thankfully, just the tumor and kidney needed to come out, and I was officially diagnosed with stage 2B grade 2 clear cell renal carcinoma. I actually just had my most recent scans about a week and a half ago. Those came back clear, so I'm very happy to report that I'm still just on active surveillance, and we're going to be doing that for at least up to 5 years, and we'll make a plan after that. But the point of this is, where does that leave me after a diagnosis like this? Where do patients move on after a diagnosis? And I'm going to get into this a little bit later, but some patients decide to go into advocacy. Some patients decide to kind of sit back and try to kind of move on with their life. And I'm going to try to talk about how there's an intersection between both of those, and why patients choose those, and also the tools that patients use to move forward in advocacy. We can go to the next slide, please. So what is advocacy? I think when a lot of people think of advocacy, they think of lobbying, right? They think of talking to lawmakers. They think of contacting local representatives, talking about bills and spending. And I don't have to explain to any of you guys right now, at least the current climate in the United States. There's lots of talk about funding for cancer research and the current threats that could be happening to that funding. That is one important part of advocacy. But advocacy also includes these other things as well on this list: storytelling, amplifying voices, mobilizing communities, and listening. When we're talking about storytelling, it's kind of a little bit about what my background was in social media and communication. So it's telling the patient's story, the caregiver story, the family story. I think a lot of times when we think about storytelling, we think of just the cancer story, like what I gave you guys at the beginning of the presentation. But it also encompasses the family. It encompasses the partner, the spouse, the kids, for instance. Amplifying those voices. A lot of times when patients are diagnosed, they might not be in major metropolitan centers. They might be kind of out in the middle of nowhere, where there aren't many organizations to kind of amplify those voices. Thankfully, since we are in the age of technology, it's a lot easier to amplify those voices now than it might have been 20 or 30 years ago. When we're talking about mobilizing communities, we're talking about working with organizations in the space. I've worked with organizations such as the Kidney Cancer Association or Kidney Can or KC Cure, and getting connected with those organizations to connect with other patients, connect with lawmakers, and connect with people in the field to continue on throughout your advocacy journey. And then lastly, listening. When we're talking about listening, I'm talking about not only doctor to patient, patient to doctor, but I'm talking about patient to patient or patient to caregiver or caregiver to caregiver. These things are really important to remember. And I've always been a believer that listening can do wonders, not only for a doctor and for a patient and for a caregiver, but when they all intersect and everybody is listening, I think better decisions are made for the patient and better outcomes are seen. We can go to the next slide, please. So when we were thinking about advocacy, I kind of broke it down into 3 different levels. It was a lot easier for me to understand this when I broke it down like this. So I think when we're thinking about advocacy, most people think of the personal level, right? Supporting the individual needs, whether it's the need for comfort or the need for reassurance or love. Any of those basic needs that we think about when a patient is diagnosed, we do think about those personal needs, and those are very important. But we also want to think about community needs as well, raising awareness. I'll say personally, before I was diagnosed, I knew very little about cancer, let alone kidney cancer. So raising that awareness where my neighbors, my family, my friends start at least understanding the basic concepts and what goes into cancer awareness. And then with that awareness comes raising those funds, getting research done, getting more clinical trials out there to obviously see better outcomes for patients and their families. Systemic change. Now, at the beginning, when I talked about, obviously, advocacy is a lot of different things, but lobbying is one of them. And when we're talking about systemic levels to advocacy, we're talking about changing laws and funding sources. Like I said earlier, there's been much talk about funding levels and funding for cancer research currently in the States. And this is one of those important things right now where patients and caregivers have to be able to come together with doctors, not only the doctors that they're being treated by, but other doctors in the field to come together to voice their concerns about why this funding and why this research is so important to the field. We can move forward. So, why do this, right? That's a silly question, but it is a question though. Why do this? Well, first of all, it puts a face with the disease. So before I was diagnosed, I didn't know that many cancer patients, to be frank with you. I didn't know many, some distant family members, but I didn't know kind of what the disease encompassed, right? I think I've told patients and doctors this, TV and movies have not done a great job about showing exactly what cancer is and what it encompasses. When you think of cancer, I think a lot of people that haven't been touched by cancer think of the classic TV show or movie show or movie that's out there where there's a dying patient who might be extremely frail and losing their hair and this and that. And as we know on this call, kidney cancer does not respond to traditional chemotherapy, and the treatments are very different than a lot of other treatments out there for cancer. So I think putting a face with this disease makes it a little bit more personal. And that also kind of bleeds into challenging those societal stigmas. When I tell people that I was diagnosed with kidney cancer, if they know nothing about cancer, a lot of people are like, "Oh, are you on chemotherapy right now? Or did you have to do this? Or did you have to do that?" And I think I've tried to do a great job, or at least I think I've done a great job about showing that cancer is on a multitude, plane and different levels, and that it's not always what people think it is. Drives change, and driving change leads to saving lives, right? So challenging these stigmas leads to driving that change in the field, whether it be new clinical trials, funding for junior researchers or doctors in the field. Those things drive that change. And then at the end of the day, that's going to save lives. I don't think I have to tell you guys that obviously in the last 10 or 15 years, the research and new drug development for kidney cancer has exploded. And I hope and I think that that's going to continue on down the line as long as we continue to advocate. We can move to the next slide, please. So the tools, these are tools that not only patients use, but also doctors can use too. I think when we use the word advocacy, we think of just patients, but doctors are obviously very welcome. And we hope that doctors welcome us to the table as well when we're talking about advocacy. So I mentioned storytelling earlier, but I want to talk a little bit about partnerships as well. So with partnerships, we think of partnerships as a one-on-one transaction, right? Well, with patients, especially when we're talking about a patient that's been diagnosed, we're not only talking about a partnership with a doctor or with a researcher, but we're also talking about partnerships with organizations organizations, like I mentioned earlier, the organizations I've partnered with, putting a face to that disease and that partnership can lead to not only better outcomes for that patient, but also allows that patient to bring in other patients that are newly diagnosed, whether it be to an organization that might know about a clinical trial in a different state, or to a doctor that might be on the medical board for that organization. It leads to greater outcomes for these patients. You're going to continue to hear me say better outcomes for patients from advocacy. Digital advocacy. So this is something I obviously have a strong background in. So when I was first diagnosed, or I should say after I was diagnosed and after I had my surgery and official diagnosis, I went in and I created an Instagram page that used a little bit of humor, but also utilized it to kind of reach out to patients and be able to connect patients with other organizations or even other doctors. Even last week, I had a patient that was newly diagnosed, and they were actually a young adult like myself. And I reached out to them, and they were asking me about different organizations in the space and who to kind of get plugged in with. Lastly, policy engagement. So when we're talking about policy engagement, I think a lot of advocates get a little bit scared about doing this, whether it be contacting your lawmaker or contacting someone else that's making these decisions when it comes to funding for cancer research, or specifically kidney cancer research. And that policy engagement is extremely important, because a lot of time these lawmakers, and I'm sure some of you know this, lawmakers, they have a busy day, right? They have a list of things that they're going through, meetings that they're going to. And at the end of the day, if we can't put a face to this disease, whether it be a doctor and a patient, especially when it's a doctor and patient together, putting a face to that disease does drive that change, as I mentioned earlier. So that policy engagement, not only for the patient, but for the caregiver and for the doctor, those partnerships do lead to policy change. And it might be slow. I'm not here to say that it's something that's going to happen overnight. I think we all know that laws don't get changed overnight. But if you are persistent and you keep putting a face and a story with that diagnosis, it does drive to policy change overall. We can move to the next slide. So there's always going to be challenges, right? If this was easy, I don't think we would be having this conversation. But one of the biggest challenges that advocates face in the space is feeling unheard in the medical system. I think we've heard countless stories about, oh, somebody went to the doctor and it might have been brushed off because maybe they're too young for cancer, or maybe it's anxiety or this or that. I think the tide is shifting a little bit towards that not being the case now. I think we still have a long way to go. But I do think the tide is shifting. And I think we see that with, we hear in the news all the time about the explosion of cancer cases, right? We continue to hear this in the news. Some of that is because there's better screening out there, there's better tests, there's better imaging, and there are continuing to be doctors listening to patients when they come into their office. Information gaps for patients. So as I said earlier, my wife is a nurse practitioner now, but she doesn't have a lot of experience with cancer. So I felt confident bringing her into the first couple of meetings that I had during my diagnosis. But there was a lot of big information gaps for myself when I was first learning about this disease, because I mean, there's experts on this call all over the place, and you guys are a plethora of knowledge. But for a normal person like myself, somebody who doesn't know as much about cancer, it can be very intimidating for somebody to kind of get into the field through advocacy, whether it could be triggering for them. They could feel like they don't have enough knowledge to offer the field, or to offer to change that policy. So those information gaps can be filled not only through organizations, but through doctors, whether it be taking the time to talk to a patient. Especially, I want to always encourage doctors. Doctors have such a busy day, right? You guys are seeing patients left and right, maybe 15, 20 minutes. And then some of you guys are in surgery. Some of you guys are doing clinical trials. It is a long day. But I do find that if you have a patient that wants to be involved in advocacy, it does pay off trying to find ways to get that patient plugged in. And those information gaps in turn will be filled. Global inequities such as access to scans, treatments, clinical trials. I experienced this a month or two ago when I had a patient reach out to me, another young adult actually, and they lived in Europe. So I was not as familiar with the trials and the approved drugs for treatment, et cetera, because it all changes. I didn't know that at the beginning of my diagnosis. I thought that one drug that's approved here is approved across the board, but that's not how it is. And that kind of comes back to those informational gaps for patients when they're first diagnosed. And then advocacy burnout is real. So one thing that I like to mention, that just like burnout is real for medical professionals, it can be real for advocates as well. A lot of advocates really dive headfirst right into the field, and they want to just make change overnight. And when it doesn't happen, or when maybe unfortunately they lose a friend to cancer, or they lose a relative, or a caregiver loses a loved one to cancer, burnout can be real. So realizing that and noticing it, especially in that partnership dichotomy that I was speaking about earlier, is very important for not only practitioners, but for patients, advocates, and caregivers as well. We can move to the next slide. So circling back after my diagnosis, a little bit about what I did after I was actually diagnosed. So how did I put these things that I was talking about into practice after my diagnosis? So like I said, I had a background in communications and marketing, and I wanted to leverage that into the advocacy field. So I knew that I already had a strong background in speaking with people, and I was very lucky. Now, I will say it's still intimidating talking to experts in the field, because at times I feel like, I'm not talking up to their level, but I had a hard time finding where to start. Well, one thing that I did, obviously, was I connected with other patient advocates, such as Katie Coleman. Some of you might be familiar with Katie Coleman. She was diagnosed with a very, very, very rare stage 4 kidney cancer. And I got connected with her because she was another fellow young adult, and she got me plugged into organizations, especially the KCA, Kidney Can, and KC Cure. She was able to get me plugged in so that I was not only able to share my story with other patients and on their platforms, but B, start getting involved in their patient advisory board, start getting involved in that change and that policy engagement I was talking about earlier. All of those organizations were extremely welcoming to me, and doctors that I have talked to have also been extremely welcoming to me. And I think that helps in that entire process. I joined the patient advisory boards with the KCA and Vanderbilt Ingram Cancer Center, and those have been very rewarding processes. As I'm still early on in my diagnosis, we're talking just a little bit over a year and a half since my diagnosis. Not every patient hops into advocacy right off the bat like I did, but that's kind of the roadmap, if you will, of how I got involved in advocacy and how I kind of used my background after I was diagnosed. We can move to the next slide, please. So, as I mentioned in the previous slide, I kind of said that there was two paths after a diagnosis. Patients tend to some want to be heavily involved in advocacy, like myself. It very much interested me after I was diagnosed, not only because I was a young adult, but my wife worked in the medical field. Hospitals never really intimidated me. I still do get nervous going in for scans, like most people do. But that's kind of the route I went. Some patients decide not to go into advocacy right off the bat. Some of them decide that they just kind of want to live their lives and they want to have their scans and their tests when needed, and then that's it. And that's perfectly fine as well. I will say sometimes advocacy can be triggering for patients, right? Sometimes they don't want to think about their cancer, and that's perfectly fine. Maybe they make a decision 5 years down the road. Once they're more comfortable in their own shoes and their own diagnosis, maybe they do want to be involved in advocacy. I want to also highlight there's no right or wrong answer for the patients that you're seeing. When and if they ask to get involved, it's a personal decision for them. But if they show that interest, I really do encourage practitioners, if they have the time, to point those patients in the right direction, because it's going to pay dividends not only for the patient, but also for the field moving forward. We can move to the next slide. So, kind of highlighting a little bit about what I spoke with earlier about my social media. I created a page called The Unremarkable Kidney. I harness that social media to touch age groups across the spectrum. I think we all know here kidney cancer typically afflicts folks that are, 55 to 65 is kind of, I think, the median age. I could be corrected here, but it's 55 to 65. I obviously was in the rarer subgroup, especially with clear cell being diagnosed at 32. But I was just checking the statistics last week. I reached 10,000 people last month just on my Instagram page. And my thought is, of those 10,000 people, if one patient is able to get to a clinical trial or get to an organization or get to a support group out of those 10,000, then I count that as a win. It's providing a space for patients that are looking for an outlet after their diagnosis. A lot of patients don't really know where to turn. They might be like myself, where they didn't have a lot of experience with cancer, and they want to connect with other patients and kind of not only loop other caregivers and patients into the space, but also have doctors invite them to the table as well, not only when they're diagnosed, but after they're diagnosed as well. I have full faith that most doctors are heavily involved in their patients when they're diagnosed. But if they do want to get involved in advocacy, like I mentioned earlier, it's great to sit down with those patients and point them in those directions on how they best can be involved, whether it's being on a clinical trial or getting involved with an organization that a doctor sits on a medical steering board with. It's vital to have those patients at the table. We can move to the next slide. So my call to action, right? I kind of want to finish this talk up with a call to action, speaking to everyone individually. So patients, you're your own best advocate. If there's any patients on this call right now, you are your own advocate. Ask questions and seek second opinions when needed. At first, I've heard it from patients all over the place that they're always very intimidated by asking for a second or even sometimes a third opinion. For complex cases, most doctors welcome that. Most doctors will welcome a second opinion or a third opinion, especially for complex cases. So if there's patients listening to this, if you're on your own journey, whether it be through cancer or advocacy, you are your own best advocate, and I encourage you to continue to move forward. Caregivers, stand in the gap when patients are overwhelmed. So I'm sure there are some caregivers on this call. You are the unsung heroes in a patient's diagnosis and cancer journey. Stand in those gaps and be there for the patients when they need you, and it will pay dividends in their treatment. Clinicians, I'm sure there are mostly clinicians on this call. Partner with patients and listen and integrate the patient voices into their treatment plan, and that will not only pay dividends for the patient and their health overall, but it might pay dividends for you in the future when you run into another patient that might be having a similar diagnosis, or they might want to get involved in advocacy. And everyone, advocacy starts small. It's sharing a story and joining a support group and contacting policymakers. And then that leads to greater and greater things in the field. And it benefits not only the patient, the doctor, and the caregiver, but the field as a whole moving forward. We can move to the last slide. I want to thank you all for listening to my talk today. I really do appreciate it. The board, the chair here, OncoDaily, the clinicians that are on the call. I want to obviously thank my family, my friends, and the caregivers and the patient advocates that came before me. I really do appreciate your time today, and I hope that this touched the people that it needed to touch today. Thank you, guys.
Thank you so much for sharing your experience with us. We will move to our next speaker, Regina Barragan from Mexico, postdoctoral fellow at the Geriatric Clinic and Medical Oncology at the Medical Therapeutics at the City of Hope. Please give us a minute and we will share your presentation and we can start. Dr. Regina, can I ask to share your screen? Maybe that will help us to do it faster.
Oh, sure. Got it. Can you see my screen now? Oh, yeah. Please let me know if you hear me and you can see my screen.
Yes, I can see your screen. Can you change the slide so we can see it? It works out. No, I mean the second one so we can see.
Yeah, no, sorry. I'm not sure why it's not. Oh, sorry. I know why. Yeah, it changes.
Yes, that's great. We can start. It works.
Great. Awesome. Well, thanks for the very kind invitation to OncoDaily and to the committee that's organizing the Global Voices in Renal Oncology. My name is Regina Barragan Carrillo. I am a Mexican oncologist specialized in GU malignancies, currently working as an attending at the National Cancer Institute in Mexico City. So I'm going to talk about a little bit about renal carcinoma and its current state in Mexico. So overall, Mexico is quite a big country. There are 131.9 million inhabitants in the country. And if we look at the overall rate of new cancer cases, we have over 200,000 new cases, accounting for 96,000 new deaths. And overall in the country, if we look at the current rate of cancer lethality, it reaches up to 41%, which is quite contrasting to if we compare it to, for example, the United States or some countries in Europe. So here, around like 4 out of 10 patients diagnosed with cancer died because of the disease. And because, as I mentioned, Mexico is quite a large country, we decided to divide it into certain regions that are quite important to understand why there's such strong disparities even within the same country. So as you can observe, I want to highlight region number 2, which is the center of the country, that it's where Mexico City is located, among other major states with important economies, followed by region number 1, which is the countries that are south of the border with the United States, which also account for a very important of the economic input that the country receives throughout their own industries. And finally, region number 5, which represents the southern part of the country. This region is characterized more of a either a touristy type of economy or an agriculture-based type of economy. So if we look at the purchase of cancer essential drugs at this analysis, I'm not talking exclusively about RCC, but overall the essential cancer drugs, we can observe that there is a stark difference on the rate of availability and how many of these cancer drugs are actually being purchased when we compare different regions. Mostly, you can observe starting from 2014, there's a stark difference among those drugs that are being bought, for example, in the states that are belong to the central region, in contrast to the other ones. So specifically talking about RCC, we can observe that it does not represent one of the major causes of cancer. Actually, here in the country, breast and prostate cancer are quite important. Talking about GU oncology, for example, prostate cancer is the main cause of cancer-related death in Mexican men. But what we can see is that number 1, it represents the 11th cause of cancer in the country and the 10th cause of mortality, accounting for over 6,400 deaths. And I want to make an emphasis in the graph that you can see in the lower part of your screen, showing different lines in different colors. And we can see the different trends that we have regarding both incidence and mortality within Mexico, within the whole PAHO regions, the WHO Americas region, and in comparison, for example, with the United States. So even though right now we're not seeing that RCC represents one of what we would consider like the major causes of cancer diagnosis and cancer death, there's definitely a trend towards increase in both incidence and mortality. So what I can see in the future probably is that the 11th cause of incidence is going to end up becoming probably one of the top 10 causes of cancer in the country. And what we can observe also in the same line as I was mentioning is that the incidence has been showing a very important percentage increase as we can see in the last couple of years, that in contrast to, for example, the United States and the whole Americas region, where the incidence has been increasing 49 and 28% respectively. In Mexico, we can see an increase of 69% of new RCC diagnoses and an increase of 89% of new RCCs related deaths. So probably I want to emphasize the fact that even though it's right now not one of the main causes of cancer, I think in the future this is going to be something that changes. And the Mexican healthcare system, it's a very highly fractionated system, and it's very complex to understand. I just want to highlight the fact that we have two major type of coverage. We have a public one that could be either dependent on the social security, that's where all like the employees or the teachers and the firemen and the police, how they get their healthcare, and the rest of the population that do not have an employment belong to the government scheme. And on the other hand, there's a private system that is completely independent from the public one, that it's either dependent on out-of-pocket expenses directly by the patients, or a prepaid private type of insurance, that how many patients are being treated in which type of setting. Around 70% of patients with cancer in Mexico are being treated within the public setting. The rest are being treated at least partially in the private setting. And how many of these patients do have a prepaid private insurance that they can rely on whenever they have any type of cancer diagnosis? Around 5 to 10%. And this type of private insurance also has different limits of how much they can spend on specific diseases. So overall, in the 100% of patients with RCC, how many do have a prepaid private insurance that would give them access to a first-line therapy that they could be able to receive anywhere else in the world? Somewhere around 1 to 3%. And this is just to show also starking differences between only the public setting, that we have the one, for example, that belongs to the teachers, the one that belongs to former employees of the Army or the Navy, and also to overall patients who do not have any social type of security. And you can see that there, even within the public setting, there's a stark difference of how much money is being spent on cancer essential drugs. That, for example, the best coverage right now is for the one that belongs to former teachers and policemen and workers of the state. And another thing I want to highlight is that the highly fractionated system is not only dependent on the different entities that give cover to health coverage to patients, but also on the availability of different services. And as you can see in these different areas of servicing within cancer, you can see, for example, Reiki therapy is mostly available only in the south central region of the country, as well as the availability of surgery rooms, as well as linear accelerators. So even though they're, at least by the numbers, a good amount of resources in certain regions, the problem we have here is that these are centralized in the bigger cities in the world. And how many of the cancer care facilities do have enough resources to be considered as enough for the basic care of these 5 different types of cancer, highlighting the fact that highlighting prostate cancer, because there's no data, for example, for renal cell carcinoma, only 16% of them. So there's definitely a starking disparity on how the type of care that the patients can receive. And specifically talking about prostate cancer, we can see that the central region of the country is the one that has the better resources, and the patients have the possibility to get the better care. Which, for example, in contrast to what we can see on the right side of your screen with colon cancer, with cervical cancer, there is not such a stark differences. And you can see that at least for these other 2 types of malignancies, the presence of adequate core cancer care facilities, it's much more widespread. And another important problem we have in the country is the availability of oncologists. So overall, there are like 1,900 registered oncologists in the country, and around 40% of us are located in one of the 3 major cities of the country. And another important problem is that per 1,000 new cancer cases, we can observe that in Mexico, there are only on average, only 2.4 oncologists available, which is quite a striking difference if we, for example, compare with the United States, that we have around 6.6 oncologists per 1,000 new cancer cases. So definitely, even though there are like around 2,000 oncologists, we have two problems. Most are located in only 3 different cities, and the number of cancer cases is definitely a very contrasting availability of oncologists throughout the country when we compare ourselves to different economies. And another important difficulty we have when dealing with RCC in Mexico is that there's an overall a lack of high quality data. So when we observe the registries available and the quality of data, for example, taking as an example, the United States, where the quality of data is categorized as A1. So you have different registries that are being prospectively collected. In Mexico, the registries only cover partially the cancer deaths. So what it means that particularly in certain rural areas of the country, not all deaths are being accounted. So probably the numbers that are being publicly available do not show the whole picture right now. And this is a problem actually we have in different regions in Latin America, not only exclusive to Mexico, as you can observe also, for example, in Peru, in Bolivia, in Belize, that the quality of the data that we have for epidemiological studies and decision making is actually very, very low quality. And finally, just to give a general snapshot, I want to highlight the fact that the number of not only oncologists, but in this case, urologists that are available per center, even when we talk about cancer-specific centers, is around 2.3. So this is definitely an area of very unmet need. The fact that it's not only a fact that there are very few oncologists in comparison to the new cancer cases we have in the country, but also all the rest of the multidisciplinary team that is needed for the adequate care of patients with RCC is very, very limited. So how will the patients be diagnosed in Mexico? So throughout the presentation, I looked at the data that's available from different independent centers. So this might be showing only a very small fraction of what's the reality, but it's the information that's available. So overall, a phenomenon that we have been observing in Mexican patients with cancer is that they are being diagnosed around 8 to 10% younger than patients located, for example, in the United States or Europe, where the mean age at diagnosis is 59 years. And we can observe that around 55% of patients are being diagnosed as stage 4 because of T4 disease or as overall metastatic disease at the time of diagnosis. Another important fact is that only 21% of patients who present with an RCC, who eventually are diagnosed with RCC, present to their PCP within the first 30 days from symptom onset. So these patients are being diagnosed very late in the disease in comparison. Even it's very striking to observe that 13.5% of the patients present to their PCP over 360 days after their initial symptom presentation. And which symptoms do they present? More often than not, they present with several symptoms at the same time, for example, with low back pain, hematuria, or weight loss. And it looks like overall only 25% are being diagnosed as an incidental finding. And when undergoing surgery, something that was very striking, contrasting to how the patients are presenting, is that most of these patients are being diagnosed with T1B disease per the pathology in the group of patients that are diagnosed with a localized disease. And another limitations we are observing in Mexico is that the distribution of urologic oncology clinics, you can see that's mostly in the center of the country where the bigger cities are. So for example, in red, you can see Mexico City. In yellow, you can see Mexico State. In purple, you can see Nuevo León, that's where Monterrey is located. And in orange, you can see Jalisco, that's where Guadalajara is located. And the availability of multidisciplinary clinics in the country is quite limited. You can see that in this report published in 2021, there were only 10 clinics with an MDT directed for urologic oncology available. And as I initially mentioned, the healthcare system in Mexico that we have is very highly fractionated. So this means that that patients are most likely to receive a different quality of care, and that's the reality. So how are patients being diagnosed in Mexico according to type of insurance? We can observe that looking at the patients that are diagnosed in the public setting, 13.4% of them are being diagnosed with a de novo metastatic disease at the time of diagnosis, contrasting with 7.5% of the patients that come that seek care within the private insurance setting. So patients who are receiving care through the public health coverage are being diagnosed considerably later in their disease. And another interesting fact I observed while looking at the data that we have for Mexican patients is that an important percentage actually present with paraneoplastic syndromes, highlighting the presence of elevated ESR and hypertension at the time of diagnosis. And when looking at the risk factors of Mexican patients that present with metastatic disease, one important risk factor that was shown in several series was the presence of obesity, which accounted for overall around 30% of all patients diagnosed with metastatic RCC. So how are they also presented to clinic throughout the years? So if we look at the different decades, we can observe, even though considerable percentage of patients are diagnosed with metastatic disease, throughout the years we have been observing an increase in the incidental detection rate in these patients. So what I think is going to happen in the future is that the incidental detection rate is going to keep on increasing because of the higher number of CT scans we're performing to the patients because of other types of diseases. But there's definitely something that's very similar to the global epidemiology of RCC. Nevertheless, as you might imagine, there's also an important differences between how the patients are presenting in the public healthcare setting and in the private healthcare setting. When we can observe that in the public healthcare setting, they're presenting with a symptomatic disease much more frequently, twice as frequently as in the private healthcare setting, which means that probably these patients that are being diagnosed as incidental finding belong to this very small percentage of patients that do have a proper private healthcare coverage. Is there any data on non-clear RCC in Mexico, and which was an important area of unmet need? So we decided to study this specific matter within the NCI, which is the largest cancer center in Mexico. And overall, in the last 14 years, we have seen in this center over 2,000 patients with cancer. And how is the distribution looking at? We can see that among these 2,000 patients, 6% have a non-clear RCC. And something that was very striking for me is that unlike the international data available, 52% present with a chromophobe RCC. Contrastingly, for example, only 18% present with a papillary RCC. What's the reason behind this? We're looking into the data. This is something that's not been published yet, but I think it's something to highlight the fact that if we don't account for these patients and if we don't make like a good epidemiological data registries, we wouldn't know this type of striking differences and we would not be able to develop appropriate treatment strategies. And how are these patients being diagnosed? Overall, the same age at diagnosis we have seen with non-clear RCC, which that we can see on average considerably younger than the patients that are seen with RCC in the United States. And something that I found very strikingly different among groups is that within the patients that present without any comorbidities, for example, those with both unclassified RCC do not present with any comorbidities at the time of diagnosis. So definitely a specific population that it's hard to make like very stark assumptions with such small numbers. But the epidemiological profile that we can see in these patients is that they tend to be younger. So these are important patients that we need to diagnose earlier in the disease. Other important points that I want to highlight is that within the different groups, the patients with unclassified RCC, the patients with translocation RCC present with higher rates of de novo metastatic disease at the time of diagnosis, contrasting with, for example, chromophobe RCC and FH deficient RCC, where less than 1/4 of patients diagnosed at the time of diagnosis present with a de novo metastatic disease. And finally, regarding the demographic data of the non-clear RCC patients in Mexico, is that most of them do have do present with a good enough functional status to receive systemic treatment throughout the disease. Not all the data does correlate very strongly with what we have observed. Another registry that we had in Mexico actually referred to a higher rate of papillary RCC contrasting to chromophobe RCC, but these are smaller numbers, so I wouldn't make any very definite statements regarding these differences. I just wanted to highlight the higher rate of chromophobe RCC that we are observing right now. And when we look at the overall survival data, overall, the 24-month overall survival data of patients with non-clear RCC in Mexico is around 60%. And we can see a very striking difference between the different subtypes of non-clear RCC, with, for example, a landmark 24-month overall survival rate in the chromophobe RCC group of 78%, contrasting to, for example, less than 50% in the other group of histologies, including unclassified papillary and translocation. On how are patients being treated? As I mentioned, the very highly fractionated healthcare system makes it difficult to work among oncologists. And there's some guidelines that are extremely not updated to the fact that they still recommend as first-line treatment sunitinib, bevacizumab, sorafenib, as you can see in this graph. And there's a very also striking differences how they are being treated according to their type of healthcare. For example, those who are receiving treatment in the public healthcare are being treated much more frequently with a radical nephrectomy and with an open surgery. And if, for example, if we look at the patients who are being treated in the private healthcare, we can see that these patients have considerably higher rates of laparoscopic nephrectomy, as well as higher rates of robotic nephrectomy, because of the availability of these type of techniques outside the public setting. And within the Mexican population, something that's very striking, for example, is the potential access to second and third line treatments, where, for example, specifically for Mexico, the percentage of patients with RCC that have access to second line treatment is 39%, and to third line treatment is 12%. The reason of this is it's complex to actually explain. On one part, definitely the functional status is going to be playing a role, but on the other part, also the lack of novel treatments or the lack of novel drugs is playing an important part also. And what are the treatment trends we have observing in our population? We can see that overall, most patients are receiving treatment with TKIs with sunitinib till this date. And for example, when we compare between public and private, how they are being treated, we can observe that in the first line treatment, most of the patients in the public setting are being treated with TKI, 73%, contrasting to, for example, first line treatment in the private setting with either IO TKI or IO combinations, where this number is 49%. So there's definitely a starting difference of how patients are being treated among this type of coverages. And the socioeconomic status impact on overall survival, definitely, I think I have been given enough reasons to believe this. And as I mentioned, the type of coverage does impact very directly with overall survival, as we can see that patients that do not have any type of insurance in Mexico have a 24 landmark overall survival of around 40%, contrasting to, for example, the patients that have some sort of social security or private insurance, where the 24 landmark overall survival is around 80%. So in spite of all the limitations, we have observed that the time of death of patients according to decades has been prolonged. For example, those patients that were diagnosed initially in the 1980s, their median survival time in months was 5.2. And currently those patients that were diagnosed between 2010 and 2019, their median survival time is around 50 months. So even though we have important limitations, there has been some progress. And when we look specifically at the decade where the patients were being diagnosed, we can see the survival probability at 5 years of patients being diagnosed between 2010 and 2019 of 90%, which is very contrasting to, for example, those patients that were diagnosed between 1980 and 1981, where the 5-year overall survival probability was around 33%. And I want to finish up with an important topic I'm very passionate about, which is access to clinical trials. So this is a study actually that Dr. Pal, which will follow this presentation, mentored me. And we looked at the availability of clinical trials throughout the world, specifically talking about renal cell carcinoma. And we can see that the United States and China are the top 2 leading countries, accounting for the number of trials available in those 2 countries. But if we look at the number of annual deaths from RCC, we can see that there's not such a good correlation. For example, China leads the number of annual deaths from RCC, even though it does not have a correlation between number of clinical trials available. As well, for example, you can see India is the 3rd country with the most number of RCC deaths. And even though that's a very striking number, 10,000, we can observe that comparatively, there are no clinical trials available in this country. Similar phenomenon is happening in Mexico, where, for example, it's between the top 15 countries with the most annual deaths from RCC. But as you might imagine, there is an important lack of clinical trials available. Actually, as of today, there are no clinical trials available in RCC recruiting, and there are only 10 active trials who are doing their respective follow-up for these patients. And this is something that's not happening only in Mexico. So overall, there's an important imbalance in clinical trial availability between high-income countries, where your odds ratio for having a clinical trial available, if you live in an upper middle-income country, decreases around 80% if you live in an upper middle-income country compared to a high-income country, and this decreases to 95% if you live in a low middle-income country. And finally, your probability of finding a clinical trial in RCC if you live in a low-income country is around 1%. So I want to make this a call to action for all the researchers, for pharma key decision makers, that even though these countries do have their challenges, one, we have been proven that through the adoption of novel therapies, through what they call tropicalization of resources, our patients are living longer. So it's important to try to have all the best resources available for their treatment, including RCC. So with this, I finish up, and I thank you for your attention.
Thank you so much for a wonderful presentation. We will move to our next speaker, Samantha Ball, Professor and Vice Chair of Academic Affairs at City of Hope, Chair of Kidney and Bladder Cancer Disease Team, Co-Director of the Kidney Cancer Program. Please welcome.
Great, thanks a lot. It's wonderful to be here. Everybody can hear me okay, I take it?
Yes, we can hear you.
Okay, great. Well, I'll start with this slide from the organizer of the meeting, Rana McKay, and one of her students. You can go to the next slide, that's fine. Let's see here. Can I advance the slides?
Sorry, we have a little technical problem. Just a minute, and we will change the slide.
Okay.
We can continue.
Okay, great. You can keep going to the next slide, please. I'll try to speed things up because I know we're a little bit behind schedule. So, non-clear cell kidney cancer is a hodgepodge of multiple diagnoses. It includes papillary, chromophobe, and a whole host of other subtypes of cancers. Dr. Barragan-Carrillo had referred to the distribution, for instance, of some of these histologies in Mexico. And it seems as though, perhaps they're, a bit underrepresented there. Within the United States, I would say that these constitute about 15 to 20% of patients. Next slide, please. This is a beautiful table that was put together by Rana McKay, who's one of the organizers of this meeting. Dr. McKay, with one of her medical students, highlighted actually several of the alterations that are seen across tumor types. It would probably be beyond the scope of this talk to really go through one by one all of those different elements. But just suffice it to say that, in this scenario, there's a number of molecular drivers of each one of these diseases independently. Next slide, please. I want to focus most of my talk on different histologic subtypes, and I'm going to do sort of a whirlwind tour of all of these. This is a clinical trial that focused on papillary kidney cancer, known as the PAPMET study. PAPMET was a study that included about 150 patients with metastatic papillary kidney cancer, and it was predicated on the biology of the disease. We thought that papillary was noted to have an overrepresentation of MET alterations. So in this study, we randomized patients to get sunitinib or one of 3 putative MET inhibitors, either cabozantinib, crizotinib, or savolitinib, we saw there was a progression-free survival advantage with cabozantinib in this setting. Next slide, please. But beyond this particular study, it's so important to, for instance, take a look at the impact of randomization. If you look at data that we've produced from City of Hope and other sites through the COSMIC-021 study looking at cabozantinib with atezolizumab, you can see that the response rate is quite high, 47%. It's similar in a Memorial Sloan Kettering-led study on the right, with a response rate again of 47% with cabo-nivo. So there may be some benefit in potentially using doublet therapy. Next slide, please. So as we go to other potential regimens, slightly lower response rates with bevacizumab, atezolizumab, but very respectable response rates with a combination of lenvatinib with pembrolizumab. So all of these are very viable regimens. But if we go to the next slide here, I think really the key in this particular setting is that we're going to ultimately need to do something a little bit more focused on the biology of the disease. What you see here are clinical trials looking at the agent savolitinib led by Tony Chueri and Cristina Suarez. And these studies actually look at the use of savolitinib in a MET-directed fashion. The study on the left looked across all subtypes, but focused on those that were MET-altered with papillary kidney cancer. And the one on the right did the same, but you can see in blue those individuals that have MET-driven biology with a combination of savolitinib and durvalumab. So the combination of these data have led to, on the next slide, several randomized studies. So for those in the audience, I think that this is what we really need help with. The two studies at the bottom are now finished with enrollment, Stellar 304 and SAMETA. These are the two first large randomized phase 3 trials in the disease. On the left, Stellar 304 will randomize patients to zanzalintinib, nivo versus sunitinib. And this includes patients with papillary, unclassified, and translocation RCC. On the right is SAMETA, which includes those patients that are MET-altered. The top two studies are still ongoing. The study in the top left is one in particular that could use your support if you're here in the US. This particular study will randomize patients to cabo with or without atezolizumab. If you go to the next slide here, all of these studies are really quite different from one another. These studies are at the top are randomized phase 2 experiences using different control arms. At the bottom, randomized phase 3 studies, one molecularly selected, one not. But I think all of these are really encouraging because they're bound to make a profound change in how we manage the disease. Let's jump ahead to slide 15. So we can go ahead just a couple slides here, just in the interest of shaving off some time. So I wanted to go through the other histologic subtypes of kidney cancer. So this is what's known as chromophobe kidney cancer. This is just about 5% of cases. If I were to give you sort of a bottom line for chromophobe kidney cancer, I would suggest that it's really critical that a lenvatinib-based therapy be considered. So lenvatinib and everolimus yields responses of close to 44%, lenvatinib and pembrolizumab 28%. The study on the left, of course, is a very small series. So whenever I see chromophobe patients these days, and I don't think you know why, but lenvatinib tends to be the preferred option. On the next slide, I highlight collecting duct kidney cancer. And this is something that I've only seen, and I would gather most people have only seen a couple of cases of. And frankly speaking, I used to say that this is something that we manage just like a bladder cancer with platinum-based chemotherapy, but we've really migrated beyond that to consider targeted therapies as well. Giuseppe Procopio did the study on the right, which is published in JAMA Oncology, and it's a really Herculean effort to put together patients who actually have metastatic collecting duct carcinoma and treat with cabozantinib with a pretty respectable response rate of 35%. On the next slide is probably the most challenging subset of kidney cancer to treat. And this is called renal medullary cancer. I've gotten some great advice over the years from Pavlos Masol, who's listed on the slide here. He's faculty at MD Anderson, and he's really taken lead on a lot of these efforts, looking at doxorubicin with gemcitabine, bevacizumab with erlotinib. These are really small numbers, but if you go to the next slide, what I'll highlight here is the management strategy that he's proposed for these tumors. So if you see patients with renal medullary carcinoma, consider starting with platinum-based chemotherapy. As a second-line treatment, you can consider gemcitabine and doxorubicin, then maybe EGFR-directed therapies. thinking about oligoprogressive or oligometastatic patients, maybe chemoradiation as well. These are all viable approaches in this setting, and this is from my personal conversations with him. Next slide, please. Since we're talking about rare subtypes, it's worth discussing HLRCC. This has been since published in the New England Journal of Medicine, but pretty remarkable response rates of 72% with bevacizumab and erlotinib in combination. Now, erlotinib we often think of in the context of patients with lung cancer with EGFR alterations. Here, it's really being used on the basis of what's called the Warburg effect, which affects glycolysis, something that I haven't really studied since my college years. But in any case, it seems as though bevacizumab with erlotinib has some unique activity, and there's studies that are ongoing at the NCI in the United States to look at bevacizumab, erlotinib, and atezolizumab in combination. Next slide, please. So beyond this, I wanted to quickly highlight translocation kidney cancer. There's great data that's been published from Omar Al-Halabi, who's at MD Anderson, and Ziad Bakouni, who is actually based at, I believe it's Sloan Kettering now, but they've both done some efforts to suggest that perhaps there might be some benefit to the combination of VEGF plus IO in this particular therapeutic setting. It still remains to be seen. But I do think that, the combination of VEGF IO remains the mainstay in this case. So on my last slide here, just some key takeaways. I focus this mainly on papillary kidney cancer. There have been some randomized phase 2 studies, but we have multiple ongoing trials. We can go to the last slide that really do need support in this context. So I urge you all to consider using clinical trial finders like this one to identify the right study for the right patient. I think we can go ahead and close there. Thank you very much.
Thank you so much for a wonderful presentation. And now we can move on our panel discussion, moderating with Ravi Kora, Vice President of Oncology at and also joining with Samantha Paul, Giovanni Lucas Orosley, and Andre Fai. Thank you. Please welcome.
Good morning and good afternoon, everyone. Thanks to all the wonderful speakers. I'm really enthralled. I'll start off with an overarching question, having listened to all the interesting presentations. On one hand, at one end, actually, I see chemotherapy still being a part of treatment regimens. And on the other hand, I see pembrolizumab, in fact, in some of the guidelines. So, Dr. Paul, can you please give us a bit of a context on the extremes? Gemcitabine on one hand, and then immune checkpoint inhibitors on the other. What's happening?
Yeah, I would guess that there's very rare instances when you'll think about using chemotherapy in kidney cancer. It would just really be those rare circumstances that I mentioned where you might have a patient with renal medullary cancer, or you might potentially have a patient with collecting duct kidney cancer, or you might use it. When I was in training, 25 years ago, there was some data for looking at combinations of chemotherapy with, for instance, doxorubicin and gemcitabine for sarcomatoid kidney cancer. But I think that's all gone by the wayside. It's all been supplanted by checkpoint inhibitors.
Excellent, thank you. And would I be right in understanding that immune checkpoint inhibitors seem to play a role in most pathological varieties of kidney cancers?
Absolutely.
Dr.
So what I mean with, so what we, yeah, I'm gonna go. Yeah. So what I was thinking is, yes. So definitely what we've seen is like, now we are talking here about non-clear cell histologies. In clear cell RCC is quite defined that our usual approach is to use IO-based combinations based on phase 3 clinical trials. Obviously, when we come to the non-clear cell histologies, we have less evidence, but as Monty-Pal has shown, we have very good data from phase 2 clinical trial. I think we are We are pushing to use IO-based combinations as well in non-clear cell histology in most of them because it seems really positive, the data. However, as has also Dr. Pal mentioned, it would be ideally we need to see at least randomized trials looking at those in IO tyrosine kinase inhibitor combinations versus tyrosine kinase inhibitor, also in non-clear cell histologies.
Sure, thank you. And
So
Dr. Velasco, Dr. Paul, and Dr.
I
Frey.
don't think I'm supposed to be here,
Sure.
but you know, it's my pleasure to join you and also ask a few questions and make some comments. I think my session is the next one, but you know, I am among friends, so I'm happy to be here, you know, and excited about, you know, to attend this session. So I think that the difficult that we have here when we are, you know, looking at this data and studying, you know, different variants in RCC is that it's very difficult to study, you know, those subtypes because we have a small number of patients. It's very difficult to run a big phase 3 clinical trial for every variant. So this it's a challenge, and sometimes we are putting all those variants in the same study and creates some difficulties to understand what is the best treatment for every variant here. So I'd like to hear, you know, from Monty and from Guillermo insights on this.
For which variant specifically, Andre? I'm so sorry, I missed that.
So
for
the non-clear cell overall, you know, you have papillary, you have chromophobe, you have translocation, and sometimes we have clinical trials that are enrolling all those variants to test the same combinations, and sometimes we have different biologies, and that we should design a clinical trial for every different variant or every different subtype, that it's very difficult to run a clinical trial like this.
That's so true. You know, I think that's really where maybe the geography plays a big role in trying to get studies open internationally. I think Regina's presentation ahead of mine was really illuminating because you really see the preponderance of, and at least in her series, patients with chromophobe kidney cancer in Mexico. I was just on a call very early this morning here, but very late in China at around 6 or 7 hours ahead of this with Yao Zhu, who's at Fudan University. And he actually was sharing a series of 2,000 patients that he put together with translocation kidney cancer. You know, it's just crazy because, you know, we were talking about, for instance, 10 or 15 in a series here and there. So I think that with an international effort, you know, ensuring that we have quality controls to make sure that we're getting the right pathology captured, I think we can probably do individual studies across some of these rare malignancies. I don't know what you think, Guillermo.
So what I mean, I totally agree. And what I was just thinking is how can really work together to see how, so because sometimes we see studies from the industry, and you were talking today about the Stellar, has finished accrual very fast. You have the Puppet 2 that is still ongoing. And it's all what do you think is what's happening there? Because what I mean, I think it's still really interesting study is because the access in US is really open to any combinations, and that's why physicians don't want to push to use for tyrosine kinase inhibitor while it's a very important study.
This issue, and you know, for instance, in the United States, where you have multiple regimens available, very few people are, for instance, considering PAPMET2, where you can easily give the patient the combination of cabozantinib and nivolumab. You don't need to do a randomization. Whereas, you know, if we were able to open and enroll in other parts of the world, I think we'd get done a lot more quickly. And I hate to capitalize on the lack of available therapies elsewhere, but I also look at this through the lens of maybe giving access to different parts of the world to these types of novel therapies. So I'd love to see more global enrollment on trials like this.
No, absolutely. And I think it's what I mean, I think it's the key because we've seen that with the Stellar has already finished, and that study that was open in Brazil, in Mexico, and even in Spain. I think you will finish accrual in 6 months.
Yep.
Yeah,
exactly.
and that's true. And I think, you know, talking from Brazil and from a Brazilian perspective here, and I will present this data soon. We don't have those clinical trials open here, right? So we need to use the therapies that we have available, and sometimes, we are extrapolating data from clear cell RCC or based on the data that Monty presented, but we really need more clinical trials that could be focused on the biology of the disease, trying to get better clinical outcomes. Otherwise, I don't think we are gonna do better.
Agreed.
Great. What are the panel's thoughts on radioligand therapy? Do you think that there could be a potential role for radioligand therapy in kidney cancer?
I think that was for Monty.
I do know a couple of programs that are. Yeah, there are a couple of programs that are building onto like girentuximab, the CA9 monoclonal antibody, which are using, again, lutetium and so forth. So I do think that those are quite interesting. I've also heard of some companies with mini bodies that are in development that are also linked to a radioligand. But I think we're pretty far from really, understanding their role. Years and years ago, Peter Mulders from Germany had published some series looking at radioligand-based therapy with, again, a CA9 antibody, and the data was pretty modest with that. So I think we'll have to see how they pan out in early trials before we can really go there. But it's a possibility, but a little farther out.
Okay. Yeah, there is also some data with PSMA that it could be expressed in clear cell and non-clear cell. And there is also, I think there is a proposal from the EORTC. They are planning to do a study with lutetium PSMA, but I think we haven't seen really a lot of data there. So, but that would be more for clear cell.
Okay. Well, Andre, looking at the treatment algorithms in Europe as well as in North America, specifically in the US, how does Brazil fit in with respect to the treatment algorithms?
This is a very nice question, and I will be presenting about the way we are treating renal cell cancer in Brazil very soon. But it's challenging because usually we don't have access to all the medications. Sometimes we still have difficulties in terms of diagnosis of these different variants in RCC. So, for example, sometimes we don't have pathologists dedicated to only GU, to only kidney, that are able to make a good diagnosis, for example, for a translocation RCC or for a rare variant. So it's difficult sometimes to have the correct diagnosis of the disease and have access to the new medications that could change the clinical outcomes of those patients. So it's challenging, and I believe that we need the international community here trying to get more clinical trials and opportunities through Brazil and Latin America in order to improve the cancer care for kidney cancer patients.
Thanks, Andre. Guillermo, you did mention about EORTC. So are you aware of any transatlantic collaborations that are happening for the academic front?
With what? Sorry?
Transatlantic cooperation. You did mention about EORTC. So are there other academic collaborations that are happening?
So I don't think at the level of like doing trials from the academic perspective is much more difficult. I think probably one of the huge effort that is being conducted these days is the CARE1. This is a randomized study that the PI is Logan Salvilles, and what we are doing is randomizing patients to ipi/nivo versus iotyrosine kinase inhibitor based on PD-L1 expression. I think that's the only one that started from Europe with, but I think he's now moving to different countries in Australia and some other countries around the world.
Okay.
But it's really
okay.
difficult these days to do a Gilead trial in that setting from across different countries.
Okay, well, I took that EORTC. Well, I used to work with EORTC, and that's why when you mentioned that, I was very curious to know if there are any other endeavors from other academic organizations. Now, talking about the differences between US and Europe, obviously the reimbursement schemes are different. But within Europe, Guillermo, do you see a difference in treatment patterns, for example, between Germany, France, Italy, and other West European countries?
Yes, absolutely. So there are the reimbursement in Europe is totally different. So usually when there is IMA approval, there is a couple of countries that they get approval straight away. That is Germany and Switzerland. But the other countries, they need to have they have a different process. It takes from 1 year to several years, depending on the country. So there are some places where, for example, now let's think about one drug such as belzutifan. I think the only country that is already approved is they have access and reimbursement is in Germany and Switzerland. But if you want to get the drug, for example, from Spain, it should be through compassionate use, and it's really difficult to get it.
Okay, okay, thanks. Well, any other final closing thoughts from any of the three panel members? Monty, Andre, Guillermo?
Partners from literally around the world. Oh, sorry. It's a great opportunity to highlight international collaboration. So it's great to see my partners from around the world, Andre and Guillermo. And, I think it's only when we really band together for non-clear cell kidney cancer that we can really make big changes happen.
No additional comments. Thank you.
Guillermo, any final thoughts?
Yes, absolutely. I think it's really difficult, but when we are talking about these rare tumors, unless we work together, we won't be able to really improve the outcomes for our patients.
Thanks. On that note, thanks everyone for the wonderful talks, and very glad to have been a part of this session. Thank you very much.
Bye.
Bye.
Sorry. Thank you so much for a wonderful discussion. And now we will move to our next speaker, Pedro Barata from USA, Associate Professor of Medicine in Case Western Reserve University School of Medicine, Director of Clinical Genitourinary Medical Oncology Research Program, and co-leader Genitourinary Disease Team at the University Hospital Seidman Center Cancer Center. Please, Dr. Barata, can I ask to share your screen? And
can the team hear me okay?
Yes, we can hear you.
You guys can? Okay, wonderful. Thank you so much. And nice to see my friend as well. I think I'm able to share screen.
Yes. Now we can see your screen. Just can you please change can you have a full screen first of all?
So what are you seeing exactly? Let me make sure you see.
Now I just see if you try to have a full screen, we can try. Yes, this way. Somehow we see it. Yes, this is great. This is great. This is great. Can you try to go to the next next slide?
Sure.
To be sure. Now it's not. Yes, this is moving. So great. We can start. Thank you so much.
Fantastic. And I'll stay on time. This amazing panel here. Nice to see everybody. Thanks for having me. Amazing meeting. So I was asked to talk a little bit about refractory kidney cancer, post-immuno-based combination regimens, particularly IO-TKI. So that's what I'm going to do. Here are my disclosures. So we know that kidney cancer is not just one disease. It's kind of setting the stage. I think this is known to many of us on the line today. We'll be focusing today. It'll be more about clear cell RCC. And of course, we have many different systemic therapy options considered. Today, we'll focus mainly what happens post-TKI, but we'll touch base a little bit on post-IO, dual IO, if you will, as well. So one way to address this is, number one, when you start thinking about what to do next, is actually when you look at the trial data, how many people are actually getting something else, right? There's always a question around treatment attrition. And so we actually underwent and did that exercise, looking at all the phase 3 trials in GU tumors, but this is for kidney cancer, and kind of looking at patients in the control arm that did not receive immunotherapy-based combo in the frontline space, what happened to them? And as you can see here on the left, not 100% of patients got subsequent systemic therapies. And when you think of those who did, on the right, you can see not everybody got immunotherapy beyond after progression. Remember, these are patients randomized to the non-immunotherapy-based arm. In these cases, for the most part, was TKI or observation, depending on the setting. You have adjuvant as well as metastatic trials included in here. So again, phase 3 trials that led to the approval of those combinations. So the first thing that we take out of this is actually there is treatment attrition. Not everybody gets the treatments. And so a lot of times it's not a matter of now or later. In some cases, it's now or never, right? So that's one point. And the other way to show that is a reminder that we are basically lose almost half of the pool of patients every time we go from one line of therapy to the next. So to me, that's really strong data to support and strong evidence to support the idea that we should not save the best therapies for later. We should consider them when we think it's appropriate. So second line and beyond, as I said, patients get there in different ways. They might get there post-TKI, they might get there post-dual immunotherapy, Ipi/Nivo, they might get there following a combination of immunotherapy, TKI. When we look at the guidelines, we understand that for the most part, we're really talking about monotherapy regimens, with the exception of lenvatinib everolimus combination. But we really talk about a number of options that were developed and available based on data at different time points within the last 10 years or so. Axitinib, belzutifan, tivozanib, lev-av. And so I'll focus a little bit about that in the next few slides. A reminder that TKIs are not all the same. They change the selectivity of the TKIs follows the generation. Most recent or newer generation or higher generation of TKIs are more selective, and that means axitinib and tivozanib, if you will. And so from that perspective, you also have the potency of that selectivity, if you will, for the target. So this is my attempt to kind of put together a lot of the data that we're using to support treatment decisions in clinical practice, supporting cabozantinib, lenvatinib everolimus combination, tivozanib, axitinib, and belzutifan. And the idea is how much of this data actually has been generated in the post-immunotherapy setting, assuming all these patients were exposed to those therapies, if you will. So kind of walk through that really quick. I really like the work from Lawrence looking at activity of cabozantinib for patients who progress on IO, whether it's dual IO or IO TKI. And basically for this talk, we'll look a lot more around cohort B, which is the post-IO TKI. But throughout, I think it's fair to say, not surprisingly, these patients derive benefit from cabozantinib post-IO-based combos. And that means that cabozantinib, it is an active agent in the second line. To be fair, it's not really surprising. We've seen data when we know that Meteor leading to the approval of cabozantinib also happened in post-TKI setting. The difference here is in the post-immunotherapy context, we do see activity of cabozantinib. And so I do consistently consider cabo as a very valid option for patients who have not received it in front line, for example, cabo-nivo. Then we move on to the most recent therapies. Tivozanib first is the TIVO3 trial. Again, Brian Rini led those efforts here, failed 2 or 3 systemic therapies, including at least 1 TKI, randomized to Tivo sorafenib. What's interesting about this trial is actually we do see a kind of activity of tivozanib was shown to be superior to sorafenib in a form of tumor control measured by progression-free survival. and basically 38% risk reduction. But what's interesting is looking at the 3-year, 4-year mark, we have a subset of those patients that remain on therapy without progression. 12% at 3 years, 8% at 4 years, compared to 2.4 and 0% for sorafenib. So there's something about tivozanib and these patients enrolled in the trial that were able to benefit from tivozanib in the long run. As we know, tivozanib has a different profile, and and in this situation, what we can see clearly here by looking at the conditional PFS is patients who get great at 1 year or year and a half tend to do very well afterwards as well. The other perspective is what happens for earlier signs of efficacy, like response and duration of response. About one out of 4 patients will have a shrinkage of 30% or more, and about 21 out of 5 patients will not benefit from TiVo. Those results are way better than what we're looking with sorafenib. About 1 out of 10 will have a response. About 30% or so will have progression as best response, right? So, and then if you respond, you'll get to respond a little bit over a year and a half on TiVo as a median. So that's quite interesting data considering the refractory setting where those patients were treated on this trial. Then thinking about the safety, tivozanib is a newer agent on the block. It's important to look at the safety. And I would say beyond the high blood pressure, which 1 out of 5 patients will develop significant high blood pressure that we need to pay attention to, I would argue these numbers look very favorable comparing with other TKIs. And that's my experience in clinical practice as well. I find tivozanib a very easy agent to tolerate, and that appears to be the case in matching the trial data, from TiVo-3, but also from TiNivo, which I'll talk about in a second. And just a reminder, we can actually titrate the dose from 1.34 to 0.89. We do this 3 weeks on, 1 week off, like we used to do with sunitinib. Then we still go back to our LENF data, old data from 2015, pre-IO. It's not really, we don't really have strong data post-immunotherapy. We have this data, which is post-TKI, as we know. 3 arms, LENF, everolimus combo versus LENF versus everolimus. We know this is a positive study. And we look at progression-free survival, really talking around 14, 15 months or so, compared to lenvatinib and everolimus. So it's a positive study for our PFS. However, as we know, not always is a walk in the park to take lenvatinib 18 milligrams with everolimus 5 milligrams. So actually, there was a regulatory mandated study to kind of look at the combo and ask the question, do we really need to do 18 milligrams of lenvatinib? So that generated a study that Monty ended up presenting, which is the study 218, really looking at a composite endpoint of responses and safety at 6 months, looking at the lower dose of lenvatinib 14 with 5 everolimus compared to standard dose of 18 and 5. And to me, it's actually quite interesting to see the results because, number one, this was powered to be a non-inferiority study, and it did not meet the primary endpoint. In other words, it's not non-inferior. So you see an inferior PFS there for the 14.5, 11.1 versus 14.7 months. But the other aspect, when we look at the safety, you don't really appreciate a better safety profile with a lower dose. And that was surprising. And even though it's a phase 2 study, it's quite a robust study. You have over 300 patients on this trial, and those are the results. So to me, it gave me a little bit of pause around the dose modifications to start patients with. Then a reminder that we do have data post-immunotherapy with axitinib. This great work from my colleague, friend Moshe Ornstein and Brian Rini, kind of looking at titrating doses of axitinib, and bottom line, you do see activity here with axitinib in these patients. It makes a lot of sense to individualize those. I try to follow this in clinical practice, playing with the dose according to safety, but also to response in these patients. And then we also have a new MOA, HIF-2 alpha inhibition in the form of belzutifan. This is the trial for sporadic RCC, not VHL disease, and this is a LightSpark-05. We saw these results, no difference in the median, but it's a positive trial for progression-free survival based on the tail of the curve, if you will, right? As a ratio appreciates the difference throughout the time to event analysis, and median 5.6 months. However, you have a 25% risk reduction favoring patients treated with belzutifan. And on this trial, also no overall survival was appreciated. However, when we look at the activity as form of response rate, there's a few things we can comment. 1 out of 4 patients or 1 out of 5 patients will respond to bel. We almost don't see response with everolimus. It's in the single digits, 3-4%. The other piece of the story, a third of the patients will progress as best response, right? So there's something about, the tumors that we have a good deal of patients that, HIF-2α inhibition is not the way to go. So far, we don't have a biomarker, but it's important to highlight that as an aspect to take into consideration moving forward. And by the way, if we look back on the curves for PFS, that tail of the curve, I guess, around those 20 to 25% maybe, it's maybe the group of patients who are benefiting from belzutifan the most and wondering or raises the question whether or not we can figure out a biomarker to identify those patients. And then if you respond, you tend to respond over 1.5 years as well, closer to 2 years. And I think the results for everolimus are pretty as expected. So I don't think the arm here underperformed either. So with that in mind, the other aspect I would like to highlight is, of course, the safety profile of belzutifan, which is different from what we're used to, right? I'm paying more attention to anemia. I am thinking, should I do EPO or not? Should I, checking SATs, oxygen saturations, and so those are aspects that we're not really used to do them or test them or think about them in the past the same way. So as a kind of a learning curve, but it is true that we can, combine therapies like belzutifan with TKIs because there's not a huge amount of overlapping toxicities. Then the next question, the refractory setting would be, should we do salvage immunotherapy? And actually, this started a few years ago. When Ipi/Nivo data came out on CheckMate 214, we thought, should those patients get ipilimumab at any point? So there's a number of studies developing that idea, and unfortunately, most of the data to support Ipi/Nivo in the refractory setting is really limited activity in the teens for activity, and so this became not a super exciting opportunity. And then there came the question around PD-1, PD-L1, right? And the two trials that looking at that, CONTACT-3 and TiNivo-2, really did a great job understanding or helping us to understand the role of challenging patients with a checkpoint inhibition. There's a few differences between the two studies. I think a lot of us know about that. CONTACT-3 used the same dose of cabozantinib on both sides. It uses a PD-L1 atezolizumab, and also it required progression on a checkpoint within 6 months. By contrast, the TiNivo-2 trial took a PD-1 inhibitor, nivolumab, allowed for progressions beyond 6 months. Actually, a third of patients or so end up receiving something else after progressing on a checkpoint before going on trial. And also, the tivozanib dose was different on both sides. It was normal dose on the control arm, but it was reduced to 0.89 combined with nivolumab. And when we look at the data side by side, we really don't see a difference in terms of outcomes. And in some situations, we see more toxicity when we're looking at the combination compared to the TKI monotherapy. So I think for most patients after this data came out, we start recommending against immunotherapy rechallenge. Of course, there's always specific situations that we can debate, but for the most part, it's a less attractive option for our patients. And the concept that somehow the immune system gets rebooted and we can revisit the concept of checkpoint inhibition, at least in these studies, did not pan out. Finally, and I'm getting close to the end, stay on time. How is the field evolving? And I could bring a number of trials. My colleagues and friends, a lot of them are running those studies and very important to the field. I decided to highlight 2 of them with HIF-2α inhibition because I really think that's where we're going to be seeing data first. LightSpark 11 might read out at any point, including this year. We'll see. It's basically asking the question around the optimal, early refractory setting line, because it took patients who receive up to 2 prior systemic therapies. So I think we're going to see a solid number of patients getting the randomization, the second line, Lev-Bel versus Cabo. And it really is going to show us, how does this combo performs compared to cabozantinib, right? We got a little bit of that idea on the data by Kathy Beckerman, on the umbrella study that was presented about a year ago, but it will be interesting to see these results here. See if belzutifan moves from being used as monotherapy to actually being combined in the refractory setting, perhaps second line. And then the second study is a different HIF-2 alpha inhibitor, casdatifan, which has been developed. The data for phase 1 was presented, just at ASCO. And, the phase 3 trial is going, and it's going to enroll. I think it's going to start enrolling late this year. Of course, there's other very interesting concepts of interest. There's, of course, bispecifics being tested. There's radioligand therapy being tested. There's proof of concept studies, smaller studies testing different second line options like Cabo versus Lev-Av, for example. Kudos to Andy Hahn out of MD Anderson. There's a number of very interesting concepts that are being explored, and hopefully will give us a little bit more data in this kind of post-TKI, but I would say also in the post-IO setting that we'll need to understand what we're going to do. And so with that, I would say, attrition in the refractory setting is real, and we know that many patients never make it to later lines of therapy. We do know that VEGF TKIs, for the most part, remain the cornerstone of treatment. And after you progress on IO-based combos or IO-based or IO TKIs combo, TKIs, they have shown activity and tolerability. I've shown you data showing you that or demonstrating that immunotherapy beyond checkpoint inhibition has limited value as of now, and HIF-2 alpha inhibitors are being investigated for the most part in combination strategies in large randomized studies, and we'll find out about those in a very near future. And this is all I got for today. I wanted to stay on time. We had 20 minutes. Here my email and WhatsApp around the world. Happy to connect. It's a pleasure to be here, be part of this world community, and be part of this meeting. And happy to take any questions or comments. And again, thank you for your attention.
Thank you so much, Dr. Barata, for a wonderful presentation. We will move forward to our next speaker, VIRO 2025. Chair Rana McKay will introduce future direction, emerging agents, and combination. Please, Dr. McKay, can you share your screen so we will check that everything is correct?
Let me just make sure you guys see that.
Just a minute. Yes, now we can see your screen. If it's a full, now we can.
You guys see that?
It's not.
Is it full screen now?
Can you try again? It seems.
Okay,
Yes.
can you all see that?
Can you just check the next slide? So we will see that it's changing. Yes, that's great.
Perfect.
Floor is yours.
Perfect. Well, it's a pleasure to speak with you all. I know there's been a little bit of shift in the agenda. UA is going to be speaking a little bit later on HIF-2 alpha inhibition. So we're going to go through future directions and emerging agents and combinations in renal cell carcinoma. Here are my disclosures. So to level set, we're going to go through several different targeted therapy strategies to treat renal cell carcinoma. We're going to talk about novel anti-angiogenic agents that target VEGF and HIF. We're going to talk about IO targeting agents and other targets that are being considered. And we'll end a little bit talking on selective drug conjugates, including ADCs and radioligand therapy. So that question about ADCs has been sitting in the chat for some time, so we'll get to it here.
So the strategies for novel targets, like I said, the anti-angiogenics, HIF inhibitors, VEGF inhibitors, we're going to largely focus on those for the bulk of the presentation. There aren't inhibitors that are currently in development, though it's still very early stage. We'll talk a little bit about cell cycle and GCN2 activation, very brief touching on bispecific and CARs, and then talk about the selective drug conjugates. So just as a way of background, targeting the HIF VEGF pathway has really been the backbone of treatment for patients with advanced renal cell carcinoma. And actually, this work has led to a Nobel Prize being awarded to these 3 recipients for their discoveries on how cells sense and adapt to oxygen availability. And when we think about, patients who have particularly clear cell RCC that have dysfunctional VHL, this results in HIF2 alpha accumulating within the body. It does not get targeted for proteasomal degradation, which is what VHL does, and then that results in downstream signaling, angiogenesis, proliferation, and so forth. So we're going to go through a series of different drugs. I'm going to highlight, kind of the newest kids on the block, and then we'll go from there. So zanzalintinib is a multi-targeted inhibitor of VEGF, RET, MET, and the TAM kinases. It's been shown to reduce tumor angiogenesis, impede tumor growth, and relieve immune suppression. Here is data that were presented at ASCO last year by Dr. Monty Pal that looked at the single agent activity of zanzalintinib, which demonstrated an objective response rate of 38%. This was in a heavily pretreated population of patients who had, majority all received a checkpoint inhibitor and 81% had received a TKI. And the median number of lines of prior therapy were 2. You can see that immune cell subsets had significant changes with zanzalintinib treatment, resulting in a more immune favorable profile on therapy, and that baseline levels of plasma biomarkers actually associated with response, including HGF, IL-8, CRP, and TNF-alpha. There are several studies that are currently ongoing looking at zanzalintinib in combination with various different agents, including the Stellar 001 trial, which is close to accrual, looking at Zanza in combination with atezolizumab and avulimab. Stellar 002 looking at Zanza in combination with Nivo plus Nivo-Ipi. Stellar 009, which is looking at Zanza in combination with casdatifan and casdatifan plus nivolumab. And this drug does seem to have a similar target profile to cabozantinib, with a shorter clinical half-life and PK properties that's suitable for once daily dosing. Here is some data from Stellar 002 that were presented. This trial enrolled patients who had metastatic RCC, all IMDC risks. The groups that were going to that had received no prior systemic therapy or RCC. These patients treatment included zanzalintinib plus nivolumab or zanzalintinib plus nivolumab plus relatlimab. For those of you who also do melanoma, you may be familiar with this agent. It's a LAG-3 inhibitor that is being tested in RCC, and you can see the combination data, objective response rate of 63% of Nivo-Zanza, actually lower objective response rate that was seen with the triple therapy at 40%. The rate across the board was really quite low. The median PFS 18.5 months with the dual therapy compared to 13.07 months with the triplet therapy. Now we're going to shift gears a little bit, talk about belzutifan and different combination studies being done in context of this trial of this agent. Belzutifan is a small molecule inhibitor of HIF2 alpha. We know cabozantinib is a multi-targeted VEGF TKI. Here is data from LightSpark 003 that looked at cohort 2 of patients who had received prior IO therapy and received this combination, demonstrating an objective response rate of 31%. Many of these patients were heavily pretreated. 54 had received prior IO, 46 prior IO and VEGF. The PFS was 13.8 months and OS 24.1 months. Additional data on this combination is further highlighted here in the context of the study that was presented by Jamie Merchant and Tony Shaweri at ESMO 2023. Cohort 1 enrolled patients who were treatment naive, and cohort 2 enrolled the pretreated patients. In the treatment naive cohort that received the combination of belzutifan cabozantinib, we saw objective response rates of 70% with a progressive disease rate of 2%, so highly effective when HIF VEGF inhibition are used in combination. For cohort 1, the PFS was 30.3 months, and cohort 2, 13.8 months. Belzutifan is also being looked at in various other agents. This is the Keymaker U03 trial, which is looking at belzutifan and other combination drugs together. The top panel here is looking at Pembro-Bel, Len-Bel compared to, I shouldn't say compared to because this wasn't necessarily a comparison trial, but reference standard of Pembro-Len. And you can see that the Pembro-Belzutifan cohort had a response rate of almost 20%. The Len-Bel cohort had a response rate of 47%, and the Len-Pem a response rate of almost 40%. And keeping in mind that this was a cohort of treatment refractory patients, patients had to have progressed on a prior immune checkpoint inhibitor in sequence or in combination with a VEGF TKI. So these are all pretreated individuals. And then you can see the PFS numbers here for Pem-Bel at 5.4 months, Len-Bel at 12.5 months, and Pem-Len at 9.4 months. On the bottom graph, these are not actually belzutifan combinations, but rather various IO combinations that have been utilized together. And, what's, I think, nice to call your attention to is the pembrolizumab quavonlimab combination, which quavonlimab is a CTLA-4 inhibitor. And these are in people also post-IO. And you can actually see the objective response rate of 30% here in this cohort, 0 for the other IO, immune therapy strategies, but kind of highlights that there's probably a subset of patients who, if they didn't get a CTLA-4 inhibitor in frontline, could potentially derive some benefit from a CTLA-4 inhibitor in later line. It kind of corroborates some of the data that we've seen in the fraction trial as well. There are other belzutifan combination studies that are ongoing that are going to further inform the field. LightSpark 011, which Dr. Barada just highlighted, is looking at lenvatinib plus belzutifan in the second-line setting compared to Cabo. LightSpark 012 is looking at various combination regimens in the frontline setting, looking at triplet therapy of Len-Pem plus belzutifan, or Len-Pem plus quavonlimab, or Len-Pem, and then LightSpark 022 is looking at Pem-Bel in the adjuvant setting. We won't spend too much time on DFF332. This agent has actually is not moving forward. It's a HIF-2 alpha inhibitor. Data were presented last year by Dr. Monty Pal about its mechanism of action and activity. This agent had a very, very long half-life of 85 days. And there was some, difficulty with managing toxicity in the context of the trial. This drug is no longer further being developed, but just for completeness, mentioning the other HIF-2 alpha inhibitors in development. The other agent is AB521, now known as castatafan. This is a next generation HIF-2 alpha inhibitor that has been in testing in the ARC-20 study, and is also now end up looking at its activity in various combinations. The ARC-20 was the first in human, which looked at escalating doses of monotherapy and also at the recommended phase dose, and also other expansion cohorts in combination with various other agents. You know, when we talk about casdatifan, casdatifan showed potential best-in-class PK/PD profile with a dose proportional exposure. Casdatifan 20 milligrams daily provided a very similar level of EPO suppression to belzutifan 120, keeping in mind that the recommended dosing for further development is actually at 100 milligrams. And the casdatifan dose of 100 milligrams had a 5x higher exposure than the 20 milligrams. And the 100 milligrams resulted in more deeper and sustained reduction in EPO. Here is the data of the monotherapy activity at the recommended phase 3 dose, demonstrating substantial, response in a heavily pretreated patient population. 83% of patients had 2+ lines of therapy, demonstrating an objective response rate of 33% and a PD-1, a progressive disease rate of PEAK-1 is now open to enrollment. It's looking at the combination of casdatifan with cabozantinib versus cabozantinib in the second-line setting for people having progressed on prior IO. They must be HIF-2 alpha inhibitor naive and cabozantinib naive. They may or may not have received a VEGF inhibitor. And the primary endpoint is PFS. Additionally, casdatifan is going to be looked at in combination with volrustomig, which is a PD-1 CTLA-4 dual inhibitor in a phase 1b/3 study that is also currently in development. This is in the frontline setting for people with clear cell RCC not having received any prior treatment. I'll highlight the NiKang 2152 agent. This is also another HIF-2 alpha inhibitor therapy, and also in combination with IO and also palbociclib with HIF-2 alpha inhibition. The development of this agent has also been recently terminated and will not be moving forward. Given the rationale that I just described regarding the potential for synergy of CDK4/6 with HIF-2 alpha inhibition and the role that CDK4/6 actually plays in RCC, there was a study that actually looked at the palbociclib as a monotherapy. This study was actually intended to be a combination study, but for various reasons, it became a monotherapy study. And as a monotherapy, this strategy did not prove to be effective, but there is a phase 1/2 multi-center study looking at belzutifan in combination with palbociclib versus belzutifan alone, the LIGHTSPARK-024 study in a refractory patient population. HC7366, this is agent that is an activator of GCN2, and preclinical studies have demonstrated that it has anti-tumor activity given its lethal activation of the integrated stress response. It inhibit the inhibition of protein translation, a down modulation of oncogenic proteins and induction of mitochondrial dysfunction has been demonstrated in preclinical models. There's a phase 1 multi-center single-arm combination study with belzutifan that is currently ongoing. Now, we're going to lastly touch on the selective drug conjugates just as a point of background. When we talk about selective drug conjugates, we have a carrier with a linker that's attached to a payload. There's all different kinds of carriers, whether they be antibodies, proteins, small molecules, peptides that target a tumor-specific, usually a protein, a cell surface protein. Then there's a linker. There's all sorts of linkers, whether they be non-cleavable, cleavable, protease dependent, and then there's the payload, and whether that payload be a chemotherapy agent or a radio, a nuclide, transcription factor. There's various agents that are out there. So I just want to highlight, these are the antibody drug conjugates that have been developed in RCC. or the different targets, I should say, that have been looked at in RCC, particularly CA9. CA9 has very limited normal tissue expression. It regulates pH in hypoxic tumor environments, promotes tumor growth and survival. PSMA is actually also expressed in the neovasculature of RCC. ENPP3, which is expressed in the kidney, liver, and brain. And then CDH6 and CD70, these all have been potential targets for therapeutic targeting with antibody drug conjugates and radioligands. These are the selective drug conjugates that have been looked at thus far, and I think every time I put this slide together, the list continues to expand as there's new agents entering into the clinic, and I would probably have to say that the data to date thus far has been pretty limited with regards to the antibody drug conjugates. Many of these programs have either not moved forward or there's been a significant toxicity. And when we think about antibody drug conjugates, here the payload is chemotherapy, and chemotherapy has largely not been effective in the treatment of renal cell carcinoma. And so, I think the rationale for the limited therapy has been a lot of on-target off-tumor toxicity, the heterogeneity of the target expression at the tumor site, actually tumor uptake, the circulating molecular decoys, the conjugate properties of linker stability, and then the sensitivity of the tumor to the payload. So, in summary, there's many novel therapeutics that are being explored in renal cell carcinoma, many agents targeting angiogenesis through both HIF and the VEGF pathway. There's agents with novel modes of drug delivery that are being looked at in the clinical setting, and selective drug conjugates to date thus far have had limited activity, but they definitely warrant further understanding of the pharmacokinetics and the pharmacodynamics. So with that, I'm happy to take any questions that you all may have. If you want to drop them in the chat, go from there. Thank you all.
Thank you so much, Dr. McKay, for the presentation. And I think we can already move to our next speaker, Dr. Andre Fay. Please welcome medical oncologist, professor of medicine at PUCRS School of Medicine, visiting scientist at Dana-Farber Cancer Institute. Dr. Fay, you can share your screen. We already see it. That's great. That works. We can do it again.
Okay, let me just share it here. 1 second.
No problem.
Okay, are you seeing my screen?
Yes, can you do it full screen?
Is
Great.
that okay?
Yes, that's great. Can we check that that's moving? Can you?
It's moving?
Yes, great.
Okay, so thank you so much for the invitation. It's a pleasure for me to be here, in the Global Voices, to talk about the current state of renal oncology in Brazil. And for me, this is a very important topic once we would like to do better, in developing countries when you talk about kidney cancer patients, treatment and clinical outcomes. So thank you very much again for the opportunity. This is my disclosure. And let's start to understand the incidence and the mortality of kidney cancer in Brazil. This is data, the most updated data from 2022, showing an annual incidence of approximately 11,000 cases and a mortality of more than 4,000 patients. So if we look and if you compare the mortality, the incidence mortality rate, the mortality rate is almost 40%. That is almost, 2 times higher than a well-developed country. So the mortality, it's very high in Brazil when we talk about kidney cancer. So I'm sorry, about this slide, but this is the National Cancer Institute estimates and data that we have about incidence of the most frequent cancers. And as you can see here, the kidney cancer doesn't appear among the main cancers or the most prevalent cancers in the country, even in men and women. So it means that the incidence of renal cancer in Brazil is less than 2% in both sexes. So this is a very rare disease in Brazil. For in this year, and this is the most updated data that we have. So when we talk about the trends in terms of incidence and mortality, when I was preparing this presentation, I realized that the data that we have, it's the same that we have from 10 years ago. So it means that also we don't have a lot of data and quality data showing epidemiology of kidney cancer in Brazil and Latin America. But as you can see here, and this data applies for 2025 in terms of message, in terms of what we want to say, is that the incidence of kidney cancer is increasing, but the mortality is increasing as well. And as we compare to the mortality rates in well-developed countries, we see that there is an instability in terms of the mortality rates, and this reflects the disparities that we have in terms of cancer care in the whole Latin America and also in Brazil. So we expect a higher incidence of kidney cancer and high mortality rates. And when we talk about these disparities in cancer care, we have many factors that are involved in these different clinical outcomes and that we have for kidney cancer patients. And to understand, it's important for us to understand a bit of this because, Brazil is inside of all these factors here. So, for example, we have a lot of patients that are diagnosed with advanced disease or with higher stage disease. But we don't have in Brazil a cancer care infrastructure for the whole population. We have a huge problem in terms of patient access and availability of cancer medication. We have different health and lifestyle here, and the health system infrastructure is completely different. So to understand the kidney cancer scenario in Brazil, it's important to understand that we have many of these aspects involved that will reflect and result in the disparity in cancer care when we compare to other countries. So let us understand a bit about the healthcare system in Brazil, and this will be important to understand how difficult would be to treat kidney cancer in Brazil. So Brazil is the largest country in Latin America, and we have huge differences in terms of healthcare access. Some differences are, related to demographic factors. So we have a different access in larger cities, and in the south of Brazil, the access is better than in the north or in small towns. We have economic factors that will be involved in the clinical outcomes and the way that we are going to treat kidney cancer. So, for example, we have people that will be able to have private health insurance, that will have prompt and complete access to medications and to physicians that will be able to treat the kidney cancer. But if we talk about patients that will depend on public system, this will be a problem. So in Brazil, the private and the public healthcare systems coexist. And usually the private system covers about 25% of the population. It means that 75% of the Brazilian population will be in the public health system, and this will be very important when I show you the differences in terms of healthcare, comparing private system and public system in Brazil. So it's a very small part of the Brazilian population that at the end have access to a private system. So also Brazil has its own regulatory process to approve new technologies, new medications, and it could take up to 2 years or longer sometimes. That will impact the way that we treat cancers and that we provide patients the new treatment and the novel technologies. So let me try to explain you how works the public system. And the public system has a specific model of payment, of a reimbursement. So the model for reimbursement is a fixed budget based on the disease type and staging. So, for example, the government will pay for metastatic renal cell cancer a predetermined amount of money and leave the decision regarding the appropriate treatment to the healthcare provider. So they will give me that amount of money, and I will be able to decide what treatment I will give for that patient. So usually the new technology and novel treatments do not fit in this budget. So, and here, this is an example to understand the difficulty that we have to treat a kidney cancer patient. For example, in the public health system, the healthcare provider receives around 3,000 reais a month per patient to treat this patient, okay, to provide this patient a systemic therapy. However, when we evaluate the price of one cycle of EP plus Nivo, the cost is 70,000. So who will pay the difference of 67,000 reais, or each money you want to talk about? So the difference is huge. So we are not able to provide EP-Nivo for this patient because we have a very small amount of money, and we need to try to find a treatment that will fit inside this budget. So it's very, very challenging to treat patients in this scenario. So when we look at the drugs that are approved in Brazil for RCC treatment, you are going to see that the majority of medications that are, in the national and international guidelines are available and are approved in Brazil. We have a gap of time in terms of international approval and in the approval of those medications in Brazil. And we have the availability of these medications in the ANS, that is the institution that regulates the private system. So we have those medications, the majority of those medications available, and we can provide those to patients. However, when we see the availability in the public system, that the last line on your right, the US availability, that is the public system in Brazil, the majority of medication are not available for those patients. So for more than 75% of Brazilian patients with kidney cancer, the only options we have is sunitinib and pazopanib that were incorporated, that were available to be given to the patients in 2018. So this is for me, a very dramatic situation, because in 2018, we, in Brazil, we're treating patients with EP-Nivo, and we are now incorporating sunitinib and pazopanib for the majority of patients. So until 2018, patients were receiving interferon for treating metastatic kidney cancer. So this is definitely not acceptable, but that's the reality that we have in Brazil. And still, this is the reality in many centers that are not able to handle and work with the government to incorporate those medications in the system. So this is a huge challenge. And we are going to see in the next few slides that it will impact the way that we treat and the clinical outcome for those patients. So here is a paper that we published, a few years ago, Rana McKay and myself, showing the impact of geographic regions on overall survival in patients with metastatic kidney cancer. This is in the era of VEGF target therapies. But what I want to show you here is that even with different baseline characteristics, the clinical outcome is the same, right? It's not statistically significantly different in terms of overall survival and progression-free survival. And it means that we could achieve a good clinical outcome if we are able to provide medications, the best medications for patients, right? Independently of country income or country life expectancy. So this is an important thing. So if we are able to provide patients the medications, we will be able to get good clinical outcomes. So probably this is the data, the most important data that we have from kidney cancer treatment in Brazil. This is a registry of renal cell carcinoma in Latin America. This is a LACOG 1120 study, which I am the PI. And this is a prospective, registry of patients with renal cell carcinoma, any subtype, and we get a lot of socioeconomic data, risk factors, clinical pathological characteristics, and also follow those patients, trying to understand the treatment patterns and the clinical outcomes for those patients. And there is a specific subgroup of those patients, of Brazilian patients, that we just presented in the poster session at ASCO 2025. So we presented the poster showing the differences in patient characteristics, treatment patterns, and clinical outcomes of renal cell carcinoma, comparing the public and the private systems in Brazil. So we got 230 patients with renal cell carcinoma from 16 cancer centers across Brazil. So we tried to get and to get patients that will reflect the heterogeneity that we have across Brazil, and then we collected data to present clinical pathological characteristics, demographics, and also clinical outcome. And this is the key takeaway that we presented in our poster, and I like to highlight this here. So we are talking about the same cancer with completely different outcomes if we are treating those patients in the private or in the public system. The 5-year survival in Brazil of a kidney cancer patient that is treated in the private system is around 79% versus 42% in the public system. So we are doubling, the rate, the chance of this patient survive in 5 years. So let us understand a bit this study. Here's some clinical characteristics. The majority of patients had clear cell RCC. And it's important to look that usually the diagnosis is still have been done through nephrectomy, and the majority of nephrectomies are radical nephrectomies. We don't have the robotic assisted surgeries and partial nephrectomies that could preserve renal functions on those patients. And as you can see here, the distribution of those patients according to the health care system is similar as I presented to you. So we selected 61% of patients in the public and 37% in the private system. And here you can see that at diagnosis, the stage distribution by public and private are completely different. So we are getting much more patients with advanced disease in higher clinical staging in the public system compared with private system. So this is an important difference. So the patients are arriving late to a cancer center, and it makes much more difficult to treat those patients, okay? So in terms of adjuvant treatment in Brazil, just, we don't have a lot of information in terms of adjuvant therapy. As you can see here, we have a very small portion of those patients that are receiving adjuvant treatment, but we have some patients now receiving pembrolizumab and sunitinib, 2 patients, but pembrolizumab is becoming more frequent in Brazil with the data and with the approval of this medication. So let us see some information about treatment patterns here. We have only 53% of patients in the private system, so it's the best scenario, that are receiving a first-line therapy. And if we compare with the public system, only 34% of patients are receiving a first-line, 27% in the private system are receiving second line, and 10%, about 10% receiving third line or further. And as you can see here, only 5.7% of patients with a metastatic renal cell cancer carcinoma are able to achieve a second line treatment. In Brazil, as you can see here, and considering the access and the timeline for medication approval, Ipi/Nivo is the most frequent treatment in the private system, followed by Pembro/Axi. But still, we have some patients that are still receiving sunitinib and pazopanib, because depending on the healthcare provider, the medication is not available. And in the public health system, if the patient is not in a clinical trial, patients are receiving sunitinib or pazopanib. And this is the overall survival for the entire sample, for the whole cohort of patients. But what I would like to show you here is that if we separate the curves in the cohorts of patients in the private system versus public system, the difference is really big. 42% of patients are alive in the year 5 versus almost 80% that have been treated in the private system. And then it means that they have access to the new treatments and with the best options, immunotherapy and combination that are available in further lines. So if we ask about if this could reflect also earlier stages, this is also true, because even patients that are diagnosed with localized disease, they have more chance to be alive if they are in the private system. And we separate that, we see that the public system and the access of medications will impact the chance of the patient and the clinical outcome of those patients. This is very quickly an older study that was presented only for metastatic patients, comparing the treatment patterns in metastatic RCC between developing and developed countries. Showing the same thing. If we compare, for example, with IMDC data, we still have a huge difference in terms of patients that are receiving second line, that are receiving third line, compared with developed countries. And this slide is, for me, something that it's very important, and even it's being presented in 2017, I can tell you that this remains true. And this is what we see, patients receiving non-traditional therapies in the first line setting. And as you can see here, we still have a high proportion of patients that are receiving treatment that are not active in patients with renal cell carcinoma, right? patients receiving gemcitabine, carboplatin, gemcitabine, cyclophosphamide, docetaxel, and this is something that we see when we go across small cities in Brazil, where also we need more education and training those professionals. So we are seeing non-traditional therapies being used because those therapies will fit in that predetermined budget that they have to choose a therapy to treat those patients. So this is something that we need to tackle and train people to make them understand that this will not help those patients. So having said that, it's important to show that clinical trials could be and are the best option to treat kidney cancer patients that are in the public system in Brazil. It means the majority of the population. And if we see, for example, the 130,000 patients, clinical studies in cancer that are recruiting around the globe, only 5.5% are open in Latin America and only 2.2% are open in Brazil. So those patients are also not having access to clinical trials, and we need the help of the international community to bring clinical trials to Brazil to improve the clinical outcome of those patients. And what trials are recruiting in Brazil for RCC right now? If we look at all the platforms, we are seeing the Stellar 304, that was the study open here for non-clear cell RCC at my institution, that it's an academic institution with a very strong clinical research center here. No studies are available to treat RCC patients, which bring us a huge challenge to treat those patients. Just to finalize my presentation, just saying that we have a local guidelines and consensus to define the best options that are adapted to reality of Latin America and to the Brazilian reality, but still this does not reflect the real world when we are in front of patients. So thank you very much for the opportunity, and hope we can, improve the access to healthcare in Brazil to improve the clinical care of kidney cancer patients. Thank you very much.
Thank you, Dr. Fay, for a wonderful presentation. It was very interesting to listen. And now we can move to our next speaker. Please welcome Elizabeth Wolf Birchfield, Associate Professor and Medical Oncologist at the University of Kansas Health System. Unfortunately, Dr. Elizabeth couldn't join us live. We will be viewing
Hello,
her
my name is
presentation.
Elizabeth Wolf, and I am a genitourinary medical oncologist and palliative care physician at the University of Kansas Medical Center in Westwood, Kansas, USA. I'm so sorry that I couldn't be with you live, but I'm honored to be among you for this inspiring global congress. Today, I'm going to be discussing palliative care and renal cell carcinoma. And these are my disclosures. And here's where we're going today. In terms of our objectives, I'm going to define palliative care and talk about principles as well as differences between specialty and primary palliative care. We're going to be talking about palliative care solutions for some difficult renal cell carcinoma specific challenges, as well as talking about determinations of when patients need specialty palliative care referral. So first, let's start by defining palliative care. I choose to use the definition of palliative care from the Center to Advance Palliative Care, or CAPC, which is that palliative care is specialized medical care for people with a serious illness with a focus on relieving symptoms, either physical or emotional or psychosocial, from a serious illness for the patient and their family members. Other features of palliative care that are common are the fact that this medical care is conducted in an interdisciplinary team, which can include team members not commonly seen on a typical interdisciplinary oncology team, such as chaplaincy, as well as another important feature of palliative care is that it can and should be conducted alongside conventional medical care, including care undertaken with curative intent, and that palliative care is for any stage in a serious illness and any age of patient. And while palliative care was really developed as a response of the medical community to the grassroots development of hospice, which came about due to the increasing medicalization of the dying process. Because of that, palliative care and hospice are often conflated. However, more recent data over the past 15 years or so has clearly demonstrated that there are a number of benefits to patients receiving concurrent palliative care with their conventional oncology care. And those include improved quality of life and symptom control, including physical as well as emotional symptoms when patients receive palliative care alongside their cancer care, as well as greater satisfaction with their medical care, more time spent in hospice when indicated, and less aggressive care at the end of life. However, something important that palliative care doesn't do, it does not shorten how long people live. While I personally am not someone who frequently touts the longevity benefit with palliative care concurrent with oncology care, I do think that the landmark TEML study was crucial in demonstrating that patients who receive concurrent palliative care do not live a shorter time. And therefore, this is not in any way a threat to longevity for our patients. In terms of primary versus specialty palliative care, a lot of what I have described thus far has been largely specialty palliative care, including that's what was described as the intervention in the TEML study for advanced lung cancer. So specialty palliative care are specialized clinicians that can be physicians, advanced practice providers, nurses, social workers who provide expert consultation, advice, and care for patients with a serious illness. But primary palliative care are core competencies that all clinicians participating in this virtual Congress already use in the care of patients. This is something that is, I would argue, more important than specialty palliative care for a few reasons. One is that our patients have medical comorbidities and frailty that we need to contend with as oncologists. Two is that the stakes are higher than ever with modern medical treatments, especially and including renal cell carcinoma. And the decision-making that results in patients receiving those treatments is nuanced and complex. There's also in the United States a shortfall of more than 20,000 palliative care physicians and providers and I believe that those shortfalls are probably even greater in some other regions and countries. And this gap is widening by the year. So there will never be enough of us specialty palliative care physicians to care for all of your patients. Because of that, data, what I would like you to walk away with today is a few data-driven strategies that we use in specialty palliative care that can help enhance the primary palliative care that you already provide to your patients to help both your patients with renal cell carcinoma and you as their doctor or clinician to feel as good as possible about the care being provided. So let's start by talking about a challenge that I think is so important and impactful for renal cell carcinoma in 2025. Specifically, I would say that the really high quality treatment regimens that we have to offer patients at this time represent a unique challenge for this disease. And some have described it as an embarrassment of riches. With such high quality treatment regimens that have not been compared to each other, we clinicians do not have a data-driven strategy that is scientifically sound to tell patients that there is one clear winner, one truly scientifically best strategy for all patients. Instead, what we're left with is finding the regimen that's best for every single patient as an individual. So what does it mean when we have a need that isn't met by the science? How can we bridge these gaps? With palliative care strategies, of course. So I would just say that Using some palliative care techniques to learn the patient perspective can help foster really sound decision making. While, of course, it is the clinician's job to synthesize the data regarding expected outcomes and efficacy of different regimens, as well as things like the quality of life that each of those regimens can receive. Understanding a patient's goals can really be a crucial part of bringing the patient narrative into decision making, and that is a very important pillar of shared decision making for renal cell carcinoma as well as any other serious medical condition. Now, goals of care are an oft-cited sort of nebulous term that people seem to think can mean anything from code status to individual preferences for treatments. However, it really is a multidimensional description of a patient's values and how they intersect with their medical care, and it can include decision-making preferences, their fears and goals, their tolerance of medical burden, wishes for family involvement, and what prognostic information they want and when they want to receive it. However, I wanted to highlight tolerance of medical burden because I think this can provide meaningful guidance to us clinicians in mapping patients' goals to a given treatment when they're, even though efficacy may be similar across different treatments, quality of life and or toxicity could look different for different treatments. And so knowing what kind of medical burden a patient is willing to take on and under what circumstances is a really important way that we can get help from the patient in recommending a regimen for them. But the patient's views on trade-offs could be easily missed, and if not intentionally asked. But I would say in general, most patients are willing to take on more burden if they get more for it. That's what I think most of us feel most of the time. But there are still patients who are willing to go through an incredible amount of medical burden for a poor degree of medical benefit, or patients who are not willing to take on hardly any medical benefit, even if we think it could really help them. Elucidating these kinds of goals of care and tolerance for medical burden is difficult in clinic. We are busy and there are lots of factors to consider with every single patient we meet. But I wanted to introduce the REMAP framework to help create a more systematic approach to these discussions and provide meaningful insight into the amount of medical burden they're willing to undergo. REMAP stands for reframing and therefore providing a headline of the medical narrative. E stands for expecting emotion and just being prepared to receive that from patients or observe that in patients and allowing some space for them to experience it. Mapping values, which will be the element of REMAP that I highlight the most on the next slide, aligning with the patient. So summarizing what you hear from them about what their values are, as well as how their medical care could map onto those values, and then proposing a plan by incorporating that into the decision making. Mapping values really is a way of crystallizing the patient's beliefs, their fears, their goals, and associating them with concrete medical options and considerations. In renal cell carcinoma, this is pretty important because we have a number of high quality frontline regimens. And while there are faculty members participating in this Congress who've already done a beautiful job of outlining personalization for treatment decision making, as well as colleagues who have discussed symptom management in order to make all treatments as tolerable as possible, it is important, I think, to have if we have a North Star for what patients are willing to take on that can help make the process as smooth as possible from the beginning. So this can include asking patients about their values directly, or exploring some worries that they may express or any worries they may have had walking in the door to your practice that day, or reflecting on any emotion that you might be observing and asking what is underlying it. Ultimately, when patients are willing and able to share their values with you, that will help signal what they are most likely to take on and can be a springboard for you asking them very plainly the degree of medical burden they're willing to take on for their goals. If patients tell you that their primary goal is longevity, much of the time it's very appropriate and logical to ask, have you ever thought about what it would mean to take on more side effects from treatment to pursue a treatment that's associated with longevity? Patients are prepared for that once we have taken the opportunity to help them describe their values to us. as I mentioned earlier, I think that a three-pronged approach to decision-making in terms of what we as clinicians bring to the decision-making process and what we can derive from our patients can help find the ultimate treatment selection for our patients. However, I wanted to provide you another communication tool that I use in clinic regularly and I think can be extremely helpful, especially in deciding between two good treatment options like what we're often doing for advanced renal cell carcinoma today. So that best case scenario, worst case scenario communication tool was developed for complicated surgical decisions making, specifically emergency surgical decision making. However, it has a great place in the world of medical oncology when doing a comparative decision making process between two treatments. And the process is relatively simple. Once you do it once or twice, you will feel as though you've mastered it and can use it to help concretize your discussion, give you a sense of direction and control, and even send your patients with a little handout that you've made them personalized to them that they can consider after the discussion's over. So the process includes describing two treatment options and the best, worst, and most likely outcomes for those treatments and illustrating on a line diagram. This figure derives from a paper by Dr. Schwartz, who helped develop this strategy as well as validate it. And it includes a visual component, as I say here, which starts by writing on a sheet of paper the names or description of two different treatment options, starting on one of them, drawing a star underneath the words that describe it, where in this diagram it says palliative care or surgery, but it could describe two different systemic therapy options, a systemic therapy option versus observation or versus surgery or radiation, and then verbally describing what the best case scenario is, then drawing a vertical line down the paper to where you draw a box, which represents the worst case scenario, and then you verbally describe the worst case scenario, and then drawing a mark on that vertical line about how close to best case and how close to worst case you think this patient's experience is most likely to be, and then repeating for the other option. I've created a brief clinical vignette here of a patient with PT2 grade 2 non-sarcomatoid clear cell renal cell carcinoma who did not receive adjuvant therapy, but presents at the 12-month mark with lung nodules. This gentleman has decided surveillance is not acceptable to him. And let's say in this case, bear with me, some of you may have feelings about these treatment options, but you're deciding between standard systemic therapy and stereotactic radiation. Using best case scenario, worst case scenario for these treatments that have not been directly compared in a scientific way could include something like this, describing standard systemic therapy. If you describing the best case scenario as having a CR with some side effect burden, but managed well enough to stay on treatment. The worst case scenario as severe side effect burden that results in the patient being hospitalized and having maybe some degree of chronic symptoms, even though their cancer responds. And then the most likely scenario, which in this case, you might describe in the way I've depicted here, perhaps a little closer to worse than best. And then just as an example, please know this is not a global endorsement or indictment of standard systemic therapy. But in any case, talking about stereotactic radiation in a different way, talking about best, worst, and most likely scenario. Ideally, while you wouldn't be writing down your description of these, you could send the patient home with the diagram depicting the line drawing and where you think they're most likely to land. Prognostication is another extremely important challenge for renal cell carcinoma. And while there will always be, at least I suspect during my lifetime, uncertainty in terms of cancer outcomes for our patients, immune checkpoint inhibitor therapy has really made prognostication even more challenging than in the pre-immune checkpoint inhibitor era. We've learned that there are patients coming into us with the hope for the immunotherapy miracle, and it's our job to balance facilitating them, maintaining that beacon of hope while really drilling down and having some practical discussions about most likely outcomes for patients with immune checkpoint inhibitor therapy that are, unfortunately, in most cases, not miraculous. So best case scenario, worst case scenario is a tool that you could use with some of these prognostic challenges, or at least predictive challenges in terms of their outcome, as I've depicted here. However, no matter how excellent a job you do at preparing patients for the best, worst, and most likely scenarios that they might encounter with something like immunotherapy. It still is crucially important for patients to have prognostic awareness throughout their cancer journey, and in order to have sound decision making and for us to be able to meet them where they are and support them as best as possible. So prognostic awareness could really be defined as sort of when the patient understands what we as clinicians understand about their expected medical trajectory and their outcomes. But as we know, patients don't always share in this understanding, which can get in the way of sound decision making. Prognostic discussions are difficult. They're emotionally challenging and time intensive. They're stressful, especially without having a clear and concise strategy. And so I wanted to provide you a communication tool that I use quite literally every clinic day, either in my GU oncology practice or in my palliative care practice, every single day. This is a beautiful paper to which I would direct you about by Dr. Vicky Jackson and others, to providing a communication strategy for cultivating prognostic awareness and delivering prognostic information to patients. We know that these gaps that are so difficult for us to bridge can be bridged, and having a clear path, an algorithm for you to follow will give you confidence you didn't even know you were missing. So the strategy is relatively simple. It starts by assessing a patient's understanding of their illness and their prognostic awareness. We list some questions in this diagram for your consideration. Then inviting them to imagine a worse state of health, asking them a question like, have you ever thought about what might happen if you got too sick to get more treatment, or if this treatment didn't help you the way that we're hoping? Their response to that will help you understand their readiness to receive prognostic information from you, as well as you as their treating clinician will understand the level of medical urgency that they're experiencing due to their state of health and what you believe their clinical trajectory to be. Now, what I would say is that one of these steps, I think, is one of the most important, and what I want to leave you here today. And one of these steps, in terms of how to respond depending on a patient's response to step 2 of asking them to imagine a worse state of health, is this step. So on the left-hand side, on the bottom section, when it says that patient has a disease that's stable, but the patient is not interested in discussing prognostic awareness, this communication guide indicates, and I would support the idea that you don't need to push it. You can allow patients to respect their boundary and move through the appointment. However, if you have a patient whose disease is worsening or you think is clinically declining, but they do not wish to discuss prognostic information, then this is a time to do what I think is the most important step that you can master, and you probably already do to some degree, but you can use in a very strategic way going forward. That is simply described as aligning with the patient and naming the dilemma. Aligning and naming the dilemma should be repeated over and over with time for our patients. And aligning is very simple. It essentially is just a verbal acknowledgement of what you know about what the patient's hoping for. This could be something like, I can tell you really hope that this treatment, it will work better than the last one did. Naming the dilemma is what also can be described as, if anyone who comes through my practice is going to hear me tell a learner that I am going to be using some I'm worried statements. They don't have to be specifically I'm worried. Some people don't feel comfortable using that degree of emotion, but it could also be a statement describing a given medical symptom or phenotype as worrisome or concerning. But using an I'm worried statement would be the second half of the statement that you would say in the aligning and naming the dilemma. So if you started out by saying, you've told me how hopeful you are that this treatment is going to help your cancer more than the last one did, then you could end the statement and phrase by saying, but I'm concerned that the treatment isn't helping you because your pain is getting worse, or that you are losing weight out of control. Aligning and naming, it really is that simple. Those simple I'm worried statements, and as well when preceded by a statement describing your understanding of the patient's goals and hopes, is powerful and will help cultivate their prognostic awareness. Finally, there are situations in which we simply don't have time for more aligning and naming the dilemma. I'm worried statements won't cut it in every scenario. And when this happens, that a patient is clinically deteriorating, then sometimes it is necessary to deliver prognostic information, even if that's not what their preferences are. So when doing this, I recommend that you start with a statement that acknowledges their values, and then provide a statement describing the urgency involved and why it is necessary for you to share prognostic information, even though it is in conflict with their preferences. And finally, then delivering a succinct prognostic statement like, I'm concerned that the cancer is making your body too sick for more treatment. These steps, believe me, it seems too simple to be true, but having a really clear data-driven strategy underlying your approach to this will empower you, as well as give you more efficiency than what you might have, and just give you a sense of safety in these conversations, which can be really, really difficult and emotionally loaded. Finally, specialty palliative care considerations. Who needs specialty palliative care? The American Society of Clinical Oncology has synthesized some of the existing data and recommends specialty palliative care referral for all patients who have advanced cancer and or a prognosis of less than 2 years, even though they acknowledge that specialty palliative care can benefit patients who have a longer expected prognosis. However, as we've discussed, there are not enough of us specialty palliative care docs to help all of your patients. So I'd like to leave you with one final tool that can help with your decision-making in clinic about how to help your patients with renal cell carcinoma and when to think about referring them to specialty palliative care. Specifically, the surprise question. It is as simple as it sounds. Would I be surprised if this patient died in the next 12 months? If the answer is no, that is a patient for whom it is appropriate to consult palliative care. That is true even if the patient still has treatment options available or still has the potential for a deep and durable response to immune checkpoint inhibitor therapy. And I say that because the data doesn't lie. Systematic review and meta-analytic data demonstrates that clinicians are right more often than not, 82% of the time, and that there's even higher accuracy with patients in the oncology spectrum. So I would just say, I would encourage you to consider the surprise question for patients, even your patients who have treatment options available, to help give you guidance so that you can take some of the pressure off yourself in finding the perfect time. So my conclusions are here, and I encourage you to use best case scenario, worst case scenario, remap, naming the dilemma like with I'm worried statements, as well as asking the surprise question in order to help find the ideal treatment regimens for your patients with renal cell carcinoma, identifying their goals as part of shared decision making, as well as providing cultivation of prognostic awareness throughout their cancer journey. And then finally, knowing when to get them to specialty palliative care to augment some of the care that you're already providing and help them have the best quality of life possible. Thank you so much for your time and attention. And I hope you enjoy the rest of this important conference. Thank you.
Thank you so much, Dr. Elizabeth, for insightful presentation. And now we can move on to our next speaker, Petros Grivas, Clinical Director of the GU Cancer Program at the University of Washington. Thank you, Dr. Grivas, for joining us. The floor is yours. Sorry, we can't see your, we can see you. Can you just try once again? Sorry, Dr. Grivas. Can you hear us? We can have 1 minute break till Dr. Kires will rejoin again. Dr. Grivas, can you hear us? Dr. Grivas, can you hear us? Dr. Grivas?
Yes, can you hear me okay?
Yes, now we can hear you. That's great.
Yeah, I
So,
don't know why in the computer it didn't work. I tried so
no
many times.
problem. There is always technical issues, so no problem. Stage is yours.
Okay, can I start now or I need to wait?
No, we don't need to wait. We can start already.
Okay, wonderful. And thanks again for inviting me. How much time we have? I know it's a little bit off time with all the technical issues.
Yeah,
How much time
around
do we have?
15 minutes will be great.
Okay. And if I may ask, because I have limited visibility, how many people we have in the call, and what is the background of the audience, just approximately?
There is so many, approximately 5,000 or like 1,000 people are watching us now, and
Okay, great.
in different backgrounds, mostly oncologists.
Fantastic. Thanks so much for having me. Sorry for the technical issues. We were trying to be creative and use the phone here instead of the computer. I appreciate the opportunity to connect with you. I'm Petros Grivas. I'm a medical oncologist in Seattle. I'm a professor at the University of Washington and Fairhurst Cancer Center. Such a pleasure to be with you and OncoDaily. It's really, I would say, exciting times in oncology. I think it's unprecedented times in terms of the opportunities we have to help our patients and also move the field forward with practice changing research. And I was kindly asked by the OncoDaily team to talk about career development in GU oncology. And there's so much to talk about. And I decided if one of the few times I'm not going to use any slides, which might be good because of technical issues anyway, and just talk about career development in general, including of course kidney cancer. And of course, there are many experts and amazing colleagues in the audience here today, so they can comment, and I want to make sure people can ask questions. So let me start by saying, I was doing some leadership courses in the last few years. And one thing that stands out that I think is relevant to career development has to do with the passion of what we do, right? And the why behind, our actions and our decisions. So, pursuing a career in GU oncology, represents, of course, interest in this disease. GU oncology includes multiple different cancer types, and I think that's an important component of decision making. And of course, kidney cancer is, one of the most common cancers. Very important public health issue, and I would say it represents a need to improve outcomes. So our calling in terms of patient care is obviously timely access to patient care and research and education. I think the importance of the implementation of the science in the patient level is critical. So there are, of course, opportunities for career development in the what I call implementation science, right? Which is how we apply the data in clinical practice. How do we address disparities in healthcare globally, and how can we help bridge the gap between the clinical trial data presentation and what the patient in front of us wants and chooses to do. And I think there are huge opportunities in career development in that regard specifically, because I think there is a need, and probably we don't have enough implementation scientists, I call them, people who can try to intervene to bridge the gap and reduce disparities. The other point I want to raise is obviously, training matters, right? And when I say training, it's not only where, but also what do we do in training? And are we developing skills in patient care that has to be exceptional? Are we developing skills in research? And are we developing skills in mentoring, educating others? And as we start our careers, overall, including, GU oncology, I think seeking right mentorship is very important, especially when it comes to those aspects, patient care, research, and education, specifically research, even more. And mentorship is an art, and is also time and effort and energy and commitment. It's like a relationship, right? You have to be there for the mentee. You have to put the time, energy, and effort to make sure the mentee is successful, because as I always say to my mentees, their success is my responsibility. We take ownership, and that's really, really important, I think, as many of us are involved in mentorship programs. And going back in time for myself, I found, the light, right, in working with great mentors, opening the doors. Mentorship and sponsorship are critical, and they're a little bit distinct. Obviously, broad spectrum here, but in broad definitions. But mentorship has to do a little bit more with particular, projects or research, education, career pathway discussions, helping, the mentee decide what they want to do, direction in research, and, a decision on the next steps in career. Sponsorship is a little bit different, has to do with support. Someone, can sponsor me by, providing access to me to a conference, giving me opportunities, interview me, provide, recognition, social media, talking to other people about me. So all of those aspects of mentorship and sponsorship is very important. And I would say, all of us should keep, pursuing those for our mentees. And of course, even ourselves can still, benefit from those aspects. The other important thing is start early to plan. Early planning is important. It's hard to know what we want to do early in our careers, or even sometimes mid-career. But I think, developing that destination wish, let's say, or the wish list of where we want to go is important. And when we talk about destination, it's, of course, it's hard to know exactly, right, the end result of our journey. But the more concrete and specific we are in terms of the metrics we want to achieve, more, I would say, easier it is to achieve those metrics. And I think, to be more specific, for example, if someone's, is in early stage of career, residency, or fellowship, we talk about what disease type you want to work with, and some may say kidney cancer. And I think specifying that early is not always easy, but can help if that interest is there. Focusing and tailor the energy and research projects. Having said that, even someone is involved in other disease types, research does not preclude, right, to pursue a separate, a career down the road for kidney cancer. I can share with you myself, when I did my PhD after a medical degree back in Greece, I did my PhD in the lab, focusing specifically in colorectal cancer. That was my interest at the time. And then when I started my fellowship, I developed this significant interest in GU oncology, specifically bladder cancer. And I took the experience gained in the colorectal cancer PhD project in the lab to become a clinical investigator doing clinical trials in bladder cancer. So one does not preclude the other. But I think, again, starting planning early helps, and again, connect with people who have the bandwidth and interest to mentor you is very, very important. And mentorship is a continuum, right? We all need mentors, right? I became a professor 3+ years ago. I seek feedback all the time and mentorship. And that, I think, it's a lifelong commitment in our continuous learning. The other point that I just alluded to is feedback. Feedback is a very important aspect. I think many of us have done the ASCO Leadership Development Program, which I recommend to many colleagues here in the audience. If you have the opportunity and you're eligible, think about it. It helps develop, let's say, a lot of soft skills in leadership. And a big part of that leadership course about feedback, both providing feedback and receiving feedback. Both are very important. And I would argue that, it's not easy, right? We are all, not feeling comfortable, right? Providing feedback either to people who have a superior, let's say, status, if I can use that term, or at least they're higher in the rank, or even, trainees or mentees or even peers. But this is an exercise that needs to happen. And I think feedback is critical. I would share with you just something I did myself when I was in a previous institution. And even now, I specifically ask for feedback from people. How can I do better? Nobody's perfect, and we can all improve, right? Including myself. So asking these areas, how can I get better, is important. And if people are not comfortable doing that, give them other ways to do it. Maybe they can leave an anonymous letter in your mailbox, right? Or people who want to be more upfront, they can meet with you, provide feedback, or you can do it through some platforms that exist out there online where you can send messages through a third party to people who you'd like to ask feedback from, and that can be very relevant in building your skills, improving yourself. A couple of more points, and then I will want to leave it up for discussion, which I think is always a fun part. I think it's always important, when we talk about research specifically, to think about projects that are feasible. Feasibility and simplicity is very important. When I started my career, I want to achieve everything in a project, which is not sometimes that easy or even feasible. So I think, the ASCO-VEL course that Rana McKay, for example, dear friend, who I think is part of this program today, and we met in this ASCO-VEL workshop. And one of the things we learned together is about feasibility and simplicity of trials, and how can we attain the results in a timely manner. And the other thing is what keeps you up at night, what makes you energetic and interested and inspired to work on, right? And that's important. Even if this is in a disease that has been evaluated before and in a pathway that has been evaluated before, that's okay, as long as you have a meaningful question that you're passionate about. And I think it's always a balance, right, between feasibility and also having a little bit more a high-risk project, right, with a low-risk project, in order to balance those two things. The low risk can give you a more timely deliverable. The high risk maybe take a little bit longer, but maybe more investment, but still can give you a higher impact. So I think it's a balance of those. And then working with your mentor is very important to try to achieve that. The other thing is collaborations. There is this saying that says, if you want to go fast, you can run yourself. But if you want to go far and further, I think you go with a team. And the other saying is that the strength of the wolves is in the pack, right? So create a team around you. You can lead the team. You can be a member of the team. In either way, I think working with other colleagues and people can help you be better. And, developing this team spirit, how can work with others? How can we synergize? How can we improve upon our roles in a team? Can pay dividends in terms of career development. And these are, of course, across areas of career, but also in kidney cancer. To be a little bit more specific, because kidney cancer is the topic today, there's so much to do. Obviously, the field has come forward significantly in the last several years, but there's still many questions. Are there opportunities for neoadjuvant treatments? We have not been successful in the field, developing, life-prolonging neoadjuvant therapies. How can we do better with that? How about patient selection and biomarkers? KIM1 seems to be a very interesting biomarker, especially in the adjuvant setting. Can we improve upon that? Can we leverage that early data, develop practice informing trials in the future, evaluating biomarkers like KIM1 and others to evaluate the clinical utility, meaning are they going to improve outcomes if we use this biomarker? The other component, obviously, is patient selection, right? And that goes with the biomarker as well. We live in a world where most of patients, we take the approach of trying to personalize as much we can, but we need more personalization. And I think Libby gave a fantastic talk. I was able to capture the latter part of her talk, talking about, what is important for the patients, and of course, asking the patient, don't make assumptions. Ask the patient what they want to do and give them the necessary knowledge and information to make a well-informed shared decision. And I think that's relevant as we, again, think about research questions. What is important for the patient? Patient-reported outcomes, quality of life components. These are relevant to ask in clinical trials, and even more, I think, in kidney cancer. The other thing I would say, even metastatic disease, what are the priorities for the patient, right? Prolonging survival, obviously, a big one. But again, going back to what I just said, quality of life, patient-reported outcomes, how can we develop tools? I think Chris Bergerod from Brazil led a great effort recently developing a patient-reported outcome instrument about patients with kidney cancer. So that's just an example of how you can get a team together and generate a meaningful contribution. And of course, there is no doubt that drug development, developing treatments, combinations, optimal sequence are all relevant questions that can be pursued in kidney cancer, again, in the context of mentorship, context of teams. When it comes to clinical trials, which is one of my favorite topics and expertise, there are several buckets: investigator-initiated trials, your idea that being bounced off a company that may support it, industry-sponsored trials, which is probably the most common phenotype of trials, and also cooperative groups. I know that many of us are involved in, myself, I'm in ECOG Akron, with Libya. I know Rana is in Alliance, and of course there is SWOG and NRG and others. So getting involved with cooperative groups is a great opportunity to get feedback in your project, get involved in trials, accrue in trials, open in your institution, become a champion. All those factors are important and get you visibility, get your networking, which is very important for career development, and also give you direct feedback for your trial concept. And you can start, and expand your career through cooperative groups. So I always recommend that. Other venues like ASCO and ESMO and AACR and of course, in kidney cancer, you have different patient advocacy groups, organizations, KCA, KCS, and others. There are many, of course, others. I don't want to leave anything behind. But getting involved in those meetings, in those organizations, and of course, applying for funding, produce timely work and quality work in a timely manner, but quality work helps build your brand. So sometimes even showing up in meetings, right, and asking a question that is relevant and makes sense, also very important. And proposing trials, even if they don't go through, that's okay. You learn and you move forward, taking the experience. And the last piece I will say is networking, visibility. Social media is a big topic by itself. We can maybe talk about that in another setting, but proper use of social media can help, right? You can get your brand on there, your name, build, again, your network, and try to maintain it, by, again, timely delivery of quality work. I'll stop here. It's great to see with all of you, and even virtually, and I'm open to questions and ideas. It's such a broad topic, but I always get excited to talk about it. Thank you so much for the invitation.
Thank you, Dr. Grivas. Okay, so thank you for this presentation. Actually, this is a wonderful topic, and I would like to say that on X now there is 6,000 people watching us live. So your recommendations were there for young oncologists all over the world, and I believe it's very timely. As young oncologist myself, you have touched the topic of mentorship and finding good mentors. What would be your advice on people sometimes don't know who can be their mentors, where to find these mentors?
It's a great question, Amalia. Thank you for asking me.
You're muted, I think.
Oh,
Just a second.
Can you hear me now?
We can't hear you.
How about now? Can you hear me now? Oh, you did. Oh.
Dr. Grivas, I think I have to stop you again. Can we try again?
Can you hear me now? No? I can hear you, and I'm not muted. Can you hear me now? Yes?
Yeah, I can hear you very well.
Okay, great. We are resilient, right? We talk about resilience And by the way, there is a great book called The Grit, Grit, by Angela Duckworth. It's about grit and resilience. So that's another relevant topic for career development. To answer your question, your great question about mentorship, and thank you for asking, it's not an easy decision, multiple factors, but I think if I can summarize the key points, ask early and go around to meet people who can be potential mentors. Take your time to make a decision based on who has the energy, time, and effort to contribute to your mentorship, who you think is a good fit. There may be great people out there, but the fit may not be there. So chemistry may work, right? May matter. Ask questions that are concrete and specific. And people may be fantastic scientists, but may be too busy and overwhelmed with work. So this may not be a good match. So I think it's important to have this specific concrete dialogue with a potential mentor. As I mentioned, starting early helps, and also spend some time and energy to go through the potential options and talk to people, to maybe mentors and sponsors, but also through that process, get an understanding of how much you feel comfortable with that person and how much you feel that the projects they have are meaningful to you. If you don't like the project, if you don't feel, excited, that may be a concern. I think, the combination of, an energetic mentor who is committed to your success. Everybody's busy, but if they can create the time to mentor you and they're committed to your success, and having a project that is realistic, or projects in plural that are realistic, are key factors. And I will say mentors can be within the institution, but also outside the institution. And it's a broader term, and maybe more than one mentor, maybe a mentorship committee. So don't be afraid to ask questions. Don't be afraid to seek explicitly mentorship in your institution, but also broadly by contacting other people, leaders in the field. And through that networking, you may find a great fit.
Okay, you have answered all of my questions I wanted to ask. So I would like to ask whether you can do only one mentor or not. But indeed, I think you're right. And for our young generation, and for me myself, I think one program could be an option. ESMO, ASCO, and ESO are offering a lot of mentorship options, and anyone can apply. Even you don't know these people, they are very famous people, but sometimes they really are there to help. And these kind of programs could be the first option to just put you on the same level and give the platform to communicate. And you have also mentioned social media. I've never seen you before. I've only communicated with you on social media, but I think because of that, when I met at ASCO, I could come approach and see. So what would be your hint with that, how to use the social media for young generation?
It's a great question. And I remember when we met in person, it's like we knew each other before, as you said. I think social media represent a great opportunity, and again, proper use. Some people are worried about them. I understand that, but I think with a proper use, with the right scope, can be a very positive factor. I would say that getting out there, introduce yourself, to the world, by saying who you are, what do you want to achieve, what your current, training status or faculty status, or whatever your current career is, and where you want to go. I think it's a great start, and you can, potentially comment on other people's work. You can highlight your work. We're all, support humility, of course, but I think it's not wrong to get out there and say what you did. If you present in a conference, if you present it in a oral presentation or a poster, if you gave a talk somewhere, or if you publish a manuscript, if you got some funding, if you're applying for all these things, it's okay. You can go ahead and present that. Tell the world what you're looking for. Get the feedback from your work. Also make sure you're supportive of others. Keep, of course, the kindness and politeness in every interaction you have. That's a North Star, how we interact. But I think the social media isn't, for some people, an easier. Some people may be harder. I understand both. And some people may be more extroverted, more introverted, and that's okay. I think it's a great venue to kind of introduce yourself, meet people, and then, as you mentioned, you go to a meeting and you meet that person in person, and then have a wonderful dialogue. I think it can be utilized properly, and sometimes underutilized. And there are many social media out there. People may choose their favorite Of course, again, mentorship and training can also help, because there are proper training programs that institutions may have on social media use. And to your previous point, Amalia, I think it's a great point you mentioned. ASCO and ESO and ESMO and ASCR have proper mentorship programs, and this can also put like an established, let's say, faculty member in an institution to who a junior faculty or a trainee or even medical student who is far away, and this is a great mechanism that I always encourage.
Thank you, Dr. Rivas, for inspiring, encouraging, and give us voice on how and tips on how to navigate our career at the early stages. This was very inspirational talk. Thank you for being with us today, and it was really a pleasure to have you with us.
Thank you so much for the invitation. Thanks for all you're doing. And don't forget, sky is not the limit. I come from Greece myself. I went to medical school in the University of Patras in Greece. I could never imagine how the career would evolve. So don't put restrictions, to ourselves. Always work harder. And the goal is, how can I get better tomorrow myself compared to what I'm today? That, I think, is something that we always try to achieve. Self-improvement and collaboration with others.
Thank you. That was perfect. I will ask our team to have the quotes from this, definitely. And thank you. So with that, we're going to move forward with our next presenter. I can see... hello, Dr. Yue Chen from USA, who is an assistant professor of medicine and medical oncologist at UC San Diego Health. And we're coming back to our research and kidney cancer. And we're going to be talking about the integration of HIF2 alpha inhibition in renal cell carcinomas. Thank you for accepting our invite and being with us.
Okay. Thank you so much. Can you hear me clearly now?
Just a second. Yes.
Okay, appreciate it. Yeah, thank you for this invitation. It is my great honor to be here to talking about a topic, integration of HIF2 alpha inhibition in RCC. So for today's presentation...
Before moving, I'm very sorry to stop you. Please, can you put in the presenter mode so it's full screen, and I'll leave the floor to you.
Oh, sorry, is that presenter? I think it was, right? What about right now? Does it work?
Well, from the PowerPoint. No, it's not a presenter mode now. Can you try again? It's okay. Yes, that's is good. Yeah, perfect. This works. Great.
It works.
But yeah.
Okay, so I'll just stay like this.
Yes.
Okay, yeah, no, so thank you everyone. So for today's presentation, I'll review the role of VHL HIF2 alpha pathways in RCC briefly. We'll summarize the VHL syndrome results of LIFESPARK 004, which investigate belzutifan in VHL-associated tumors, including RCC. And then we'll discuss the safety profile of belzutifan. We'll examine the efficacy data of belzutifan in combination with VEGF TKIs. And in the end, I'll highlight some ongoing trials of belzutifan in adjuvant first-line and also refractory RCC. And lastly, we're talking about some emergent studies of other HIF2 alpha inhibitors. The slide's showing okay? Okay, so the VHL gene plays a critical role in oxygen sensing through the regulation of the HIF2 alpha transcription factors. In normal oxygen level, HIF2 alpha is degraded through the ubiquitination and proteasome systems. In low oxygen level, HIF2 alpha is dimerized with HIF1 beta and leading to activation of the hypoxia response genes such as the VEGF and EPO. As many of the audience are aware that more than 80%, 90% of sporadic clear cell RCC tumors harbor VHL alterations. So I just want to spend one slide talking about the VHL disease. It is a germline mutation in the VHL tumor suppressor gene. It is inherited as a autosomal dominant fashion, and the penetration is high. Nearly more than 90% will have presentation of the symptoms by age of 65. The common tumors associated with VHL disease is the hemangioma. It can happen in the CNS system as well as the retinal hemangioma in the eyes. It can present as the clear cell RCC in kidney cancer in the kidneys, and also the pancreatic neuroendocrine tumors on the pancreas. So the first study I would like to discuss is the LIFESPARK 004, which included patients with VHL disease based on germline alterations. And these studies investigated belzutifan 120 milligram daily dosing, and the primary response rate, the primary endpoint is response rate. So when this trial was first published, the response rate in RCC was 49% with 0 PD rate. And the response rate in pancreatic lesions was 77%, and the response rate CNS hemangioblastoma was 30%, and almost 100% of the retinal hemangioma had improvement. So based on the initial results, the FDA approved belzutifan for cancers associated with VHL disease. At this year's annual ASCO, Dr. Narayan presented the updated analysis of the LIGHTSPARK 004. As we can see here with extended follow-up data, the RCC response rate just increased higher, about 70%, and the PD rate is 0%. About 93% of the tumors had experienced a reduction in target lesion. Here is the duration of response of the VHL-associated RCC. As we can see here, the 4-year landmark of the duration of response, about 76% of RCC patients remain in response. Here is the response of the VHL-associated CNS hemangioma. About 50% of the hemangiomas remain response, 50% response rate, and the PD rate was 60%. And 97% of the patients who had measurable disease experienced reduction in their CNS hemangioma. Here showing is the duration of response by landmark 4 years, and about 80% of the patients with CNS hemangioma treated with belzutifan remain in response. Here is the result showing the VHL associated with pancreatic neuroendocrine tumor, and 90% is the response rate, and the PD rate was 0. And 100% of the pancreatic neuroendocrine tumors in VHL disease patients treated with belzutifan had experienced reduction. Here showing you is the duration of response of the pancreatic neuroendocrine tumor at 4 years landmark. 94% of VHL-associated pancreatic neuroendocrine tumors remains in response. Here is the table showing you the RCC data of the belzutifan treated VHL RCC at a 2 time point. I wanted to highlight here is that extended follow-up data, the response rate just get higher from 49% to 70%, and the landmark progression-free survival at 4 years at about 76%. Time to response remains similar at 8.5 months, and the duration of response has not been reached. Now move on talking about the belzutifan monotherapy in the LIGHTSPARK 005 study. So the LIGHTSPARK 005 investigated clear cell RCC patients who previously had 1 to 3 lines of prior systemic therapy, including 1 anti-PD-1 inhibitor and also 1 VEGF TKIs. This study randomized patients 1-to-1 between the belzutifan versus everolimus, and the primary endpoint was progression-free survival and also overall survival. This study included a heavily pretreated patient populations. 45% of patients had 3 lines of prior therapy, and 42% of patients 2 lines of therapy, and 12% had 1 line of therapy. On the left corner side, I'm showing you the progression-free survival. The median progression-free survival was similar, 5.6 months in both arms. In terms of landmark progression-free survival, we can see that belzutifan was associated with higher 24-month landmark progression-free survival, 17.5% versus 4.1% for the everolimus. Below showing you the subgroup analysis of the PFS data by the subgroup, and we can see the signal here is quite consistent, favors belzutifan. However, in this data set, we didn't see a clear differences of the overall survival benefit comparing belzutifan versus everolimus with a hazard ratio of 0.92. Here showing you the response rate of belzutifan versus everolimus, and the belzutifan response was about 23%, and the median duration of response was 19.3 months. Here I want to highlight here is the high PD rate of the belzutifan in this data set. It was found to be 34%. This slide showing you the patient-reported outcome data as well as the quality of life data what we can see here is that belzutifan is associated with prolonged time to deterioration of the quality of life and also the patient-reported outcome metrics compared to everolimus. Here, I would like to break down the PFS data by the IMDC risk group. As we can see here, the PFS was longer in IMDC favorable risk subgroup. The median PFS was about 11 months versus 5.3 months among intermediate and poor risk patients. Here is another subgroup analysis of the PFS by lines of therapy. As we can see, when we look into the subgroup of patients who had one line prior therapy, the median progression survival was 9.1 months. However, for 2 prior lines of therapy or 3 lines of prior therapy, the progression-free survival just get smaller, 3.8 months versus 5.5 months respectively. This is a important summary report analysis of the 4 clinical trials presented by Dr. Shuri last year at the KCRS meeting. So this abstract summarized 4 clinical trials and pulled the safety data with a total of about 576 patients of belzutifan. What we found here is that the belzutifan, in terms of any cause of grade 3 or above adverse events, it was about 62%. In terms of treatment-related grade 3 and above adverse event, it was about 38%. However, the treatment discontinuation rate is low, about 6%. Anemia and hypoxia are on-target toxicities associated with belzutifan, and we see that for grade 3, 4 anemia occurred in about 29% of patients, and grade 3 and 4 hypoxia happened in about 12% of patients. In terms of the management of the anemia, evaporating stimulating agent was given in about 23% of patients, and 18% of patients received blood transfusions. And at about 30% of patients got both erythropoietin stimulating agents and also blood transfusions. This is an important table, highlights the time to first onset of adverse events that is attributed to belzutifan. As we can see here, most of the side effects happened in the first 2 months. And for the on-target toxicities, anemia and hypoxia, they happen around in the first month, 30 days. Now I would like to move on to another study investigating belzutifan plus cabozantinib combinations. These studies included 2 cohorts. Cohort 1 included patients who are treatment naive, and cohort 2 included patients who had a prior immunotherapy and less than 2 regimen of metastatic RCC treatment history. And the primary endpoint for this study was response rate. So here is the data showing you for cohort 1 is the treatment naive cohort, which shows the combination demonstrated a response rate of 74% with the median progression-free survival around 30 months. Cohort 2 showed a response rate of about 37% in previous treated RCC patients with a median progression-free survival about 14 months. Now I would like to move on to the Keymaker study. Keymaker study is an umbrella study which investigated several combinations of treatments in clear cell RCC patients who had a prior disease progression after PD-1 or PD-L1 inhibitors. One of the arm B5, which investigated lenvatinib 20 mg plus belzutifan 120 mg, and the primary endpoint for this study was response rate. Here showing you the data of this combination belzutifan 20 mg plus belzutifan 120 mg plus lenvatinib 20 mg in the cohort of about 64 patients. The response rate is 47% in this arm, and the median duration of response is about 22 months. Here, this cohort is a heavily pretreated patients. About 42% of patients had more than 3 lines of prior treatment, and 36% of patients had 2 lines of prior treatment, and 22% of patients had 1 line prior treatment. This is a summary table included the data showing belzutifan with or without VEGF TKI in the refractory RCC setting. The first row showing you is the belzutifan data monotherapy from the LIGHTSPARK 005. The response rate was 23% in this cohort, and the PD rate was about 34%. The median progression-free survival was 5.6 months, and the median duration of response about like 19 months. The second row showing is the LIGHTSPARK 003, the cohort 2 pretreated RCC dataset investigating belzutifan plus cabozantinib. The response rate is about 31%, the primary PD rate 6%, and the median progression-free survival 14 months, and the median duration of response about 30 months. Last one is the belzutifan plus lenvatinib data, response rate 47%, PD rate 11%, median progression-free survival 12.5 months, and the median duration of response about 22 months. So overall, we got a signal there by adding the VEGF TKI to the belzutifan monotherapy. The response rate gets higher and also decrease the PD rate. The median progression survival and the median duration of response gets longer. Now I wanted to highlight one of the ongoing study of the LIGHTSPARK 022, which investigated pembrolizumab plus belzutifan in kidney cancer patients after nephrectomy. This study also included MYNED cohort. So eligible patients will be randomized between belzutifan plus pembrolizumab versus placebo plus pembrolizumab infusion for a year. And the primary endpoint is disease-free survival. Another important ongoing study is the LIGHTSPARK 012 study, which is a frontline study investigates pembrolizumab plus lenvatinib with or without belzutifan or crovalimab, which is a CTLA-4 inhibitor in a first-line advanced clear cell RCC patients. The primary endpoint of this study was PFS and also overall survival. Another ongoing study is the LIGHTSPARK 011 study. In this study, belzutifan plus lenvatinib was investigated compared to cabozantinib in advanced RCC patients after anti-PD-1 and PD-L1 therapy. So in eligible patients will be randomized between those two arms, and the primary endpoint is progression-free survival and also overall survival. Now I will move on talking about another novel oral HIF2 alpha inhibitor, casdatifan. This ARC-20 is a phase 1 dose escalation and dose expansion study of casdatifan, and which investigated casdatifan 50 milligram twice daily, 50 milligram daily, and also 100 milligram daily in their dose expansion cohorts. So casdatifan 100 milligram daily dose showed rapid response and also favorable safety profile, and with response rate about like 33% and a low PD rate about like 7%. And casdatifan 100 milligram daily dosing has been selected for further development in future studies. In terms of adverse events, greater than 3 or greater than 3 treatment emergent adverse event was about 28%. In terms of anemia, grade 3 and above anemia was about like 70%. In terms of hypoxia, grade 3 or above hypoxia was about only 10%. And the discontinuation rate is very low, about like 3% for patients with hypoxia, and it was 0 for patients with anemia. There was another expansion cohort investigating casdatifan 100 milligram daily dosing in combination with cabozantinib 60 milligram daily. The objective of this study was to evaluate the safety and preliminary efficacy of this combination in clear cell RCC previously treated with anti-PD-1 or PD-L1. And this below is the breakdown of the number of prior regimen in this data set. About 70% of patients had 2 lines of therapy, 83% of patients had 1 line prior therapy. In terms of prior therapy, 60% of patients got IO only, and 40% of patients got a VEGF TKI plus IO. In these preliminary results, casdatifan 100 milligram and cabozantinib 60 milligram daily combinations, the preliminary response rate is 46%, including 4% of CR and also 42% of partial response. In terms of toxicity profile, the anemia grade 3 or above adverse events happened about 24%, and hypoxia was about like 7% for casdatifan. There is an ongoing phase 3 study investigating 100 milligram casdatifan plus 60 milligram cabozantinib versus 60 milligram cabozantinib in clear cell RCC patients with a prior anti-PD-1 or PD-L1 therapy. This is a randomized design 2-to-1 fashion with the primary endpoint of progression-free survival. Here is another novel HIF-2 alpha inhibitor, NKT2152, in patients with previously treated advanced clear cell RCC patients. So basically, this study investigated 4 daily doses and also 4 loading maintenance dose regimens evaluating this early trial. What they found was that NKT2152 showed significant prolonged EPO suppression at all dose levels, and the overall response rate was about 20%, and median progression-free survival was about 7.4 months. Currently, there are 2 loading and maintenance dosing schedules have been selected, and the study is ongoing. In the end, I would like to highlight Dr. Rana McKay's presentation at this year's annual ASCO. This table summarized the 4 agents. We didn't get a chance to get into the last one, but this table summarized the belzutifan, casdatifan, and NKT2152 in terms of the parameters, characteristics in this summary table. So take-home message for today's presentation: belzutifan is the first FDA-approved HIF-2 alpha inhibitor for treatment-refractory RCC. Ongoing trials are evaluating belzutifan in adjuvant, first-line, and refractory settings in combination strategies. Anemia and hypoxia are on pathway toxicities, but the overall safety profile is generally favorable. Additional novel HIF-2 alpha inhibitors are under active investigation in RCC. Here is the end of my presentation, and thank you very much for your time. And again, thank you again for this opportunity for having me here today.
Thank you so much for a wonderful and insightful presentation. It's very honored to have you on board. And now we can move on to our next speaker. Please welcome Zhang Hao, Professor of Urology at West China Hospital. Dr. Zhang couldn't join us live. We will be viewing his per-recorded presentation. Please.
Hello, everyone. I'm Dr. Zheng Hao, a urologist from West China Hospital, Sichuan University. It's my pleasure to be invited as a speaker here. Due to the time zone difference, so I have to pre-record a radio for you and apologize for not giving a live presentation. Today, I'd like to introduce some current status and improvement in the treatment of kidney cancer in China. In my impression, there are at least 3 times reports about the global cancer statistics in the past 1 decade. Every time we could find that for both 6 combined, it is estimated that nearly 1/2 of the new cases and over 1/2 of the cancer deaths in the world will occur in Asian region, in part because of close to 60% of the global population residents there. In the field of genitourinary cancers, global statistical data show that the incidence of PC, UC, and RCC increase year by year. Only the mortality of the RCC is declined from 43% to 36%, while the mortality of UC and PC seem to maintain stable in the past 4 to 5 years, which implies that earlier diagnosis through the images following the curative surgery and more effective systemic therapeutic agents could contribute further improve the clinical outcome of RCC. How about the situation or status of RCC in China? In 2022, Global Cancer Statistics Report Among RCC population, China is ranking #1 in the incidence of kidney cancer. It is very surprising, but reasonable to explain. I think it is mainly because of large population base with relative good image screening. Analysis based on age standardized rates show that actually China is not the country with highest incidence of kidney cancer. North American and European regions have the highest ASR of incidence, while in the aspect of deaths, age standardized rate of the mortality in China is very similar with that of the other Asian countries, but higher than countries from other developed regions. Totally, 5-year overall survival rate in China reached to nearly 75%, but the data is just from high volume medical center, just like our hospitals, which seem to be better than developed countries. But if you look at the global cancer statistics, 120 cancer registry sites from China, you could find that more than 70% of the sites were small to medium-sized cities and rural area of China. The real incidence of RCC should be higher than estimated, and deaths from RCC should be even more discouraging. So in China, it is necessary for government, for doctors, and for patients to further extend recommended and receive ultrasound CT, MRI examination in order to discover earlier stage of RCC. In clinical practice, when someone was suspected renal malignant tumor by CT or MR scan, usually surgeon would like to do operation directly without biopsy, while tumor staging and tumor ferment grading or ISUP grading would definitely impact on surgeon's decision and the following surgical plan. Undoubtedly, unsuitable and imperfect surgery may lead to the disaster to our patients. So how to accurately evaluate kidney cancer before surgery is of importance. Several RCC teams in China and all over the world now have focused on the construction of image alarm or warning system to help surgeon making correct decision before surgery. Radiologists from Chinese team such as Western China Hospital, Sichuan University, and Tongji Hospital, Wuhan University of Science and Technology, using AI technique, analyzing RCC image textures, and then construct models predicting T staging or ferment grading before surgery, which could further help urologists design precision or individual surgical plan, do nephro-sparing surgery or not do. Our team, together with radiologists in our hospital now, is trying to construct a learning system based on functional MRI to predict aggressive renal cell carcinoma, help surgeons change or reconsider their surgical strategies and maximally achieve radical treatment. And now the result result analysis has completed, and we are just writing a manuscript. And precision pathological diagnosis with kidney cancer may be another clinical problem with the greatest difficulty among genital urinary malignant tumors. With the development of molecular pathology and genomic testing, diagnosis of RCC has entered the era of molecular diagnosis. In the latest edition of WHO classification published in 2020, we can see that at least 11 molecular driving kidney cancers have been nominated, and including FH deficient RCC, ELOC RCC, SMARCB1 deficient RCC, and so on. In China, several departments of pathology from high volume medical centers, including Shanghai Fudan Cancer Hospital, Shanghai Renji Hospital, the first affiliate hospital of Peking University, Sun Yixin Cancer Hospital, and also our hospital have achieved specialization of pathological diagnosis so as to reach the international standard as soon as possible. Pathologists would be in charge with different fields of pathology based on different organ systems. Professor Chen Ni is one of outstanding uropathologists from our medical center, who was invited as one of members of 2022 WHO classification, attending chapter with FH deficient RCC. Here, I'd like to take FH deficient RCC diagnosis as an example to exhibit the effort from pathologists in China. As shown in the left pictures, FH deficiency RCC has very high aggressive biological behaviors, and it is highly worthy of the attention from clinical doctors. While its pathological diagnosis is so difficult to lead to misdiagnosis. Firstly, FHRCC has lots of morphological features in HE slide, which usually make confusing with classic papillary RCC and easy to misdiagnosis without differential diagnosis. And even IHC standing with FH and 2SC, at least 10% of the FHRCC will be still misdiagnosed in clinic. In order to improve the diagnosis of FHRCC in the past 7 to 8 years, our RCC MDT team, together with several medical centers in China, constructed one of the biggest FHRCC clinical and bioinformation database in the world. And based on this database, we successfully constructed an artificial intelligence model, WCH-FHPM model, to predict the possibility of FHRCC with HE slide. And at the same time, a novel molecular biomarker, AKR1B10, has been added into FIRMA triplet molecular diagnostic tool for clinical diagnosis. Finally, wanted to achieve almost 100 accurate diagnosis with FHRCC. You can see in the left bottom, there is a website link. If anyone is interested, you can just log in the website, upload your HE slide, and the platform will tell you the possibility of FHRCC, and then pathologist could make a decision if the sample need or need not to do duplet or triplet IHC standing to exclude diagnosis of FHRCC. Finally, every FHRCC diagnosed with pathologist would be recommended to do genetic testing to further clarify the pattern of mutation, which may be help clinical doctors to predict a prognosis of this disease. Of course, in the past 2 to 3 decades, the treatment of kidney cancer, including surgical techniques and systemic regimen, has been received a significant improvement. In the aspect of surgical technique, we could see that maybe surgical improvement in China could be divided into 3 stages. Before 1990, almost all of the surgery with kidney cancer was underwent by open surgery with higher perioperative complications. During the second stage, laparoscopy techniques have helped RCC surgeon enter the era of microinvasive surgery, and lots of RCC patients could get laparoscopic radical nephrectomy, and more RCC patients could be considered to do or to complete nephron sparing surgery to achieve the balance of tumor control and renal function preservation. After 2000 years, minimal invasive technology underwent another revolution. The appearance of a robotic surgical system, including Da Vinci and several domestic robotic systems from China, make the surgery easier, simpler, and safer. Telesurgery between Beijing and Sanya, between Beijing and Rome, has placed China's urological surgical techniques leading the world. Due to the evidence support neoadjuvant therapy before surgery among patients with venous thrombus, more and more surgeons in China would like to consider systemic therapy before thrombectomy in order to decrease operation difficulties and decline the perioperative complications. Usually, non-clear cell RCC have very poor prognosis. What is the role of surgery among patients with this kind of aggressive disease, and how to do the surgery for these patients? In the clinical practice in China, urologists from several high-volume medical centers would plan their surgical strategies through the ongoing construction of image learning system. After careful pre-operative image evaluation, urologists would plan individual surgical plan for each of the patients suspected with histological variant RCC. And after clinical exploration for about 5 to 6 years, Chinese doctors have reached a consensus. And when we plan to do surgery for this suspected non-CCRCC, we would pay more attention as following. The first is considering the importance of radical nephrectomy plus retroperitoneal lymph node dissection in some subtypes of non-CCRCC even without any image clues. And the second is undergoing nephro-sparing surgery with a widened margin. Just means the margin should be at least 6 to 10 millimeters outside the tumor capsule in selected patients. And the third is the maximal discussion of visible tumor lesion among local advanced non-CCRCC before the systemic therapy. And globally, now 6 combination therapeutic treatment has obtained FDA or EMA approval, and several combos has been covered by national medical insurance outside China, which could definitely ensure patients receive the best therapeutic strategies and at the same time could decline financial stress of patient and their its family. And in China, till now, unfortunately, none of these 6 combination therapy has got CFDA approval and covered by national Medicare. And if patient wanted to receive IO-based combination therapy through out-of-pocket expense, doctors in China have to repeatedly tell them the risk of combination therapy, and after sign the informed consent, and then we could help to balance the side effects and efficacy evaluation. But good news for Chinese RCC patient is coming recently till 2024, after a result from Renal Oncology study published on Annal of Oncology. CFDA quickly approved this kind of treatment as a standard of care for the first-line therapy among MRCC. Patient could get one of the best IO-based combination therapy under the national financial support. And after published on Lancet Oncology, allottinib plus bemo-torbal has been quickly approved by CFDA, and now it's just waiting for being included in the national reimbursement drug list of China, so that the drug cost could be covered by the national medical insurance in the soon. And picture on the right side is a recent national survey for RCC systemic therapy, and the results show that axitinib and toripalimab are the most commonly used TKI and IO drug monotherapy in China. And due to the indication, accessibility, and the national medical insurance support, axitinib plus toripalimab is the most commonly used combination therapy in China. In the future, once allottinib plus bemo-torbal is included in NRDL, patients in China would have another affordable combination selection in clinical practice. And how about the efficacy of systemic therapy for metastatic RCC in China? Again, I'd like to take our hospital RCC database to show the efficacy of systemic therapy, including TKI monotherapy and IO-based combination therapy as the first-line therapy from 2010 until 2024. Our database collected almost 900 patients received effective systemic therapy. Before 2018, a majority of patients could get TKI monotherapy as first-line therapy, while after that, a growing number of patients have more opportunity to receive IO-based combination therapy as first-line therapy. And among MRCC population, proportion of patients receive first-line, second-line, and the third or multiple line therapy was 95%, 50%, and 22% respectively in our hospital. The ratio is much similar with the situation in other countries. Since 2017, our RCC research team began to focus on the treatment of non-CCRCC, and in 2021, with the support from China and Anti-Cancer Association, CACA, we constructed real histologic variant RCC collaboration group in the country, including at least 28 high-volume hospital attending. So we could see that in our database, ratio of non-CCRCC was as high as 37%. Furthermore, compared to classic CCRCC, more non-CCRCC patients would receive IO-based combination therapy as their first-line therapy. And as we all know, after 13 to 24 months, a patient would face to drug resistant with IO-based combination therapy. In the Western countries, maybe a majority of patients failure from IO-based therapy would change to TKI monotherapy as subsequent strategies. IO re-challenge is seldom chosen due to lack of strong evidence, while in China, due to insufficient TKI accessibility. For example, in China marketing, we could not get cabozantinib and only have domestic lenvatinib available, but without clinical trials about RCC to validate its efficacy. And in the other hand, while in Chinese marketing, PD-1 antibodies has more favorable acceptability. We have at least 3 to 4 kinds of PD-1 agents, such as toripalimab, sintilimab, tislelizumab, and calizumab, and even imported pembo and nivo. So a certain proportion of the patients failure from IO-based combination therapy would receive IO rechallenge in the following therapy. And we do observe some extent of the survival benefit in clinic. And here is show the efficacy of TKI monotherapy and IO-based combination therapy in our hospital. Totally IO-based combination therapy could get better clinical benefits than TKI alone, regardless of histological patterns. And even among patients received TKI monotherapy as a first-line therapy, patient could still get nearly 4 years survival prolonging with reasonable sequential therapy. And as mentioned above, with the help and support from Rare Histologic Variant RCC collaboration group, Chinese urologists are trying to explore the optimal therapeutic strategies for non-CCRCC. We have completed the molecular feature description of TCEB1 mutated RCC, FHRCC, and TFE3 rearrangement RCC, and launched several prospective clinical trials. Sintilimab plus axitinib could be a new option for patients with advanced FHRCC, regardless of germline or somatic mutation. For patients with TF3 RCC, we proposed and emphasized the testing for the fielding subtypes through RNA sequencing, because ASPR TFE3 fielding RCC may be the best subtype for the IO-based therapy, and other fielding subtypes need to explore novel strategies in the future. And in the field of non-CCRCC, Chinese doctors are always on the way. Of course, there are so many challenges in the treatment of RCC in China and in the world. And first of all, as we all know, in the Western countries, nivo plus AP may be the most commonly used combination therapy in the real world, while in China, this kind of combination therapy is less than 1%. The reason is not only the problem with drug accessibility. Another important problem is the safety administration with nivo plus AP. In China, a majority of systemic strategist decision was made by urologists, but not oncologists, and the follow-up and AE administration still belong to our urologists. So urologists were afraid of safety of dual immunotherapy, and then they have to choose TKI plus IO because of their more experience about this kind of administration. And further, strengthening collaboration with oncologists through MDT teams construction is of very much importance for Chinese patients, suitable and reasonable prescription. And secondly, the treatment ability among different regions and cities around China has huge disparity. The treatment efficacy you can see maybe only represents the efficacy from high volume hospitals. The condition in rural regions and small cities is not optimistic. In the future, how to narrow or balance the medical gaps between developed and underdeveloped region in China is worthy of deep thinking. And I wish our government need to carry out some policies to finally achieve medical homogenization in China. And that's all for my today's presentation. Thanks a lot for your your listening, and I wish I could have the opportunity to communicate with all of you face to face in the future. Have a nice weekend. Weekend. Bye bye.
Thank you so much. We also wish that Dr. Zhang will be with us next time. And now we will move to our next speaker, Dr. Karima Ola, Professor of Medical Oncology at the Hassan II University Hospital in Morocco. And Dr. Karima will talk about the current state of renal oncology in Morocco. She couldn't join us live. We will be viewing her pre-recorded presentation. Please.
Hello, everyone. Happy to join you in this meeting about Global Voice in Renal Oncology in virtual, hoping that next time we can make it in person. Thank you all for the invitation, and specifically about this topic, which is the current state of renal oncology in Morocco. As we know, all the recommendations and the guidelines about cancer treatment are the same everywhere, but the challenge is their application in reality, because we do not have all the same condition of work, of access to treatment, same priorities, etc. So I will be happy to share with you my talk about the current state in Morocco. And well, as way of background, if we take the last Globocan statistics, so we can see here that for Morocco we do have 63,000 new cases per year, and the number of this is around 36,000. Just also by way of background, so Morocco is an African country in the North Africa, and the estimated population based on the last statistics is 36 million citizens. So when we have a look on the most frequent cancers, you can see here that globally we join the universal statistics. So for male patients, so we do have lung cancer that is the most frequent, followed by prostate cancer, colorectal, and we have bladder cancer in the fourth rank. And for women, it's as expected, breast cancer, followed by it was cervical cancer, colorectal, and then thyroid cancer. But at the last version of the registry of Casablanca that I will show you next slide, so we had some slight changes in terms of order of frequency for women. So this is the registry I talked to you about, the registry of Grand Casablanca, so the great region of Casablanca. As you know, so Morocco has like 12 regions, that we have Casablanca and Rabat, the two cities, the two regions that have their big registries, and the statistics are based on those two registries. So for sure it doesn't cover all the population, but it gives significant idea about the frequency of cancer. So we can see here, as I told you, that for male lung cancer, prostate cancer, then colorectal, and the bladder cancer, it's the same order of frequency. But for women, so we are happy to see that cervical cancer, that was the second cancer after breast cancer, so went to the fourth place. I think this is thanks to vaccination, anti-HPV, and raising awareness about cervical cancer, early detection. And just to let you know that we have well-established program of screening in Morocco for breast and cervical cancer for women. So we do have what we call Plan National de Prise en Charge du Cancer. That's like a national plan to take care of cancer in Morocco that has four main axes: prevention, early detection, diagnosis and treatment, and also supportive and palliative care. So it's a 10 years plan. So we already went through the first one from 2010 to 2019, and then the second one is ongoing now from 2020 to 2029. So if we want to have a look on the patient journey, cancer patient journey in Morocco, it's like everywhere. So we have the flow of symptoms, then diagnosis, announcement, the MDT, then announcement of the strategy of treatment. But when we have deeper look on that, it's not always that easy because the access to cancer care institution was not that easy in the last decade, but now we are having a real revolution in terms of access to cancer care centers in Morocco, because now all the 12 regions of Morocco have their cancer centers, because like 20 years ago, so most of patients to be treated, they have to move to the big cities, which are like Casablanca and Rabat. But now there is a big partnership between public hospitals and also private clinics, and we do have now cancer centers, so in all the regions from the north to the south. But we still have some challenges and barriers. For example, here I show you work that was done in terms of access to treatment to see how much, or to quantify the delay in to seen in access to treatment. And you can see here that we have like 69% of patients that have like more than 40 days to have access to cancer treatment, so which is for sure impacting the outcome of those patients. Well, I can say before moving that the main reason of that delay, this work that was performed in Morocco, was the distance to arrive to cancer center. That's why I insisted on now the availability of cancer centers in almost all the regions of Morocco. Well, as we said, so the cancer care journey, so in Morocco is like everywhere else in the world. So it can be summarized in a slide, but it's really complicated in real life, because you have to go through big process involving, so from the GP to the organ specialist, then to radiologist, biologist, pathologist, and at the end to arrive to a structure where we can have all those actors together and to have a good MDT to decide about the cancer treatment or the cancer care of those patients. So I also want to mention, I don't want to be pessimistic or negative, but this is something really that we would love to change very quickly. It's access to clinical trials in Morocco, because we have very few clinical trials in Morocco than in general, and specifically in urology also and renal oncology. And we know all the benefits of clinical trials. It makes the access feasible and the treatment available for patients, because they don't pay for. So it's a new chance. It's a chance to be treated adequately based on the new genomic molecular features and have more accurate treatment in the era of precise oncology that we have now, and immunotherapy and all the advanced treatments. So that's why we are really trying to see with our authorities on how to make the feasibility of trials in Morocco very easy. And we do ask also pharma companies to include Morocco and all other African countries in the trials, because there is big disparity in terms of access to clinical trial. That's why when we see the total health expenditure per capita in the world, you can see that if I take Morocco here, so it's the North Africa, it's not that high health expenditure, because we are limited resource country for sure. That's why. But also we know that the clinical trials are not equally available in the world. You can see here that Africa, for example, had very few number of trials. So I think the fewest number of trials are here in Africa. When we compare to North America or to Europe, for example, or even to Asia. And here you can see that when we have a look on the clinical trials by US and rest of the world, you can see that most of them are located in the United States of America, specifically for the early phases. And that's why I want to give you this background before introducing or before continuing with the work done in Morocco to show you the state of art for renal oncology. So here I mentioned this study taken 10 years or from 2014 to 2024. And you can see here that we included patients treated in our department for renal cancer. And here you can see the frequency over years. So it's really very heterogeneous. So we had some years with more renal cancer than others, but you can see that 2021, 2019, where we had the most important number of renal cancer patients. So we did have like equal distribution on men and women. So 51 female and 49 for men. For the revealing symptoms, and this is important, I will tell you why, because we have in most of cases low back pain and hematuria and even palpable lumbar mass. So which means that in some way those cancers were discovered at an advanced stage. Okay, but also for sure I have to mention that there is a bias because we are a medical oncology department. So for sure we will see more advanced stages of the disease, not like the urologists, the surgeons who will for sure diagnose more small tumors and more localized disease. When we look at the stage, you can see here clearly in our department, but once again, we are a medical oncology department, we can see that 61% of the cases of kidney cancer are at an advanced stage versus 38% that are local. When we have a look on the site of metastasis, so we can see that is first of all bone, followed by liver mets, but also lung and brain mets, then followed by lymph nodes. Well, for histology, as we can expect, is the clear cell carcinoma that is the most frequent in this study, showing 80% that have clear cell histology, but we did have also 14% of papillary and 6% of chromophobe carcinoma. Well, for the pathological profile, when we see the Fuhrman grade, so nothing very particular to mention about that. It's very balanced between the four grades. When we see the IMDC risk stratification, we do have like 40% that are at intermediate risk, 33.7% that are at poor risk, and only 26% that are with good prognosis. Well, for the therapeutic profile, and here is much to say about the therapeutic profile. We know all that we have surgery for some cases, even if they are advanced, but for sure the surgery is the backbone of treatment for local disease. But even now in the localized disease, so we can need adjuvant immunotherapy. We may need radiotherapy for very few cases. For some cases, if very small tumors, for as local therapy, or at the palliative stage, like for compression or for example pain, etc. And for sure the targeted therapies with the anti-angiogenics that have revolutionized many decades ago the treatment of kidney cancer. So for the localized disease, you can see here that, for the few patients that we had in our department at localized disease, there was no patient who received adjuvant systemic therapy. I remind you that the study was between 2014 and 2024. Well, we had the pembrolizumab as standard in adjuvant already now, I can say, for at least 3 or 4 years, but it's still not yet reimbursed in Morocco for all patients. I open the bracket here also that in Morocco we have the general health insurance that covers all Moroccans, so that is basic, but it can afford you all the basic treatment, but not all the time, like the innovative treatment like immunotherapy. It's not for all, or some, like for example Belzutifan, the anti-HIEF, it's not yet reimbursed for all comers here in Morocco. So just to let you know that in terms of accessibility, of availability of treatment, it's very challenging for us. We have moved very fast, very quickly in breast cancer with the anti-HER2 therapies, with the PARP inhibitors, with the anti-CDK4/6, etc., that are available, reimbursed for patients. But in kidney cancer, we are still struggling with this access to treatment, specifically to immunotherapy combinations, IO or IO-TKI, for example. So that's why even for our localized patients, at localized stage patients, so they did not receive pembrolizumab in adjuvant, problem of access. And for advanced disease, well, we did have some patient who received cytoreductive nephrectomy, when it was indicated for any local problems. Also, we know that it's not a standard to do in all patients with metastatic disease, and all patients received systemic treatment. So what is the systemic treatment? Now in 2025, it's really something routine to talk about the IO combination, so IO or IO-TKI, but the reality is not like this. So, well, I remind you again that the study also include patients, so before 2017, 2018, where we had this big revolution in the treatment of kidney cancer. But you can see here that as first line treatment, so we had majority of patients who received pazopanib and sunitinib, and only 3% of patients who were able to receive pembrolizumab and axitinib. I have to tell you something, that in Morocco, as immunotherapeutic agents that are available here, we have pembrolizumab, atezolizumab, but atezolizumab is not really a standard in kidney cancer. We do not have nivolumab and ipilimumab. So already you can see why no patients received nivo-epi, because we do not have those drugs yet in Morocco. We do have other therapeutic agents, immunotherapeutic agents for other locations, not kidney, like durvalumab, for example. So we have atezolizumab, pembrolizumab, and durvalumab. Those are the immunotherapeutic agents that are available in Morocco. So for kidney cancer, that's why when you will have a patient treated with IO, it will be pembro plus lenva or axitinib. Well, for second line, so you can see that most of patients so switch from a TKI to another TKI. So if pazopanib, so they switch to sunitinib, or vice versa, or they go to everolimus or sorafenib. As I told you, nivolumab is not available. So we do have now cabozantinib that is available in Morocco, but not fully reimbursed for all comers. Well, the median PFS here was 9 months, and when we see the impacting factors on PFS, well, we find mainly the stratification of risk, and the histological subtype, and the fact that the patient underwent nephrectomy or not. That's what we found in this study. The median overall survival was 26 months, and I remind you again that is really a TKI era, so we cannot say that we have very good results because of lack of IO treatment in most of patients. So, I can say as key takeaway messages that there is a huge need of global collaborations, specifically in terms of access to clinical trials and access to innovative treatment. This is an effort to do for sure by our healthcare system, our local authorities, but also it's a call for pharma companies, so to include African countries, because also we need to be represented in those trials. When I see a treatment that is efficient, that works in a trial in Caucasian or American or Asian population, I'm wondering for myself if is it working or not, because I'm not represented in those populations. So there is a huge need to have correct access to clinical trials and to innovative treatment. We need more democracy for the access to treatment. And unfortunately, still now I can say that TKI are very widely used here in Morocco in first line, in second line. We do also have, the anti-mTOR inhibitors, but there is a huge need to have this access to immunotherapy for all patients. So with this, I finish my talk. I didn't want to give you just negative messages, but this is reality, because there is a big gap between what is happening in oncology with all those nice results that we see and we present. Even me, I present this every congress, etc. But it's frustrating not to be able to make these options available for our patients, and frustrating also for the patient to know that they are undertreated by certain treatments. So with this, I would like to finish the call, calling you all to have a global collaboration in terms of clinical trials, in terms of research, including many parts of the world. So this is the only way to improve things and improve at the end the outcome of our patient. Thank you.
Thank you so much. So now, sorry. Thank you all for joining the second day of VIRO 2025, chaired by Rana McKay and co-chaired by Yüksel Ürün. The Congress brought together 15 leading renal oncology experts from around the world. Today alone, over 7,000 people joined us. On behalf of OncoDaily, thank you for being part of VIRO 2025. This marks the end of the Congress. We look forward to continuing this journey together. See you soon.